everyone. My name is Dr. Deborah Lee. I am a minimally invasive reproductive surgery and infertility specialist here in Temple, Texas at Baylor Scott & White Medical Center. I had the distinct privilege and honor to train with Dr. Cameron Najat in 2021 to 2022 in California. Some background about myself. So I am from Texas. I grew up in Dallas, Fort Worth. I played Division I soccer in Georgia at Mercer University. And when the time came to go to medical school, I came back to Texas. I went to the University of Texas Health Science Center at San Antonio for medical school. For residency, I ended up training at UT Dell Medical School in Austin, Texas, where I completed my OBGYN residency. After residency, I knew that I loved reproductive surgery from my time on my REI rotation. And upon learning about Dr. Najat's program and his surgical fellowship, I applied and was so grateful to be accepted. There, I learned an immense amount about caring for women with many different medical conditions. One of the most important was endometriosis. From my training with Dr. Najat, I learned to be compassionate about the needs of women who have endometriosis. I learned to be knowledgeable about the pathophysiology and treatment of endometriosis, and I learned how to be a scholar and understanding the research about endometriosis, and then an advocate and understanding about how to advocate for women with endometriosis. And then finally, but not least, how to be a surgeon and how to do surgery to help women who have endometriosis, specifically women with endometriosis and infertility. I count it as an honor to have had the opportunity to do almost 350 cases with Dr. Najat, learning and really mastering the skills and concepts that Dr. Najat developed to care for women who have endometriosis and infertility.
Hello again. There are some questions from Lisa on Instagram, Priya on TikTok, and Aidan on Instagram that essentially the question deals with the mechanism of how endometriosis could cause infertility and could cause organ dysfunction or a loss of the function of an organ. The way that endometriosis causes infertility, it could be many ways. In general, when endometriosis could be as common as causing anatomical, when there is severe endometriosis, the fallopian tubes and the ovaries might prevent the reaching of the egg and the sperm together. That could be one sample. But often endometriosis could cause inflammation all throughout of the pelvis and abdomen, and that inflammation could cause a problem for the sperm, embryo, the egg, the implantation. In all areas could cause, sometimes there are toxic, the endometriosis. The hormones produced by endometriosis toxic to the egg, embryo, and sperm, and again causing implantation, causing miscarriage sometimes, early miscarriages. And these are some of the factors contributing to patient not getting pregnant. For the organ dysfunction, endometriosis is an inflammatory progressive disease and causes fibrosis. Let's say if endometriosis involves the wall of the bladder or the ureter or the rectum, it being on the ureter, and ureter brings the urine from the kidney to the bladder, gradually that ureter becomes narrower and narrower and narrower because of the inflammation. and sometimes patient has only some mild gradual pain on her flank, on her back, on the right or left side with her menstruation and ovulation, and gradually gets worse. And that, as it goes on, closes the diameter of the ureter, and the ureter gradually dies. And when the ureter gets obstructed, the kidney dies. For the bladder, the same. Endometriosis could keep coming inside and could cause a lot of pain, bleeding, and in some cases go ahead and obstruct the ureters. For bowel, it is much slower because the diameter of the bowel is much bigger, and but it could cause pain with bowel movement. Rarely, not all the time, causes rectal bleeding. A lot of time could cause bloating, and very often could cause severe pain with at the time of the bowel movement. Around the time of menstruation could cause diarrhea or constipation, back pain, leg pain. These are some other organ dysfunction in this way. But endometriosis involves the diaphragm, for example, in the right side, and gradually progresses. It could cause pain on the shoulder because of the nerves in the diaphragm. Also, could cause problems like hemoptysis, bleeding from the chest wall, and also collapse of the lung. These are some of the factors that endometriosis could continue. If there is endometriosis involves sometime on the belly button, every cycle patient has, she might bleed from her belly button, sometimes from the nose. That is, it depends where endometriosis is, because endometriosis is a whole body disease. I hope I addressed some of those questions and you as well. And thank you for watching. Hello, and warm wishes to all of our viewers around the world. Welcome to the 14th episode of our webinars of Endo Explained. At the outset, I would like to thank all of our viewers everywhere, and all the chapters of EndoMarch internationally, all of the patients with endometriosis, their families, their friends, all the country captains, country presidents, ambassadors, and volunteers for all of your efforts to raise awareness about endometriosis. We especially like to thank and dedicate this chapter, this episode of the Endo Explained to our sister chapter of France, of EndoMarch, and all the members of the EndoMarch France, the president, the volunteers, the captain, the ambassadors there, and especially to Dr. Chrysola Zacharopoulou for her efforts, who is now a member of the Parliament of the European Union and has been very able and instrumental to bring this issue to the attention of all the way to the government of France, even to the top level of President of France, President Emmanuel Macron, that to declare that endometriosis is indeed a social issue, something that we have been saying for years. Why is it a social issue? because of two reasons. One of them is significant amount of problems and pains and organ dysfunction that it is bringing to millions of people around the world. And another problem is infertility, because infertility in some countries could be a social problem with the low birth rate, negative birth rate in many developed countries. For example, 1 out of 10 to 7 couples who try to have a child, they have problem getting pregnant or have problem with miscarriage. That could be a social problem. And in our opinion, over the years, we have noticed that if a couple, all of their tests are normal, the wife is normal, the husband is normal, they don't have any pain, they don't have any issues, and still they don't get pregnant. In our experience, we have noticed more than 90% of these couples have endometriosis, and that these group of patients, they could be helped significantly by proper intervention. And in the next several episodes, we want to address this issue. And we are lucky today to have a very brilliant infertility specialist, Dr. Amy Abazadeh, that she is being known and loved by the name of Dr. Amy by her patients, that she is one of the front runners of acknowledging and discovering that many of these patients who do not get pregnant and have no symptoms at all, they have endometriosis. And when the endometriosis is properly addressed, the success rate of these women getting pregnant is very high. To her credit, Dr. Amy, as you know, she is very well known by many of you, by her multiple advocacies for the infertility patients, and has been trying to educate the whole public for infertility by many of her programs. And it is very easily, you can see it on YouTube, on Instagram, on different television programs. And the most prominent one is Egg Whisperer, that would educate the couple about endometriosis. So we were lucky to have her, and we are going to give her the stage that she advocate and talk and speak about her experience in this regard. We have had the good luck of working with her and several of her other RFPI colleagues that they are interested in this issue. Also today, our colleagues and fellows, Dr. Shurudi Agrawal, that has been for the past 2 years doing a fellowship in endometriosis with us. Very brilliant, you have seen her before, and also Dr. Lee, who is doing a fellowship this year, and then she is going to join the program in Texas, heading the minimal invasive and surgery program in Texas next year, and she would tell you more about it herself. And Dr. Tavallai, who is not only a gynecological surgeon training to become endometriosis specialist, she has had also, beside gynecology, residency in endometriosis at Stanford. So they are all joining us. So we welcome you again. Thank you for joining the webinar. For the previous episode, you can easily go to the webinars on the top and find the webinars, and you can watch any previous episode you want. Thank you again, Dr. Amy. It is a pleasure to have you. Please, you have the podium. We would appreciate it if you proceed and explain your involvement and how you decided to help the patient with endometriosis and the issue of the your experience and how do you address that? Thank you.
Of course, I think when it comes to having patients in my practice suffering from infertility, they come to me because they want a reason and they want a diagnosis. They want an explanation as to why is what happening to them. And unfortunately, as women, our symptoms are often ignored, and it can take years before someone gets properly diagnosed with endometriosis. And we know far too often in our experiences together how endometriosis can affect implantation. Endometriosis can block fallopian tubes. It can decrease egg quality, causing a less number of mature eggs, for example, and a higher rate of having embryos that are not genetically normal. So when you've already gone through so much to have a baby, and in some cases it can be even multiple IVF cycles, it's imperative for me when I'm planning something for a patient to make sure that I have ruled everything out, and that includes endometriosis. So that's why there are some tests that I do. For example, the Receptiva DX test, if I suspect that someone might have silent endometriosis, or I send them to you to see what you think as far as whether the patient clinically might have some physical exam signs of endometriosis that I can't pick up because, you know, I have certain tools in my toolbox, and I feel like you obviously can pick up on some things that I can't necessarily pick up on all the time. And I'm always just so grateful for the work that you and your team does to make my patients parents. So we've had great fortune and so many success stories where patients, for example, have had IVF cycles that don't work. Then you do surgery on them, and then they come back to me and they get pregnant through either IVF or even naturally. And sometimes, you know, when you tell a patient, Amy, she can get pregnant now. And in the beginning, I was a little bit doubtful. I'm like, there's no way that this patient with this endometriosis can get pregnant. And then after surgery, sure enough, we have so many countless stories of patients who are then able to conceive on their own. Not everybody, but there are definitely some pretty amazing stories out there. And so patients sometimes will do IVF with me, have embryos stored, do surgery with you, get pregnant naturally, and then we've saved their embryos for their future. So that's pretty exciting for me. So if there's anyone out there that feels in their gut that they might have endometriosis, or you just don't know what's going on, I think it doesn't hurt to meet with someone to ask them, have you ruled out endometriosis for me? Especially if you have pain or if you're having implantation issues or problems with embryo quality, I think it's worth it to explore endometriosis as a possible factor.
Thank you very much, Dr. Amy. Dr. Amy, why do you think it is that in general, as you said it yourself, there is so you cannot deny the success of these couples who get pregnant after many failed IVFs in some of the best centers, and you treat them and they get pregnant. And why do you think, number one, the mechanism, what it is, and number two question is, why do you think this is not more known among many infertility specialists?
Yeah, I'm hoping through more awareness, like the seminars you're doing, and more patients that are speaking out about their success stories, that hopefully more fertility doctors will agree. And I think it's hard because I've personally heard other fertility doctors say, oh, endometriosis won't cause this or that. And we know that it can. So I think that, you know, with more experts like you also, you know, talking about how it can affect fertility, I think people will start to offer patients a workup for endometriosis more and more. And I'm seeing it across the board, either surgery or medical treatments like Orlissa or Depo-Lupron or Letrozole. And the mechanism is, I think a lot of it is just inflammatory. It's inflammation that endometriosis can cause that can decrease implantation rates, increase miscarriage rates. And the hardest part for me is getting healthy eggs when someone has endometriosis. And so I'm not surprised, but I'm pleasantly pleased, I should say, when a patient has endometriosis surgery, especially if it's more severe, then they come back and they make beautiful embryos for me. So I think a lot of it has to do with inflammation, and that's how it can affect egg quality and make things not work the way I would want them to work the first time for them.
Thank you very much. There have been, as you know, many couples with, everybody thinks endometriosis patients that have pain, but there are many patients with endometriosis that they have no pain at all. Many couples, many of your patients, the husband is fine, all the tests are okay on the female side, the HSG, everything is normal, and they are completely asymptomatic. In our experience, more than 90% of these patients, when we see them, they have endometriosis. And it would be very typical for you, I take it, that when you have a couple like that and you see they have had failed IVF, everything is okay, and tell them, hey, you might have endometriosis. How do you talk to those patients?
Yeah, I mean, I feel like the way I talk to them is I talk to them about how common endometriosis is for so many reasons in terms of the things that we're exposed to in the environment. And then also when you've taken so many hormones through so many cycles, I feel like IVF medications can also sometimes stimulate endometriosis. So those are the kinds of things that I bring up. And then I also tell them, just because you have endometriosis does not mean you cannot get pregnant and have a healthy pregnancy. It just means that you should be more thoughtful about the approach you take. And it's kind of a catch-22. And I'm sure everyone who's listening right now understands what I'm talking about. Sometimes people say, oh, you have endometriosis, so go ahead and get pregnant. But when you have endometriosis, it's harder to get pregnant because pregnancy can be a treatment for endometriosis. So I find sometimes it's mean to tell someone who has endometriosis, go get pregnant and that's going to fix it. They just aren't ready yet to get pregnant, or they're ready for sure, but sometimes it's just a little bit harder. So I explain it in those terms, and I feel like people can understand that it's not their fault. It's something that could be environmental and genetic, and it could be stimulated by IVF medications. And that's why it would be important to rule it out before, let's say, you transfer your very last embryo, or you rule it out before you go through all your embryos and then have to do another IVF cycle to have a pregnancy.
Thank you, Dr. Amy, you are so precise. Dr. Amy, one thing that I would really appreciate it if you explain, you have been so outspoken and advocate to raising awareness about infertility couples. Would you please talk about Egg Whisperer and your previous programs that you have done, and many of them are very, very watched by thousands and thousands everywhere. Could you please, if you don't mind, explain some of that for our viewers?
Absolutely. So I have
Could they get involved?
Of course. So I have a podcast, and you have been a very big part of that podcast. You were a guest not that long ago. And then I also have a YouTube show. And then I have a Q&A series that people can send questions into. It's asktheeggwhisperer.com. And my favorite is actually my classes. So I teach IVF classes. I call them master classes. And it's at the Egg Whisperer School. You would think that I could be more creative with the names here, but eggwhispererschool.com. You can go there. You can learn about fertility. I have a Tushy class. Tushy method is one of the methods that I teach people. All the tests that you have to do before you get pregnant. I don't know if you can see it back there. I think it says Tushy method back there, but it just raises awareness about getting your tubes checked, getting an ultrasound to rule out endometriosis if it's present on ultrasound, getting your sperm checked, your hormones, and then lastly, your genetics. So those are the kinds of things that I do to teach people, build awareness. I make catchy phrases so that people can hopefully sometimes or always laugh and smile as they think about something that sometimes brings a lot of sadness and depression.
Thank you, Dr. Amy. Dr. Agrawal, if you know, she did some work with the Receptiva test, many of them your patients, and also she has a comparison with an app that we have developed. It is called Najat Endometriosis Advisor that diagnoses endometriosis with more than 90% accuracy. It is completely free all around the world. And she did some of the work, and also still is continuously working on that area. And I think she has some questions from you. And I would ask Dr. Agarwal to go ahead and ask Dr. Amy.
Hi, Dr. Amy. Good morning. I think I wanted to ask, what do you think about BCL6? I know you are very well aware and you have it performed on your patients all the time. You test for BCL6, but we don't see it from other fertility doctors as much. So how would you educate patients on whether they should ask their doctors to test for this to see if they have endometriosis?
Yeah, I mean, I'm actually seeing an uptick in fertility doctors doing it across the country now. So we're going to see more and more patients getting this test done as people are, waiting longer to have babies. Their embryos are so precious. I think doctors are now willing to, or they agree that maybe doing this test makes sense, especially when they're doing other tests at the same time. They can easily do that. The BCL6 test for me, if someone has obvious endometriosis, I mean, I don't know how helpful it is for someone who has endometriomas. But in someone who is having implantation issues or preparing for a transfer, I think it can be a helpful test to do, even if you haven't, quote unquote, failed one transfer. I don't want people to fail even one transfer. And I know people say, oh, she's never failed a transfer. Why would you do this test? And my personality is, I'm not going to discuss this test with somebody after a transfer doesn't work. I want them to know the menu of tests that they can choose from at the very beginning, and then they can choose for themselves if they feel like that test resonates with them and they want to do it. And at the same time, it is not a perfect test. I mean, Dr. Najat and I have had patients where we think they have endometriosis. The BCL6 test, for example, is negative, and then he does surgery and sure enough, they have endometriosis. So I always tell patients, if the test is negative and you think you have endometriosis, the test could also be wrong. And I know there are other tests coming out that might be better than the BCL6 test, but that's kind of how I use it to guide treatment. It helps me change protocols. It helps me direct patients to Dr. Najat. It makes me look at the fallopian tubes more closely before a transfer. So it teaches me a lot about a patient before a transfer. But again, if a patient doesn't have access to that test because their doctor won't do it, there certainly are other doctors who could do it for you, like your OBGYN even could do it for you if your fertility doctor doesn't think that it's a tool that they want to apply in your case.
Right. I think I totally agree with you when you said that when it's negative, it doesn't really mean much because you could still have endometriosis. We see that with our own research. We looked at these patients who came to us that were positive for BCL6, and we wanted to see if you were positive for BCL6, would you be positive for endometriosis? So the correlation between a positive test showing definite endometriosis is very, very high, but that doesn't mean that a negative test won't show you endometriosis as well. Because we looked at about 40 patients and it was 96%, all 40 of them ended up having endometriosis on pathology. Afterwards, during the time of the study, we saw it was 96% positivity. But as we followed these patients further on, it was all 40 of them. And then they all ended up getting pregnant, either naturally or by IVF. So it was a very good predictive factor. And also mixed with the Najat app, with the Endo app that we have, when you score over 90% and you have BCL6, your probability of having endometriosis is, I mean, it is very, very high, like higher than 95%. So I definitely agree with you that when it's positive, it's a great thing, but when it's negative, it doesn't really mean that you don't have endometriosis.
Thank you very much, Dr. Amy. That is very important. Here I take the prerogative of confirming exactly what Dr. Amy is mentioning. There are, we explain for the patient the benefits and the risks of each option. And then if you have one hammer, everything is a nail. But you have to know the pros and cons of each option. The surgery should be done by somebody who is really, really an expert. and to diagnose all the endometriosis properly and do not cause any harm. And if it is done properly, the results are, in our opinion, are much, much better and faster and immediate and longer lasting than hormonal treatment. Because when you remove the endometriosis, you essentially decrease the inflammation. Endometriosis is a progressive disease. And as Dr. Amy very aptly said, many of the infertility treatments, because of the they produce significant amount of estrogen, and estrogen feeds the endometriosis and makes the endometriosis worse and worse and makes it even more advanced. So the fertility medication that the patient receives may increase, not always, but very often, endometriosis is estrogen dependent and endometriosis gets worse. So if we go and treat it surgically, we remove the whole endometriosis. By removing the whole endometriosis, they stop the progression of the disease. And we not only benefit the patient from the long-lasting benefit of endometriosis, the inflammation goes down, and she could go and start trying to get pregnant immediately with a shorter period, rather than giving her own hormonal management that you have to give them at least 3 months. And by giving the patient that hormone, you don't eliminate the disease, you decrease it. And not on everybody, not all the patients that they go on hormonal treatment respond. Some of them that are not receptive, actually a good portion of them, they don't respond at all. And many of those 40 patients that they did get pregnant, and Dr. Agrawal was referring, and that was published, and she is working on some other papers in that regard, they had already received hormonal treatment as well. So hormonal treatment, it has its limitation. It doesn't always work on everybody. You have to give it to them longer. And at the same time, the hormonal treatment, probably it is a good idea to use it when there is nobody who is there to do the surgery. It might be a good idea, or if there is nobody who do proper surgery, or if the patient has contraindication for surgery. But in general, in our opinion, surgery is the best choice if the patient is a good candidate and a good surgeon is available to be thoroughly treating the endometriosis, because another benefit is that patients with endometriosis, they have 2 to 3 times higher chance of malignancy. And by removing the endometriosis, hopefully you decrease that patient, her chances of having future cancer. That is another benefit. There's a caveat here there that the patient should be aware that not necessarily removing or excising the whole endometriosis is always the option. For example, when it comes to the ovaries of a young woman who wants to get pregnant, those ovaries have to be treated very differently than other areas. And that is, we have heard often infertility specialists that are like Dr. Amy are very aware of that. But you have to be cautious. It depends how you are dealing with endometriomas. So Dr. Tavallaei, Dr. Amy is one of our fellows. She did also some training in pathology, and she wanted to ask you a question also.
Hi, Dr. Amy. Great
Hi.
to see you. Thank you for joining us.
Of course.
So I have one question that a lot of our patients ask when they come see us, and that's about like the time of freezing eggs and doing the surgery. So there are studies that show that the quality of eggs actually get better after we do the surgery. So that's one thing that we tell our patients. But at the same time, there are some of our patients who don't want to lose time, or they are like older and they say, oh, do I have to get my eggs freeze and embryos freeze before the surgery or after? I just wanted to know your opinion about how to counsel these patients.
I mean, I think it also depends on, like you said, their age, their hormone levels, how much ovarian tissue is actually there, and their willingness to do multiple IVF cycles or egg freezing cycles. So I sometimes ask people to consider doing both. So do a cycle of IVF or egg freezing first, and then about 6 weeks later, whenever Dr. Najat thinks is the best time, then do another IVF cycle after surgery. So I've done it both ways for patients, and in some patients, you know, for example, where they have such a large endometrioma that I think it might be very dangerous, for example, for them to go through treatment. Let's say they've had severe pain before, you know, just from the cyst rupturing, or not necessarily rupturing, but maybe leaking or getting rushed to the emergency room. Like, I don't want any of those emergencies to happen during an IVF cycle. Then I'll definitely recommend that they do surgery first. But it's a real fear because of things that patients have heard about other people who've done surgery. Then they have a much lower egg count afterwards. And so they're fearful also of losing their ovary. But just like Dr. Najat said earlier, it is so important that you're going to a fertility-minded endometriosis surgeon. So I've had patients who've gone to somebody and they leave the operating room with no ovary because the doctor didn't do anything to save that ovary. They just removed the entire ovary rather than just removing the endometrioma. So I always reassure my patients that I actually don't think I've had one patient leave Dr. Najat's operating room with an organ removed. In all these years, the surgeries that Dr. Najat and his team does for my patients is always fertility sparing because he knows how important having babies is for them. But not every surgeon has that approach. And I think that, you know, going through all the worst case scenarios in our heads is normal, but I think it's important to verbalize that with your surgeon. And then the other thing is to go through all the worst case scenarios about your fallopian tubes as well. No one wants to wake up not realizing that a fallopian tube could be removed. And that's a very careful, thoughtful discussion that I know you guys have with all my patients as well. And I do also just let them know that, you know, endometriosis can affect your fallopian tubes and it might be helpful to have one removed. You can still get pregnant from the other side. But when it comes to transferring an embryo, having abnormal tubes can really get in the way.
Thank you very much, Dr. Amy. One issue that I like to also ask you, why do you think the couples, do you think the rate of infertility is increasing, and why do you think it is?
I mean, I know it's a controversial topic, but stress, I think, and right now we're living in unprecedented times with people undergoing, they're very, very stressed. And I think stress and then the environment and all the garbage that we're exposed to from the minute we're in utero, all the plastics, I feel like that has a lot to do with potentially why we're seeing more endometriosis. And then society, obviously, the trend is for us to wait longer to have babies. And the longer you wait, the higher the chance that you'll have a problem like endometriosis as well, especially if you had it as a younger person. Then waiting longer to have babies, you're obviously going to have worsening endometriosis. And so many people say, like, why didn't I know this when I was younger? So I think a lot of that plays a role into why I think I'm seeing more fertility patients now more than ever with some, I think with more endometriosis than I saw maybe, 15 years ago. So I do think that the environment has a lot to do with it. Stress has a lot to do with it. And then also age-related infertility is a big part of it as well.
Thank you very much. And Dr. Amy, do you think there should be a program or perhaps a national program that all the female patients who want to have children be given an option to freeze their eggs in the optimal time of getting pregnant, as you said it yourself, and we see it very often now, couples in their 40s and sometimes very early 50s, they want to have children of their own. How do you feel about that, and how do you think that should be addressed?
Yeah, I mean, I feel like we're going to see a huge trend toward a population decline in the United States. And I think the government, I predict, is going to play an active role in changing that and increasing the birth rate by incentivizing young people to freeze their eggs. I don't think it's going to be happening in the next 5 years or so, but I predict in probably 15 years, just like other countries are doing now, they're incentivizing young people to freeze eggs, and they're actually paying for it. So I would not be surprised if that starts happening here in the US, that people will actually get their egg freezing done for free, just so that as a society, we can continue to grow and support, everything that we need to support. Otherwise, Elon Musk will be taking us on SpaceX, or, Elon and Bezos to Mars soon, just because of what we're doing to this. Anyways, but you know what I mean. But I do feel that it's one of my egg whisperer golden rules that every woman by the age of 25 should have a fertility level check and get, some fertility tests done. And she should consider freezing her eggs if she is considering having children younger, even 21, if she has a history of endometriosis, having an ovary removed, or her mother went into early menopause, because there sometimes are some even 25-year-olds that wish someone had told them about these things sooner. And then I think by the age of 32, if a woman wants at least one baby and hasn't had one yet, whether you're married or not, should consider freezing her eggs. So I do think that egg freezing is a powerful tool. It's a great technology. It works. I do it a lot. I freeze a lot of patients' eggs, and they come back to me, and we use those eggs, and they have healthy babies. It's not perfect. It's not an insurance policy, but it's a future chance at a pregnancy with better chances than you had at the age that you're at. So I always tell people, you want to be your own egg donor. So when you're 40 and 50, I mean, I'm not almost 50, I'm almost 46. And I feel like if I wanted a baby right now, I could have one, but I would have to use eggs that I froze when I was 32 years old. Unfortunately, I didn't freeze my eggs. Not that I want to have more babies right now, but I froze my sister's eggs when she was 32. So maybe I'll be calling her up if I want another baby.
Well, you are a good pioneer in this area, and you have done a very good job. And thank you for that comment. So, Dr. Amy has a wonderful family. I let her talk about it if she wants, but I don't want to spill all the beans for you. So, and it has been a pleasure to know you and your family. So, what role, I have another question, and I think perhaps one of my colleagues wants to ask you. It was about anti-Mullerian hormone. Was it Shruti, who was it? Any of you want to ask Dr. Amy the question yourself, or do you want me to proceed?
No problem, sir. I mean, with anti-Mullerian hormone, we want to know, Dr. Amy, what are your thoughts? Because sometimes patients just randomly have an anti-Mullerian hormone test done. They get a low number and they start freaking out about it, thinking that they're never going to get pregnant again. And these are younger patients and patients who are about to undergo an infertility workup. What would you say to patients who just have not had a single infertility workup and just have a low AMH in their hands and now don't know what to do?
Yeah, I mean, it also depends on your age, but I tell patients one snapshot in time doesn't define you. It doesn't define your fertility. And, the AMH can go both ways. You can have a high number, and actually it could be a lab variation and wrong, and then you repeat it, and then it could be closer to what your true number is. So I tell patients to never just rely on one AMH level to guide your, fertility treatment. And then never do it in isolation. You want to get an ultrasound and have something called an antral follicle check done. So that's a measurement of the tiny little cysts called follicles in your ovaries. They kind of look like boba pearls in a boba tea, or chocolate chip cookies, chocolate chips in a chocolate chip cookie. You know, we just count those little circles. Or someone said to me the other day, they're like, they look like little caves. I'm like, yeah, little caves with a tiny sparkling microscopic egg inside. So we take all that information, and then I tell patients, I'm not your fertility doctor for just today. I'm your doctor for 2 years from now, 5 years from now. I have a patient who just saw me yesterday. I'm now helping her with another baby, and I met her 12 years ago. So I froze embryos for her back then. So when I take the AMH, I use it to project someone's fertility for them. And I say, okay, well, this is what it means right now, but I can also tell you what it means to me based on everything I know about you 2 years from now. So I always talk to patients about how many kids they want. And then I kind of think through, well, how old are you going to be when you have your last baby? And what will your AMH potentially be then? And, you know, how many IVF cycles should you do to give yourself the best chance of reaching your goals? Because we know that we have a finite supply of eggs, and we have not figured out a way to help women regrow them. So AMH, I mean, one day we hopefully will, but for now we still have to freeze eggs, you know, do lots of IVF cycles for people to make sure that they have enough embryos for themselves. And until then, the AMH, unfortunately, is the closest thing to a sperm count that we have for a woman. And it's certainly not perfect. But that's what I would say. I would say, you know, don't let that AMH define you. You're not your AMH level, and your AMH can be misleading because sometimes you can get a level that's not accurate or true for what's going on with your fertility.
Dr.
Thank
Amy,
you very much, Dr. Amy.
That's very well put.
Okay, go ahead, please. Go ahead, please, Dr. Lee. I just before Dr. Lee, please don't forget your question. And if I want to give a comment about exactly what Dr. Amy said, AMH, anti-malarial hormone. Personally, again, I agree with Dr. Amy. I don't put much weight on it at all. We have had numerous patients with a very low AMH, very low AMH. Actually, too many to count our patients that after surgery, they have gotten pregnant. I vividly remember one patient who was a physician, and she was in her, I think, mid-40s. I don't want to give too much, but she had bilateral endometriomas, and it had been recommended that both ovaries had to be removed because they were pretty large, and she still had hope to get pregnant. And she came, and we did the ultrasound, we evaluated it. Indeed, the amount of ovary left was very little of the stroma. And prior to the surgery, AMH was very low, as Dr. Amy said. I said, well, let's give it a try. We removed both endometriomas. We saved very little tissue which was left of endometrium of the ovary that we saved no matter what. We erred on the side of even leaving some endometriosis behind, but we saved both ovaries. That patient, after the surgery, she didn't get her period. And everybody thought she was in menopause. She came back, actually she was pregnant. That is a very pleased that she was a physician. So that is a very good story. So what I'm saying, that is an extreme, that she actually didn't even get her period, but she started ovulating and she got pregnant. She thought she went to menopause. And again, we have had other patients. I'm repeating myself for the purpose of better understanding of everybody and confirming what Dr. Amy said, that do not let that defy the low AMH bother you. And if it is the process done properly, many patients get pregnant. Go ahead, Dr. Lee.
That's an amazing story. I'm so, it's always so exciting when our patients let us know they're pregnant. Dr. Amy, we, on the topic of AMH, I was wondering kind of what you see in your practice in terms of the AMH of patients with endometriosis, and if you notice that their AMH can be, different with your endometriosis patients versus your non-endometriosis patients?
I mean, I haven't noticed anything necessarily different. If an AMH is, let's say 1.0, I would expect a certain number of follicles, maybe 8 to 10. And I wouldn't say that if they have endometriosis, I personally haven't seen any difference in terms of how many follicles I could get. So I personally haven't seen a difference. Obviously, if they're taking a medication like Lupron or something like that, certainly it drops the AMH level significantly. So I always tell people, don't check your AMH when you're taking a medication like that. It's not going to be helpful, but afterwards you'll see it go back up.
Thank you very much, Dr. Amy. Dr. Amy, incidentally, we had we had 3 very wonderful couples of patients of yours that over the years we had treated, and they achieved pregnancy because of your effort, and after the surgery with collaboration together, and they were part of the program. Unfortunately, at the last moment, each of them had an issue that they couldn't be on the program today. But we had several of our patients. So, and there are some questions from the viewers also that perhaps Zoe yourself, or you can ask Dr. One of the fellows, please ask Dr. Amy those questions.
I actually have one from the chat that I think could be really helpful to a lot of people. Someone asked, basically, when you're going to see your doctor, you have infertility and you're concerned you may have endometriosis, what should you be watching for? What should you ask your doctor? What type of evaluation, what exams or studies should be done if you have infertility and you're concerned that you have endometriosis?
Yeah, I mean, I would just ask the doctor, first of all, what have you ruled out? What tests have you done? What do they mean in my, what do you know about me? What do they mean for me in my situation? And then you can simply say, based on everything that you know, do you see any signs that I could have endometriosis? And sometimes on ultrasound, we can see things like little cysts called endometriomas that we have talked about today. Sometimes I get a sense that the uterus might be, the term we use is boggy or slightly enlarged, and that could be a sign that a patient has adenomyosis. And we know that that is related to endometriosis. We also look at the positioning of the ovaries. So if I see that the ovaries are kissing or touching each other behind the uterus, for me, I say, you know what, it looks like there could be some scarring here. The ovaries seem to not necessarily be, kind of flopping out to the sides. They're kind of right behind your head, and the head meaning the uterus. I do a lot of pantomimes here in my office, but those are signs that someone might have endometriosis. So that's kind of what you can ask your doctor is, do you notice anything about the position, the shape of my uterus, the way it's tilted, that maybe it's tilted that way because of endometriosis? When you look at my ovaries, do they look like they're free and mobile? Are they positioned in a way that makes you think I might have endometriosis? So you can simply ask those questions, and then obviously, go to your team if you still have a gut feeling and you don't feel heard. Because I have patients that are like, I literally asked the same thing and everyone said that I was normal. And then they come and see me and I'm like, yeah, that left ovary looks like it's stuck behind your uterus. Yeah, I can see you have this area. You can see the asymmetry in the walls of your uterus. It looks like you have adenomyosis. So if you don't have someone like me or your team who can advocate and help you, perhaps ask for a pelvic MRI. Sometimes if done, sometimes people can pick up things in the uterus, but also that's also not a perfect test also.
Thank you very much, Dr. Amy.
You're welcome.
There was more questions. Could you please ask the one in the chat? Was a couple of other questions.
There is actually one from the chat that one of our participants is asking, is it wise for someone who had undergone multiple surgeries because of endometriosis to try for kids via IVF, or chances are slim, especially if the AMH is poor?
Yeah, I mean, if someone has had multiple surgeries for endometriosis, you still have a chance for a baby. I mean, I've had patients referred to me from Dr. Najat who've had multiple surgeries, and there's one amazing success story that I can think of right now. And they got pregnant through IUI with me and had a lovely pregnancy. So I think that all options are still out there for you. You have to ask the doctor if there's any barrier to fertilization. I'll make a joke here. I know it's a little too early in the morning here for me to make jokes, but I say eggs are effed in the fallopian tube, not the kind of F word you're thinking about. The F word is fertilized. So as long as the endometriosis hasn't affected the shape and the way your fallopian tubes work, then when two people love each other, if you're in a heterosexual relationship, miracles can happen and you can make a baby. But if you're thinking that it might be better to do IVF after multiple surgeries, that is still also an option for you as well, as long as you have eggs and a doctor that's willing to work with you, even if you have a lower egg count. And you should ask your doctor that, because there are some doctors that they will say, oh, you need to have this number of eggs in order for me to help you. And you need to know what that number is at the center that you're at. For me, if you have one follicle, one egg, that means one chance, and I will give you that chance should you want it. But not everyone has that type of philosophy when it comes to treating their patients.
Thank you, Dr. Amy. Dr. Amy, there is one other question here that popped up, that if a couple are in their 20s and they would like to freeze eggs, but they are married or they are together, should they freeze eggs or should they freeze embryos? And if the female, definitely she has endometriosis and she has like endometriomas in both ovaries, what are your recommendations? Eggs or embryos or both?
Again, it just depends on what the relationship status is. If he for sure like your guy and you guys are going to have babies together, then I would do both. If you're like, I don't know if his sperm if his sperm is deserving of my eggs, then don't make any irreversible decisions that will tie up your eggs with a loser. I always tell people that no one gets married thinking that they're going to see their kids 50% of the time. And no one does. No one's like, oh, I can't wait to have a kid that I can hand off to some stranger to take care of. Right? Especially when you've gone through fertility treatment. And I've seen it, unfortunately, far too often. And I know Dr. Najat mentioned my kids. I have 2 girls and 2 boys. I've taught my girls. I said, do you need a husband to have a baby? And they go, no. I'm like, good girls. You just need a sperm donor. And I'm starting a sperm bank. It's called sparklingspermbank.com. It's a joke. I should do stand up. I know. You guys are like, how is she so funny? I don't know. I swear there's no tequila in my coffee. Maybe there is. But my point is, when it comes to making embryos with someone for your future, please think through all the worst case scenarios. Get legal paperwork signed ahead of time so that if, let's say, you guys split up, you are still going to be allowed to use those embryos. Otherwise, freeze both, because you don't want to be in a sticky situation.
Thank you very much, Dr. Amy. Dr. Amy, I didn't know you are a stand-up comedian also. That was great.
I am. I have
another talent you have.
We'll do another webinar later and it'll just be pure jokes, all fertility related, because this is pretty heavy stuff. And I try and make it super lighthearted. My patients, I hope, they're not crying because they're sad when they come here. They're crying because they're laughing so hard at some of the silly things that I say to liven up the mood.
That's wonderful. That's wonderful. No, I just great that we discovered this side of you. And Dr. Amy, one other question here that I have is, do you recommend that men also freeze their sperm, and at what age, and what is the role of age of the partner in having children, and what are your recommendations?
Yeah, so I have a jingle. It's always nice to have sperm on ice. So I have 2 sons, and I can guarantee you that their sperm will be frozen probably by the time they're 21, and I'll just put it away for them until like they may or may not use it. And the reason is, we have COVID, we have pandemic, it kills sperm for a lot of people for months at a time. So that's one reason to freeze sperm. People are delaying childbearing. If I see a guy at 50, if he had sperm frozen when he was 40, I want that sperm. I don't want 50-year-old sperm. We know that as guys age, right? You have a higher risk of having embryos that are chromosomally abnormal and a whole bunch of other diseases. And I don't want to scare you guys in talking about those things, but those are things that ideally people don't want to welcome into their family. And so I try and create as much as I can healthy families. And I want to teach people about what they can do ahead of time to give themselves the best chance. So if you have, let's say, endometriosis and you're thinking, well, I'm not ready to do IVF yet, but we're thinking about it, maybe in 3 years, maybe just get some sperm on ice now so that you can use that sperm in case something happens. You just don't know about what the future holds. And, right now with COVID, I've had cases where I've had to cancel them and it takes 3 months for the sperm to come back to life because of what high fevers can do to guys and their sperm. Sperm's very sensitive. Eggs, not so much. We can get COVID and our eggs are going to be fine, but men, not so much.
Thank you. That is insightful. What is the oldest couple that you have had? If you can just mention the name, how old has been the male partner, the oldest, and how old has been the patient? Not the same couple, but in general, your experience.
My oldest female partner, my oldest female patient, 52 years old. My oldest male patient in his late 70s. So, for me, I don't discriminate against anyone based on age. People are pretty reasonable when they come to me and they I always say, you're so smart. You must be so intelligent because you came to me as your doctor. And so they're pretty practical out there. And so they come to me because they know they're going to get the real deal. They're going to get hopefully what I'd like to think of as good advice. And most people listen to me. And so, when I say things like in their late 70s or, women in their early 50s, we're doing things that are safe and good, and we're building healthy families with lots of tests, lots of testing to make sure we're doing the right thing.
Thank you. So, Dr. Agrawal, Dr. Lee, and Tavalla, do you have any more questions from Dr. Amy?
So there is another question. I think we have touched on some of it, but someone actually asked kind of about failed IVF and an elevated receptiva BCL6 of 3.8, and they're undergoing suppression with agestin and letrozole prior to perhaps another retrieval, and also in the presence of a low AMH. I think my question would be, in counseling with that patient, where would talking about surgery be part of that counseling for you, Dr. Amy, and where would you have that conversation, and how would you kind of counsel your patient for options moving forward?
Yeah, I've learned a lot over the years about how important it is to make sure patients that you describe make more embryos, and make more embryos before you start the suppression process. Because if, let's say, you've gone through 2-3 months of suppression, I guarantee you that you're not going to have as good of an IVF cycle, especially if you're older with a low AMH, than you would have had 3 months prior. So before you even start that, I say make more embryos, because your BCL6 level is telling me that we might have implantation issues, even if we do all the things that we're talking about, like suppression and or surgery. And then I always tell my patients that my goal for you is to be a parent with your own DNA over you carrying the pregnancy. And so I want to do everything I can to make sure you have a baby with your own DNA. And I don't want to roll the embryos like people talk about rolling the dice and just see what happens. So then I want to be very thoughtful about the approach we take and include a conversation about doing surgery as well. So if, for example, you just have 1 embryo left and that's it, and we're going to talk about, should we do more cycles to get more? If we've already done the number of cycles that we need, then if there's just 1 embryo, I think it definitely makes sense to talk through surgery and suppression. And then I always say this because these are the conversations that people need to have before they transfer, before a negative pregnancy test. What would you do if this transfer didn't work? Okay, everyone remember that. All the audience out there, remember this. Talk to your fertility doctor and say, hi, doctor. If this transfer doesn't work, what else would you do for me? And if they say, well, we should consider surgery, and you say, but I only have the 1 embryo, why don't we consider it now? Because people get really angry when they learn that there could have been something else that they could have done to give themselves the best chance of pregnancy for their one embryo. And people make assumptions that the doctor the doctors make assumptions that maybe the patient wouldn't do surgery. She doesn't want to hear about all the other things. But my patients, they want to know every possible scenario. They want to know every single thing they can do to give themselves the best chance. So no matter what we do, I will always say to them, if this doesn't work, we made the right decision together, and we can never look back and say that we could have done something different because we were so thoughtful. And patients understand that. They say to me, Amy, no matter what happens, I know we did our very best, and I know we thought through everything up front before we made the decision to do this. So if it doesn't work, at least I know we tried.
Dr. Amy, thank you so much. It has been a true pleasure and privilege to have you. This is why we see all of your patients, they love you. It has been very wonderful to have you in the program. We'd like to thank also Dr. Agrawal, Dr. Lee, and Dr. Tavallaei. And also we'd like to thank all the audiences and viewers around the world for their interest in endometriosis, for their interest to raise awareness about this social issue. We wish all of you the best, and we will meet you next month, February the 26th, I think it's a Saturday, at 10 a.m. again here to continue this program make sure some of the patients next time are hopefully are all available to hear their stories. And thank you again, Dr. Amy, and have a great week. Bye-bye.
Bye, everybody.
So Mary, tell us, what do you do with these patients from your perspective, working with Dr. Talebian, using your expertise?
Sure. So I'm a doctor of acupuncture and Chinese medicine. And so I specialize in fertility, and I have a team of acupuncturists that work with me. We have a location in Southampton on Long Island, and then we also have a clinic location in Manhattan that I now share with Dr. Talebian. And we have developed this kind of integrative approach where, I work with women while they're trying naturally, and then I work with couples when they're undergoing IVF and other treatments. But I've been practicing about 15 years, and I've always loved Western medicine. And so right from the start of my career, I've always wanted to work in an integrative way. So using my tools of acupuncture, Chinese herbs, nutrition, lifestyle changes, evidence-based supplements with research backing them. Those are my tools, but my mind still kind of thinks in a Western medical kind of way. And so I really love, I can't do, in the state of New York, acupuncturists can't do blood tests or any sort of testing. And so I like to work with Dr. Talebian and her team at CCRM because they can do the testing that I can't see. So like I can't see the blocked fallopian tubes that might indicate scar tissue that indicates endometriosis. And so these are tips that I appreciate to get direction for my treatment plans. But Dr. Talebian sent me Nina pretty early on. I think we did some IUIs, right? And right from the get-go, when we see a patient, we don't just talk about fertility. We do talk about the menstrual cycle, and it gives us a ton of information on the health, their overall health. So whether they have menstrual cramps or not, just gives us information on their underlying pattern. So women with a lot of menstrual cramps might also have a lot of other stagnation in the body. So constipation, headaches, pain elsewhere, like neck and shoulder pain, back pain. But endometriosis doesn't have to go along with those symptoms. And especially for us to treat it, we treat the overall body. So we also look at digestion, we look at sleep patterns, we look at energy, we look at their diet and how their body is processing it. So sometimes people think they're eating healthy. They might go vegan or they might be vegetarian, but we look at their digestion and their overall health, and it's not working for their system. And so we really work on a holistic level where we try to help the patient become healthy overall. But through my time working with Dr. Tolabian and her team at CCRM, we've developed this integrative approach where we discuss cases. And so I'll come in and say, you know, thanks for referring so-and-so. Since we share offices, we can go chat face-to-face, which is great. And, you know, I'll give my side from the Eastern perspective of, you know, I'm seeing this in this case, there's like a weakness in the gut. I don't think she's absorbing nutrients well. I'm going to work on that and we'll see what happens. Or maybe a patient has done multiple IVFs and is getting poor quality embryos out. And so Shiva will send me those patients too, and I'll work with their diet to decrease inflammation, which is a big part of endometriosis, which I'm sure we'll talk about. And we'll try to decrease the inflammation using antioxidants and herbs and acupuncture, changes in diet, and then we'll repeat an IVF. And we often do get improved results with subsequent embryos, but occasionally we won't. And then, you know, we'll kind of switch gears, and that's when we might send someone to surgery. So in Nina's case, she made beautiful embryos, and she had a lot, right? And so there was also, you know, sometimes I think we'll get tipped off with endometriosis when it's a young woman and she has decreased ovarian reserve. She's not making that many eggs and they're poor quality, and she's like 32. That's another tip off for us, where we're like, what's going on here? Why are these eggs so poor? And, you know, we'll do our team approach and then kind of powwow on next steps. And sometimes that is surgery to explore for endometriosis.
Our patient is a 28-year-old para 2002 with complaints of non-cyclical pelvic pain for 1 year. Physical examination revealed a palpable mass in the anterior bladder wall. Previous history included chronic pelvic pain, 2 prior cesarean deliveries, and a diagnostic laparoscopy 1 year prior revealing endometriosis affecting the cul-de-sac and uterosacral ligaments. Pre-procedure cystoscopy revealed a mass in the anterior wall of the bladder that was infiltrating the mucosa. Ureter stents were placed bilaterally prior to the procedure. Upon evaluation, the bladder was severely adherent to the lower uterine segment and the cervix. We start the case by mobilizing the bladder away from the lower uterine segment. A combination of sharp dissection with cutting current of the robotic scissors and blunt dissection is used to separate the adhesions. Downward traction is placed on the uterus in order to help identify the tissue plane. In cases where there are dense anterior adhesions, it can be useful to approach and mobilize the bladder flap laterally, as demonstrated, in order to better identify a tissue plane and facilitate dissection. We now approach from the right side and continue mobilizing the bladder from the lower uterine segment. We now proceed with cystotomy using cutting current. It is important to enter at a point that is away from the orifice of the ureter. The next steps involve excision of the endometriotic nodule. Traction is placed on the nodule, and cutting current with the robotic scissors is used for dissection. It is crucial to maintain knowledge of the location of both ureter orifices during this procedure. We circumferentially dissect around the nodule. Again, we check the location of both orifices. Pre-procedure placement of stents in the ureter is crucial for maintaining safety during this procedure. We now dissect the inferior portion of the nodule. Remaining adhesions between the bladder and the anterior cervix are bluntly mobilized. Sharp dissection by cutting current is now used to mobilize the remaining adhesions. We now continue to circumferentially excise the nodule. It is mobilized from its spinal attachments to the bladder. The nodule is placed in an endoscopic bag prior to removal. We now proceed to repair the cystotomy incision in 2 layers. We introduce an ovicral suture. We first start by securing the angle. For the first layer, we make sure to incorporate the bladder mucosa with each bite of suture. The first layer of closure is accomplished using a continuous suture technique that incorporates the bladder mucosa with each bite of suture as demonstrated. This technique was continued in order to close the first layer. After closing the first layer, a second ovicral suture was introduced. A second layer, using a continuous suture technique, was done to imbricate the first layer, forming a watertight seal. Final pathology was consistent with the deeply invading endometriotic nodule that was invading the bladder mucosa. All remaining endometriotic lesions were removed. The patient did well post-op without any complications or sequelae. Post-procedure cystoscopy confirmed excision of the lesion, a watertight seal, and patency of both urethral orifices. A cystogram done 2 weeks post-op showed complete healing of the bladder. At 6 weeks and 3 months follow-up, the patient was doing well but no complaints of pain. Thank you for your attention to our video.
Hello and welcome. This is the 6th episode of Endometriosis Explained, Ask the Experts, as part of a series sponsored by the worldwide EndoMarch. The session today is about alternative therapies to surgery like acupuncture, physical therapy, meditation, herbal medicine, nutrition, prayers, etc. The sessions of the previous time can be observed on the website of Worldwide EndoMarch. I am Dr. Kamran Nejat, the founder of Worldwide EndoMarch. I am joined by the co-founders of the Worldwide EndoMarch, Dr. Spar Nejat, Dr. Sina Nejat, Dr. Azad Nejat, and also Barbara Page. Also, the guest speakers, physicians, and colleagues today are Dr. Joel Osayas, Christopher Mullen, and Beth Schiffman. Also, our guest speaker today, the patient guest speaker, happened to be a physician, Dr. Atna Mihailis. And We thank the participation of all of them for being part of the session. Each of our experts today have extensive experience in alternative therapies. Beth Schiffman has been practicing Chinese medicine for years and has extensive experience in this area. Dr. Kirsty Vermeulen is internationally known for naturopathic therapies and also is the author of the book Happy Hormones. And Dr. Joel Osayas has an illustrious background. She's a graduate of Stanford, Harvard, and Hopkins. And all of them are joined by other physicians and colleagues who are helping us, Dr. Shruti Agrawal and Dr. Janelle Jackman, that they would answer your online questions. We thank you as always to participate in our program. These are not medical advices we are giving you. For any kind of medical advice, you need to see an expert and have individual care and treatment. However, we answer these questions as a guideline to help the participant. The next session, which is going to be in October, is going to be about endometriosis of the diaphragm, lung, and chest in general, thoracic endometriosis. If you need other previous sessions, go to the website of Worldwide Endometriosis March, and you can see that all of them in your previous sections. And since so, I would start with Dr. Atina, and I welcome her. She is the director of the emergency ultrasound, and also she is an assistant professor. And we thank her very, very much for taking the time to join us and share her story. She is a patient of Dr. Parnejad. Thank you so much, Atina. Welcome.
Hello, everyone. Hi, how are you? Good afternoon. So I'm going to let you know what my story is. I have known that I had fibroids since my 20s. I knew I had an endometrioma at some point. I was following it, but I really didn't address the issue until it was time for me to have kids. So I got married in 2010, and we started trying to have children, but we were unsuccessful. I will also tell you that for many, many years, I would have heavy bleeding, pain with my periods, and then I suppose in the last 3 or 4 years prior to getting married, I had bleeding every single day, literally every single day. So it was very uncomfortable in intercourse and just in general. So what I did was I started in my free time making appointments to various specialists to see what we can do. So I had an initial ultrasound that showed multiple fibroids sometime in 2011, endometriomas, I believe, on both sides of my ovaries. And so I was told that I needed to go to a surgeon to take care of this before I got pregnant. I found a doctor that my husband knew. It was Dr. Griffo, because my next step was IVF since we had been trying for a while. And Dr. Griffo recommended Dr. Najat once he did an ultrasound and saw everything that was going on with me. So I went to Dr. Najat, and Dr. Najat saw a 12 centimeter fibroid at the fundus of the uterus, along with multiple other fibroids. He said I had extensive endometriosis, and he asked why I waited this long to take care of it. I'm just going to backtrack, because before Dr. Najat, because he was the last doctor that I had seen, I had seen someone at New York Methodist Hospital, New York Presbyterian, which had told me that I needed a vertical incision, and that's the only way that I can take care of this issue. I had seen someone at Cornell that said they weren't sure that they can actually take care of this because I had too much going on. I had seen someone at Sloan that said that they were going to get back to me and they were going to convene with other doctors. And I had seen another private doctor in Manhattan that said I required 2 surgeries to take care of this, 2 separate surgeries. Anyway, so I see Dr. Najat, and he was very pleasant from the very beginning, very reassuring from the very beginning. And if you know him at all, you know he's always smiling. And he said that he would be able to do the surgery. And I saw him sometime in December, and he scheduled me for February. So February came, and he did my surgery. It took a long time. It was a 5-hour surgery because there was a lot going on. And then he said that I would have to wait about, I think maybe 8 or 9 months until I can go see Dr. Griffo again. And I did, and I saw Dr. Griffo. And the following year, a year from when my surgery was, I had my first transfer. And it's because of Dr. Najat. And I usually don't get this emotional, but it's because of him that I have 3 beautiful children. So he took care of everything. And I recently also went to him because I had a polyp inside the uterus, a benign polyp, which he also took care of in about half an hour. So I am very grateful to him because I went to every single institution that I could think of in Manhattan. And I was very discouraged. And as a doctor, you know, you start thinking about the worst possible things, and you start thinking that this is not going to be taken care of, and maybe I won't be able to have kids right away or even at all. And Dr. Najat just smiled at me, said, we'll do a surgery, it'll be fine. And I owe him a lot. So that's my story.
Thank you very much, Athena. This is a wonderful story. And we thank you very, very much for sharing it. And we are very happy to see a lot of smile on your face now. And we really appreciate you joining us. I see you in your car, taking care of your children, dropping them for their sports, etc.
Yes.
But if you have the time and stay online, we would love to have you. If there is somebody else has any question, then we would address it to you. And we really, really appreciate your kindness to be on the program. So saying so, I will join. We will dive in the questions. And we will start with Beth Shipman. Beth, please go ahead and start. And you answer all the questions that it is addressed to you. Thank you.
Okay, good morning. My name's Beth Schiffman, and I have a clinic, Many Lives Chinese Medicine, in Redwood City. And I'm an acupuncturist. I've been practicing for 22 years. And like Dr. Athena's story, which was very brave and a very long journey to her fertility, our clinic specializes in fertility. We see general medicine, but a lot of the ways that we work with endometriosis, while we see endometriosis in younger women with painful periods and spotting and all of that comes with painful cycles, we also see quite a few patients who are on their journeys to conception. So there's Chinese medicine is quite effective in promoting fertility and promoting pain-free cycles. How do we do that? We treat every single patient individually. So with that, we do obviously an individual intake, and we find out most patients come to us, like I said, with pelvic pain, pain with sex, pain with bowel movements, heavy bleeding, spotting, and not very often an endometriosis diagnosis. So the beauty of Chinese medicine is that we treat the symptoms that are up front and very painful, but we also look at the constitution of each patient very deeply. And with that, we make a Chinese diagnosis, and we use acupuncture, and extensive herbal medicine to help rebalance hormones. We promote blood circulation and we reduce pain, which contributes to women actually having to have better cycles and a better chance of fertility. So acupuncture is quite effective. And when we come to the point, like Dr. Athena's story, where there needs to be some further investigation, then we definitely refer out, and we refer to basically Dr. Najat and work with him pre-surgically, post-surgically, to ensure a comfortable process and hopefully a better chance of conception. Chinese medicine treats a wide range of women's concerns, and endometriosis we see in our clinic tends to be, gosh, 60 to 70% of our patients. Other questions that are interesting and we get asked often are about our herbal formulas and our herbal medicine. We create very elegant formulas. We do them into, we make them into a tea, and they're individually created for this each person's case. So these formulas are often considered a little bit mysterious because you can't really get them on the open market. You can't buy them at CVS or, you know, in a general drugstore. So basically, the art of our medicine and being herbalists to create these elegant formulas contribute to our treatment protocols for each individual case of endometriosis. Some formulas are very mild. Some formulas are very, if the patient has a strong constitution, some formulas can be very rigorous. So with the formulas, we treat every phase of the menstrual cycle. So when the menstrual cycle is optimized, then the pain tends to be really decreased and the patient is much more comfortable. So herbal formulas are used quite a bit in the mix. So we do acupuncture, we use herbal formulas, we look at diet, and we look at lifestyle combined to create a treatment plan for our patients. On the herbal side of things, a lot of patients ask about the side effects of herbs. And when a patient is seeing an herbalist, an acupuncturist in the state of California is an herbalist as well. So when the patient sees an herbalist or us, the herbal formulas that are created are safe because we are trained to create these formulas with, if there's very toxic or stringent herbs, not toxic, but if there are very stringent herbs in the formulas, we use mild other herbs to offset the balance. So the formulas tend to have 14 to 18 different Chinese herbs in them, which work synergistically to create a positive outcome. There are side effects. Sometimes patients will experience some loose stools. Maybe they have a little bit of a headache, some stomach upset, but it's not very common because we've been working with these herbs and these herbal formulas for many years. We match the herbal formula to the patient's constitution. How often, there's another question too about herbs, and we talk about dosages and how much herbs should I take. And in our clinic, when we give herbal formulas, we dispense either herbs in pill form for very busy individuals, or we make the customized teas, which give us a lot more flexibility with regard to really working on specifically the diagnosis. So it gives us a little bit more power for success when we give an herbal tea. The teas are, we give 2 teaspoons of, the teas come in sand form, so they're grains. You don't have to boil them. They come in like a sand, they look like sand. And so basically they're called grains. So we give 2 teaspoons of grains in hot water twice a day, and you mix it up and you drink it. It's not the old-fashioned way where we've been taught to actually boil the actual, dongui and baishao, all of these herbs in a pot. We don't really do that anymore because those kinds of raw herbs tend to get moldy and buggy, and that's not healthy for our patients. So the herbs that we get are now distilled down into grain form, in which we can dispense them quite easily. So for the herbal piece, there's a lot of questions about herbs out there or Chinese herbs. A lot of times I get the question of, what 4 herbs can I take to help with my pain? And the answer is that we don't often dispense herbs in single form. So we don't give 4 herbs. And you won't really find 4 herbs out at Whole Foods or at any market to take. You really want to see an herbalist to get the herbal formula that's for you, and that herbal formula can be shipped to you, or, it will always be available to you. So it's not like you go once and you get an herbal formula and then you don't get it anymore. So we are available to set that kind of system up. So for herbs, we work very, very closely with herbal formulas to support the acupuncture treatments with a diet and the lifestyle to provide a positive outcome for endometriosis. Then the biggest question I get is, what is the single most pain medication I can take that's herbal? That for us doesn't really happen. That would be an herbal formula that we are creating so you can have the outcomes of less pain. There's not one single pain herb or herbal formula out there that's going to really do the trick. You really want to come see an herbalist or a licensed practitioner to get those herbal formulas. And lastly, the very last question I get, I'm sorry I'm jumping around a little bit, but this has to do with the acupuncture treatments, which I did forget. But how long should I be seen by an acupuncturist to get any sort of results? Typically, we like to follow a woman through 3 cycles to get about 50% of the pain reduced. And then we go 3 or 6 months long to actually see full results. Do we cure endometriosis? No, we don't. We don't cure it. We help manage the pain. We help put together a diet and a lifestyle plan that will be manageable, that's the operative word, and effective. And then we work very closely with Dr. Najat, all of Dr. Najat's, to work with the highly medical side that obviously acupuncturists were not able to do. And that, if you have any questions, I'm here to answer them. So thank you.
Thank you very much, Beth, for very, very insightful description and answering, as I mentioned earlier, all the questions that have been submitted. Our panel are addressing it in one session. And if you have more questions, there are other physicians, Dr. Agrawal and Dr. Jackman, online answering your questions. And if you have any specific question for the panel, please let us know. We will ask them. I have one question. How or is there a limit, or any of these medications could cause or increase the bleeding time? Let me tell you why I'm asking this question. Over the years, my brothers and I and my niece, we have experienced, I remember, at least in my experience, 2 cases of the patient that they were taking Chinese medicine, and one of them was a pediatrician actually.
Yeah.
And the other one was a patient that she was from China, and she was taking excessive amount of Chinese medicine. And usually before the surgery, when the outpatient taking any kind of medication, aspirin, Motrin, we tell all of them to stop. But because these products have some medicinal products, we also are very careful. And we checked their bleeding time to see how much bleeding, but it was almost normal. But during surgery, they had a lot of bleeding and they had nothing else. The only thing that we could find out is they were taking a ton of medicine. What I'm trying to ask, is there a limit to it? Do you think there is a side effects, or do you tell patient to take this much and don't go over? I appreciate if you respond.
Yes. With dispensing the herbal formulas, we also check if the patient does not come in for acupuncture, but only gets herbal formulas from us, we actually reevaluate them every 3 months. And with surgery, even with any sort of surgery, we ask them to stop any sort of herbal intake a full week prior to the surgery. So I don't know in those two cases if they had instructions to stop their medications before the surgery. I think you said you asked them to.
Yeah, I'm
Correct.
glad you asked. Yes. And what happened, specifically about one of them, she said, we asked everybody to stop 2 weeks. And later, when we investigated further, unfortunately, both of them, they had not stopped. And they have continued to take a lot of the herbal medicine. So you are correct.
Yes, we are quite diligent in working along with our physicians. So if there's ever if there's surgery coming, if there's any sort of procedure that's coming up, even dentistry, we always request that they stop their herbs at least a week pre-surgery. And then in the following cases of, herbs gone wild, basically, if the patient's constitution is really strong and they're taking a really big blood-breaking formula, which we do give, we can't eradicate endometriosis, but sometimes their blood stasis is their inflammation is so strong that we will give herbs to that. When we dispense those types of formulas, they are seen as once a week, and we are monitoring their every secretion. So they are under close monitoring. While we give herbs also to maintain the cycle, maintain that the hormones are balanced and the cycles are balanced, we give those formulas for 3 to 6 months at a time. They have to come back. We have to come back and check in with us, or we do a reevaluation. Like pharma, they don't get refills automatically.
Well, thank you very much. That was very, very helpful. So we have one of the other questions in between. Thank you very much, Beth. Dr. Farnija, do you want to answer your question?
Yes, what was the question? There are 2 questions. So one question was, I have endometriosis, and my physician said if I take hormonal treatment, the chance of my endometriosis coming back is less, but I cannot take hormones, and what I should do. So endometriosis is a very complex condition. The characteristic of endometriosis is estrogen-dependent chronic inflammatory disease. So, unfortunately, at the present time, the most effective way to make a diagnosis and treat the disease is surgery. So the first step is that you should contact or find a physician to remove and treat all the visible endometriosis as much as possible. So that is the first step. The next step is based on the patient's age and her symptoms. You have to individualize the treatment. Unfortunately, endometriosis affects the reproductive system, and I encourage all of my young patients that they do not have family to consider thinking about having family as soon as possible. Have a consultation with the infertility specialists. Even sometimes I refer them to have egg freezing or embryo freezing. Also, because it is inflammatory disease and the patient has, for example, pain, I try to connect them to alternative treatment like acupuncture and the non-hormonal remedies, as was discussed before, to connect them to have a multidisciplinary approach to treat that individual person. If they could get some hormonal therapy, and there are different types, I will find out why she cannot take the hormones. And some of the side effects actually may not be severe, or you could modify the hormonal treatment, because we have published papers that if the patient does not ovulate, will not form chocolate cyst. That is very important, that endometrioma or chocolate cyst comes from the ovulation. They have published several papers about it. And as Dr. Mihalos mentioned herself, she had endometrioma or chocolate cyst. And this, we could put some sort of suppressive therapy, birth control pills, and there are different dosages, and modify that treatment that she does not develop endometrioma. And in the same time, like her, she wanted to get pregnant, refer her to a good reproductive endocrinologist to get pregnant and follow them. So that is the summary of my answer.
Thank you very much, Dr. Farnajab. We appreciate it. Thank you for your comments. The next person who addressed many of the questions of the audience and participant is Dr. Christopher Vermeulen. Dr. Christopher Vermeulen, as I mentioned, he is a naturopath and internationally known, and also the author of the book of Happy Hormones. Please, Christy, go ahead and answer the questions addressed to you.
Hi, everyone. Thank you for having me. So one of the most common questions I get with my endometriosis patients, well, first of all, I see a lot of endometriosis patients that come to me as a last resort. They've been struggling for years with painful menstrual periods, painful intercourse, heavy bleeding, chronic pelvic pain, bladder pain before their periods. And they've been struggling for years. And because, you know, endometriosis is not a readily diagnosed condition. So one of the first steps I always do when I'm suspecting it is refer to Dr. Najat. He's in the Bay Area where I work. And then we really get a confirmation about if it's indeed endometriosis or not. I recommend the majority of my patients go ahead with the surgery with Dr. Najat. And then the next step is really, okay, what do we do next? You know, we have the hormonal control options to keep endometriosis suppressed, or we have the natural options. I do have a lot of patients who can't take the hormones. They've had side effects with the birth control pill and the IUD. So then we go into a lot of the natural therapies. And, you know, there isn't just one single natural therapy when we're looking at suppressing endometriosis. It really does need to be a holistic approach. It has to include dietary changes, which I'll talk about, lifestyle changes as well, supplementation with, different herbal formulas like Beth was speaking about. She does a lot of the Chinese herbs. I do a lot of more of the pharmaceutical grade supplements. And then hormonal therapy, the bioidentical therapies, I use quite a bit. Women tend to have much less side effects with the bioidentical versus some of the other ones. And I'll go through and explain some of that for you. But I just want to get across that it really does have to be a multifactorial approach when treating endometriosis. So diet, this is one of the key foundation for preventing endometriosis recurrence. And what we really want to look at here is decreasing inflammation in the body, because we know endometriosis, the pain, the symptoms all worsen when we're in an inflammatory state. So it needs to be more of an anti-inflammatory diet. And we also need to address the source of estrogens in the diet. There's a lot of chemicals in our environment and in our food that are termed xenoestrogens. These xenoestrogens, they can actually mimic estrogen in the body and stimulate estrogen-like effects. And I have seen these xenoestrogens actually increase serum estrogen levels in my patients' blood results and worsen endometriosis pain. So diet-wise, it's decreasing inflammation and taking out any hormonal impacts from the xenoestrogens. So really like a plant-based diet, low in animal products, like low dairy, low red meat, low dairy, low red meat, low sugar, as well as really the way to go. Taking out sugar significantly decreases inflammation. And sometimes just with that, I see patients' endometriosis symptoms improve. And this means if you look at the nutritional label on the back of any food you're eating, you'll see if sugar has been added to the ingredient label, and you'll see the number of grams. Ideally, you want to try to keep your sugar intake below 25 grams per day. And I see it a lot, we're already
hard to do
by breakfast. When we look at granola, yogurt, different types of cereal, we're already, 15 grams already by the time breakfast is over. So we have to do a lot of work, with really focusing on a whole foods diet where you're eating real foods. You're not eating much that comes already packaged or in a box, because that's where the sugars start to sneak in. Red meat is important to take out because the beef here is not only treated with hormones and has estrogen in it, it's also very high in something called arachidonic acid. Arachidonic acid feeds directly into our inflammatory pathways. So again, like taking out red meat and sugar, you can already have quite a big improvement with some of the endometriosis symptoms. And then if you take out gluten and dairy products on top of that, even better. A lot of research has shown that by taking gluten out of the diet, your endometriosis symptoms can reduce up to 65-ish%. And this can be from a few different reasons. Gluten, one, causes inflammation itself. It's quite a big molecule for our body to digest and tends to activate our immune system. But a lot of gluten-containing foods also have a ton of sugar in them. So it's kind of two-pronged. The gluten itself is a problem, but also the foods that contain gluten tend to be a problem. So when you're hearing a lot of no's from me, like no dairy, no sugar, no gluten, no red meat, you really want to kind of change the mindset away from all the no's to, like what can I eat? What should I eat? And this is where you really want to focus on the whole foods. You know, like for instance, breakfast, instead of having granola or cereal, think about doing, you know, whole grain oatmeal, for instance. And instead of adding sugar, you can add some fresh fruit to it and use almond milk or oat milk. You want to make sure that at least your lunch and dinner, half of your plate is veggies. These vegetables are so important. And it's not just because they're healthy for us, but they also contain a lot of fiber, which is going to bind up excess estrogen. It's one of the key things that I do with my endometriosis patients is try to reduce estrogen. And by having more fiber and plants in your diet, it's going to help bind that up and help take some of that estrogen out of the body. The vegetables are also very high in antioxidants, which are going to help decrease inflammation. And also by adding in more veggies, you're not going to be eating as many of the foods that have the sugars and the dairy and the gluten in them. So if you could focus on a healthy breakfast, you know, either like whole grains, oatmeal, do like a protein shake. However, protein shakes, we've got to be careful of too, because a lot of that protein powder is either whey protein, which is a dairy product, which can worsen inflammation and increase estrogen, or they're also soy. And I know I've received some questions about soy protein. And there's so much debate whether soy is good or bad and whether it increases estrogen or not. From what I've seen in clinical practice, I think it's a problem. I have at least the highly concentrated soy. So soy that's found in protein powders and bars are the ones that I see cause the issue. Having like tofu and tempeh, I haven't seen an issue with endometriosis and estrogen excess symptoms, but definitely soy protein bars, I have. I've seen it I had one patient, her serum estrogen levels went from about 150 in the luteal phase, so that the weeks leading up to your menstrual period, up to 400. And once I took out the soy protein, so the difference was went 150 to 400 because she added in soy protein. Once I took out the soy protein powder, it dropped back down. So I have seen it clinically with that high concentration of soy products. So yeah, diet wise, you know, whole foods, half your plate, veggies is the way to go. Whole grains are lovely. You know, just because I'm saying take out gluten and sugar doesn't mean that you can't eat oatmeal, you can't eat brown rice, quinoa, couscous has gluten, so that one's still out. But there's a lot of whole grains that you can still eat and enjoy. But definitely plant-based, low sugar, low dairy, no gluten. So that's kind of the diet component. One question I get along with diet actually is about wine and alcohol. Same thing with wine, you know, like yes, red wine has resveratrol in it and some antioxidants, which are great, you know, like we all need a little bit more antioxidants. But the problem with alcohol and wine is that the side effects of the alcohol outweigh the benefit of the little bit of antioxidants and resveratrol you get in the wine. There's every year, you know, the cancer societies are releasing new research, and they do show that especially for women, more than 2 alcoholic drinks per week does increase the risk of heart disease, colon cancer, breast cancer. And alcohol itself also increases estrogen levels in the body. So, you know, you don't have to take alcohol out completely, but limiting it to 2 drinks per week, I think is the better way to go, for sure. Okay, so that's kind of the diet component. That's super important when we're trying to suppress endometriosis. one of the other key parts is lifestyle. And lifestyle is a big thing. You know, this involves exercise, it involves stress reduction, it involves your environment and its toxicity. So we do see that stress affects our immune system and our inflammatory system. And I have clinically seen that high stress does worsen endometriosis symptoms. And yes, easier said than done. How do we, you know, we live it, we all have stress in our lives. But sometimes there's little tools that you can do that will help your body cope a little bit better. And some simple things would be, you know, set up some predictability for your body. Like give yourself some routine so so your body knows what to expect every day. So eat your meals at the same times, go to bed and wake up at the same time, exercise at the same times. If you can do that, it does bring down your stress response because your body knows what's going to happen to it next. Some other things, especially now during the pandemic, what I've been hearing from my patients is that they have no separation anymore from work and personal life because majority of people are working from home. And that's not good. You know, we need to be able to set boundaries when it comes to our work and our personal life. So one thing to reduce stress would be also, you know, have your set work hours. And that's it, you know, leave your evenings free if you can. And if you can't, then you got to leave some time for yourself in the mornings and take a lunch break, you know, give your brain and your body a bit of a break. And your colleagues, your bosses, they get used to it. They're say, okay, you know, like, I know you're not working during these hours, but I know that you're going to take care of it when you're back on at this time. So it also provides some good expectations between you and your colleagues to have set boundaries when it comes to work hours. And then of course, you know, taking care of ourselves, you know, especially for women, I find that we're the last, we take care of ourselves last, you know, everyone else kind of comes first for us. And I think it's really important that we still, even if it's, you know, 15 minutes a day, we're still doing something that brings us joy, that we like to do. So really, you know, I encourage all of you to really think about what brings you joy and try to sneak some of that into your life every day. And yeah, and what doesn't bring you joy, you know, as we overcommit, we all do. Also go through and create a list of everything that you're doing and see what makes you happy and what doesn't. And if there's things on that list that you really don't like doing, get rid of them if you can. Of course, we can't get rid of everything we don't like, but try to make some changes there.
Thank you. Thank you very much, Christy. That was very, very insightful, very helpful. Thank you very, very much. That is very wonderful, all of your advice, and we appreciate it.
Yeah.
So we will go with the next one question of Dr. Sinan Nejad and then Dr. Joel Osias. Also, I would like to let you know that the app of Worldwide EndoMarch is available for you, all of you online, and it is completely free from around the world. You can use that app to help you diagnose, to help you. Only it's not a treatment, but helps you to see possibly you might have endometriosis, and you can see the advice of the physician. Also, as you know, Worldwide EndoMarch is a charity philanthropic organization, is a 501c3. All of your donations are tax deductible. We appreciate it very, very much. And by now, Dr. Sinan Nejad could address his question, and then we'll go with Dr. Osias.
Hello, I'm Sinan Nejad from Atlanta, Georgia, and I'd like to thank all of the participants and the faculty. Actually, the question for me was, do all the herbs have hormones in them? But with two excellent presentations you heard before, they covered most of the area that I would like to address. Except I'd like to elaborate that the word natural could be misleading. And anytime we go in the grocery store, herbal store, and they said, oh, this is a natural product, or organic product, just read the content of it, see how it's been prepared. I tell my patients, you know, cyanide is natural also. We just have to be careful how we approach these organic or natural product. Do they match to our body or not? As it was mentioned, soy has phytoestrogens. And a lot of people drink soy milk or almond milk. These are all natural, but they may not be natural to our body. They may not be set for us to use it. Another question comes that how does it work if you blend and multiple vegetables? Vegetables are meant to chew, not to drink. So some of these blending that we do, it could affect the function of the herb or the vegetable we are using. It takes the fiber effect away, it takes the enzyme effect away. So it's always good to be careful. We have excellent nutritionists, herbalists that talk with them. It's simple. There was a time you had to go and visit each one, but right now, easily you can contact either Christy, Beth, or any other nutritionists who are working with us and talk with them about your individual condition and let them customize some products directed to you and your body. And thank you very much for letting me discuss this point with you.
Thank you very much, Dr. Sinanejad. The next speaker, and she's going to address questions of the rest of the questions in respect to alternative therapies, herbs, and diet that complements the excellent presentations by Beth and Christy is Dr. Joel Osias. Joel, go ahead, please.
Hello, hi, I'm Dr. Osias, and it's really a pleasure to be here today to talk a little bit about some alternative therapies for the treatment of endometriosis. The questions that I'm going to be answering overlap a little bit with what Christy discussed in terms of the diet for endometriosis. Like her, I definitely recommend a hypoallergenic diet. So I recommend that patients try to eliminate the most common inflammatory foods. So the first one, of course, is wheat, as she mentioned. Dairy, she already mentioned as well. Soy, we eliminate. Corn, because it's genetically modified. Peanuts, because of the high presence of aflatoxin. And then we try to eliminate all the synthetic sweeteners, because a lot of patients are using things like NutraSweet in an effort to lower their caloric intake. But this has a detrimental impact on the gut microbiome. So if you recall, there's a major connection between the gut and the brain. And since endometriosis is associated with a lot of pain, we want to support gut health. Because as much as we have an imbalanced gut microbiome, that impacts the perception of pain. So we generally recommend for the patients to eliminate wheat, dairy, soy, corn, peanuts, and also all the synthetic sweeteners. The other question that I was asked was about the use of CBD for the management of endometriosis-related pain. CBD is very interesting and a very an area of evolving interest, and I think it has a lot of applications for both pain and other conditions. It's been used in the past for a seizure disorder, also used for nausea related to chemotherapy and cancer. But for the relief of endometriosis-related pain, a lot of people have been used a CBD tincture. The usual dose is somewhere around 12.5 milligrams on the low side. A medium dose would be somewhere around 25 to 75 milligrams. And then the high dose would be 100 and above. Generally speaking, CBD is very well tolerated, so people don't have to worry about a very high level of toxicity, but the response is very individualized. This is due to the fact there's a lot of variation among patients in their metabolism of CBD. So to get a better assessment of what an individual patient's tolerance would be, there's a company that offers a genetic testing that looks at how the liver processes the CBD, to look at whether or not there is a variation in the different enzymes that process the CBD. And that will let you know whether you're a fast metabolizer or a slow metabolizer. So if you're a fast metabolizer, then you might require a higher dose, but if you're a slow metabolizer, then you need a lower dose. So in that case, the dosing has to be individualized based on that patient's particular genetics. So that's really helpful. And I think, let's see if I can find the company that offers that treatment. The test is fairly inexpensive, only $129. It's called cannabisdna.com, is the company that offers that testing. Usually it has to be ordered by a physician, but it's not very expensive. And I think it helps patients who are interested in CBD as a potential modality to help their pain to better understand whether it would be a good option for them, and to figure out how they should dose it. So generally speaking, I say start low and go slow, because sometimes people are impatient and they want to get the pain over quickly, but really it takes usually about a week to 2 for patients to begin to see the effect. So they will not see it very quickly. But for different patients, we individualize the treatment options based on their particular needs. Patients also ask about marijuana. Marijuana has a higher concentration of THC. So THC is more responsible for the euphoric effect that we associate with cannabis. And so generally speaking, you think about a ratio of 10:1. So let's say if you were using 10 milligrams of the CBD, you'd be using about 1 milligram of the THC. Once you get above 5 milligrams, the euphoria sets in. So if people want to avoid that euphoric sensation, then they usually stay below 5 milligrams. Patient asked again about whether we recommend a gluten-free diet for most patients with endometriosis. I definitely do. I think that gluten creates a lot of gut dysbiosis and a lot of gut symptoms, and for that reason, I think it's best to eliminate. But if patients want to individualize their dietary regimen, then we offer some food and tolerance testing that allows them to find out what foods create the most inflammation for them, so then they can decide what specific dietary regimen would be most appropriate. So we can personalize it that way. And patients ask me about whether you can combine alternative therapy and conventional therapy. I think you definitely can, especially if we think about detoxification. So things that support the liver. So we think about milk thistle. There is some broccoli extracts that help to support detoxification, and that can be used in conjunction with conventional therapy like Gizian or other oral contraceptive pills. And I think that was most of the questions that you had for me.
Thank you very much, Dr. Rosayas. As always, very helpful and very insightful. So could you please mention some of the foods that they are gluten-free, or some of them that they do have gluten? Could you mention some of their names?
Yes, absolutely. So I think of wheat as being most prevalent in things like bread. Pasta has a very high concentration of gluten, and it's also present in a lot of sauces. So you have to be very careful in reading the ingredients. So I think I recommend for all my patients with endometriosis to become food detectives. I mean, they have to always read the labels before they purchase an item to look for gluten and make sure that they avoid them. And Whole Foods has a great selection of gluten-free products. They have gluten-free bread, they have gluten-free pasta. So in California, there's a wide variety of alternatives for patients who are trying to avoid gluten in their diet.
Thank you very much. This has been very, very useful, and we appreciate it very much. So I'd like to thank Mr. Schiffman, Dr. Vermeulen, Dr. Rosayas, Dr. Mihal, and Dr. Agrawal and Dr. Jackman. Also, I would like to thank all of you around the world for listening, and all the headquarters of EndoMarch volunteers around here with Zoe Pennington, Tiffany Petowski, and Eliza Ackroyd, and Andrew, and Barbara Page, and Sean Stetner. They have been done all the work on a volunteering basis. The next session next month would be about EndoMarch and endometriosis of the lungs and the diaphragm and the pleura of the chest. It is going to be on October 31st. We appreciate you listening, and if you need to listen to the previous sessions, you can look at Worldwide EndoMarch on the top, and you can see to the other session. We thank all of you again and wish you a wonderful month until we see you next month. Bye-bye. Our next speaker is Dr. Naoma Sadler, the founder of Women's Serve and a fervent advocate for global women's empowerment. Having received an honorary doctorate from the United States International University, following a nomination by the United Nations Global Peace Council, Naoma is celebrated for her transformative work. She is dedicated to unlocking the potential of women and girls, dedicating initiative that enhances access to water, education, health, hygiene, and economic empowerment. Driven by personal experience with endometriosis, Naoma is a steadfast supporter of EndoMarch, infusing her advocacy with passion and commitment to raise awareness about this critical health issue. Her profound impact on women's empowerment and health makes her an inspiring voice in our community, and we eagerly anticipate her insight during virtual endometriosis conference.
Hello, everyone. My name is Eden Williams, and I am a Worldwide EndoMarch Headquarters volunteer. I am here today with Naoma Sadler. Once again, it is very nice to have you here today. I am really thankful for you taking the time to talk to us today and supporting our mission overall. Do you want to introduce yourself a little bit, Naoma?
Hello, everyone. My name is Naoma Sadler, and I am delighted to be here with you today. Thank you for tuning in. I have been a long time supporter of EndoMarch, and I'm just always delighted to come to the table when we're all gathering.
Great, thank you. Thank you very much. So to begin, do you want to talk a little bit about how you became familiar with EndoMarch?
Well, I learned about it through Dr. Najat, who has been my doctor now since I was first diagnosed with stage 5 endo, and that was over 20 years ago. So I've been along for the journey, and I just am always here to help raise the voices of other endo survivors and sisters who are still struggling to figure out what's going on with their bodies and be heard when they say that they're hurting or something's not right.
Mm-hmm. So to go a little bit more into that, if you felt comfortable, would you mind talking a bit about your experience with endometriosis, maybe beginning with your diagnosis or a delay thereof?
Yeah, well, I had the traditional kind of delayed diagnosis where I spent my whole young adulthood, since I started my cycle when I was 11. I was quite young, actually, and I comfortable, and I didn't have much recourse, and so there was a, go to bed with a hot water bottle and grit your teeth until you get through that phase of the month kind of approach. And it took me until mid-20s before I really started to acknowledge to myself that something was really not right, and I needed to find the answers. So it was about when I was 25, 26 that I started my journey to find the answers. And it started with a very old chiropractor, acupuncturist who was Chinese, and I was working with her, and she said, I can't really help you. You need surgery, and I believe she actually was the first to diagnose me and said, you have endometriosis. And
oh, wow.
after working with her a long time, I trusted her. And so then I went, and I was like, endometriosis. And I went on a journey to find the right surgeon to address the issue, because she had already told me that I needed surgery. And a lot of times the thing about endometriosis is you can't be diagnosed until you get scoped. And there is no diagnosis without being scoped with a laparoscope and having a camera put in you. And I had actually learned through my mother having endometriosis earlier on in my life. She had endometriosis and she had a complete hysterectomy, and it was done in not such a great way. And so I learned that you really need to find the right doctor to diagnose and treat you at the same time, and not think about one as your diagnosee and one as your doctor who's going to do surgery. Whoever goes in there to diagnose you should be able to treat you at the same time, so that you don't end up having multiple surgeries.
Absolutely.
And so that led to me going on a journey across the US and interviewing specialists and who said that they specialize in treating endometriosis. And in that process, I interviewed Dr. Najat, and I was really convinced because he had this different approach where he really listened and he took note of what I was saying and what my symptoms were. And he didn't have like one approach. In fact, a lot of the doctors that were specialists were saying they only cut, they only scrape, they only burn. They had one technique that they only did, and they were pretty committed to that technique as being the solution. Mm-hmm. And he was very clear from the beginning. He was like, this is the mysterious disease that is not the same for anyone. And once I go in, I'll be able to know, because I'll be able to see what I'm dealing with. And then I have a whole toolkit of techniques I utilize depending on what I see. And so his ability to see the uniqueness in everyone and listen was very unique.
Absolutely.
And I'll be forever indebted to him for his many years of service. And I'm getting emotional, but it is a beautiful thing that what he's dedicated his life to. And EndoMarch is a testament of that. And, you know, coming together once a year to raise the voices. And it's so important that we all come together and keep talking about it, so that it's not something that is kept inside for so long.
Completely agree. Yeah, thank you so much for sharing all of that. I definitely can also speak for his advocacy efforts and everything he does just from working with him in his clinics. I think it's really clear to see how many people he's really made such a large impact on, and how far advocacy has come to this day. I think that's something really important to acknowledge, that awareness is definitely increasing, and we've made a lot of progress in the last few years. And, you know, I think that Worldwide EndoMarch is something that has really helped further that along. So in your opinion, do you think there are any changes specifically in advocacy that we need to do to help further public awareness of endometriosis?
Well, obviously having more and more well-known figures come out and talk about it as endo warrioresses. Yeah. sharing their stories, you know, is a really important piece.
Mhm.
But also it's the great mysterious marauder, you know. There is a lot of unknown still about endometriosis, and so you know, the amount of research dollars that are given to endo is very little in comparison to other great ilks that the humanity faces. And when you look at the statistics of being 1 out of 10 women have endometriosis, and 50% of all infertility cases, I think it is, are actually women who suffer unknowingly with endometriosis. And a lot of times it takes, you know, a lot of infertility treatments and journey before you realize that's what you're dealing with.
Mhm.
So obviously we need more people coming out in the EndoMarch and coming together and raising the voices, and, you know, educating all the doctors, because a lot of times the doctors don't even know what they're dealing with. And I think that's probably one of the biggest things, is more education for doctors so that they know more about this disease.
Yeah, I
And when
really
you think about it, 1 out of 10 women being,
keep going. Go ahead.
there was a little delay there. I was just saying, when you think about it, one in 10 women being diagnosed with endo, that's based on having laparoscopic scopes. So if you think about all the women and girls that haven't had that, and probably won't in their lifetime, then you realize that it's a lot more than 1 out of 10 women who have this disease and don't know they even have it.
Definitely. Yeah. It's the same as how when you look into statistics of endometriosis, and you can see that nearly 50% of all women who have been diagnosed with endometriosis have been previously misdiagnosed with a mental health disorder. I think that's really important, related to why you brought up that physicians everywhere really need to be more educated on this matter, and it really just needs to be more standardized across the board. Because I think that, as you mentioned a bit earlier, taking women seriously in their pain and their symptoms is something that is severely under addressed in medicine today. So I appreciate you for bringing that up.
Right. It's definitely going to take a lot more like you and others working with Dr. Najat and his team to make this change happen.
Well, thank you very much. Yeah.
Working so hard in the medical world, who really care.
Mm-hmm. I completely agree. And thank you very much for talking about all of that. I really appreciate all of your contributions towards everything you've done in endometriosis awareness and with Worldwide EndoMarch. To kind of pivot a little bit, I wanted to talk a little bit more about your work with Women Serve. For those who don't know, Naoma Sadler is the founder of Women Serve. And I wanted to let you talk a little bit about that and maybe what motivated you to start that, if you wanted to speak a little bit about that.
Well, thank you for bringing that up. And yeah, so I, you know, as a stage 5 endo survivor, I've had a lot of surgeries and a lot of different treatments. And, you know, there's that thing where it's hard to get out of bed sometimes. And so having something that is bigger than you to work for, it's not just you, is really important. You know, like, so you know, I have a force that drives me to serve for equity, equality for women and girls around the world. And so Women Serve is work I do for women and girls in the Thar Desert of Rajasthan, India right now. And, you know, these women and girls have to get up and walk 10 hours a day, a lot of times, to just carry water on their heads home, 50 pounds of water. And if you have to do that up to 10 hours a day, then you just really have no time to even worry about your body. And so, like, without water, you don't have life. And so when I discovered, you know, Rajasthan and what these women and girls face, you know, with the environment that they're born into, and some of the cultural constraints and So Women's Serve is really founded to help women have water, health, and hygiene. And so then they get their time back and they can also do education and economic development. So, you know, the water is really a hurdle in their way. And that great Thar Desert right by the Pakistan border. And so personally, I've always been really obsessed with women and girls around the world. And with my work with traditional medicinals, I've been able to, you know, travel the world and visit many different cultures and communities through the farmers and collectors that farm and grow the herbs that make traditional medicinals products possible. And so the issues that women and girls face, and you know, doing something to make the world a better place than I found it is part, you know, what drives me every day. And so it's all those women and girls and the, you know, that help get me out of bed every day and keep fighting, keeping this body strong, because I can't serve this cause bigger than myself without the body. So I'm grateful every day that I get to be in health and strength and show up and continue to serve.
That's really beautiful. Thank you.
Something bigger than myself.
Yeah. Well, thank you for sharing that. For individuals that you know who would want to get involved with advocacy, things like Women's Serve or EndoMarch, or even starting their own initiatives, what advice would you offer based on your own experiences to sort of help them dive into that realm?
Well, first and foremost, and you probably heard this from a lot of people in your life, is follow your heart and do what you love. And you know, if you do that every day and you follow the passion that drives you, then you can't do wrong. So, you know, I really believe in, like, if everybody does what they love, the world would be a better place. So, and, you know, in every moment, you know, asking yourself the question, is this serving something or hurting something? And so if the answer is serving something, then you know, you're on the right track. If it's hurting something, then you should reevaluate. So there are so many causes and so many needs right now on planet Earth, and certainly the environment and fighting for the environment and women and girls and their rightful equal place, you know, kind of go together, I believe, and the health of women and girls and the health of our world. And so the earth needs us now, and you know, these sicknesses like endometriosis are symptoms of the earth being sick as well, because we've mistreated and polluted, and you know, plastics in our environment mimic this estrogen dominance, you know, can have cancers and endo, which is very much estrogen dominant, and you know, so there's lots of issues to fight. So if we can all show up and do what drives us and do it to the best of our ability every day, then the world will become better, I believe. So
I completely agree. Well, thank you so much for sharing all of that. That is really valuable information for many people out there who believe in the same causes as you and I. I really want to thank you from the bottom of my heart and from everyone else on behalf of Worldwide EndoMarch for everything you have shared with us today. It really means a lot towards our mission, and I wish we had many more like you. And I believe that interviews like this are what help people to come and fight for our cause. So I can't wait to hear about what you and your team accomplishes in the future, and in raising awareness for EndoMarch and for women and girls everywhere. But before we conclude this interview, I just wanted to go ahead and ask you, are there any last words that you would like to share?
well, for everyone watching, if you can talk about endometriosis more in your friend circles and your coffee breaks at work, and make it not such a stigma to speak about things like this, that also elevates. And so the more you speak, the better for all of us Endo sisters and survivors.
Thank you for that. Thank you for your time today overall, and I really hope you have a great rest of your day, Naoma. Thank you.
Namaste, everyone.
Endometriosis of the bowel is very common. Actually, after the endometriosis of the reproductive organ, which includes the uterus, the tubes, the ovaries, and also peritoneal endometriosis, endometriosis of the bowel is the most common. It may cause problems including bloating. All the symptoms of irritable bowel syndrome could be related also to endometriosis. That means all of the patients that are diagnosed with irritable bowel syndrome, and if they are female patients in the reproductive age group, their symptoms mimics the symptoms of endometriosis, and endometriosis could be one of the factors of the irritable bowel syndrome. So it could cause bloating, pain with bowel movement, it could cause constipation or diarrhea, or both of them mid-cycle or at the time of menstruation. It could cause bleeding at the time of menstruation, rectal bleeding. Sometimes could cause nausea and vomiting. And in rare occasions, endometriosis of the bowel could cause actually bowel obstruction. It is very, very important to remember and know how to manage endometriosis of the bowel. It is not always necessary to remove a part of the bowel or do bowel resection for endometriosis. Actually, that is rarely required. Endometriosis of the bowel, the most common, if you look at it, is around rectosigmoid colon. This is the bowel, this is appendix is here, this is called ascending colon, this is transverse colon, here is descending colon, here we call it rectosigmoid colon, this is called rectum and anus. Endometriosis is most common here first, in the rectosigmoid colon, and then in the rectum area, then it is in the ileum, small bowel around here, then it is the appendix, and then it is the cecal. For its management, there are many options, including doing nothing, sometimes manage it only with hormones, and occasionally with surgery, but it doesn't mean we have to resect the bowel all the time. Actually, the closer the endometriosis is to the rectum and rectosigmoid colon, the better to be able to be conservative and actually not to do bowel resection, but because the complications of the bowel resection itself could be worse than the symptoms. So I highly encourage you, if you think you have endometriosis of the bowel, refer to different articles that authorities have published. We also have published some articles that is very important. Recently, in the June of last year, we published in the Journal of American College of OBGYN an important article that we reviewed all the techniques, and we encourage you to read it, share it with your physician, that hopefully you receive the best treatment. I wish you best of luck.
Ok, Nancy, si nos gustas decir un poco de ti.
Sí, buenos días. Bueno, mi nombre es Nancy Aguilera Córdoba, yo soy de Costa Rica, pertenezco a la Asociación de Endometriosis de Costa Rica, a EndoCR.
Ok, muchas gracias. Y ahora vamos a continuar con algunas preguntas para ti. La primera pregunta es, ¿cómo crees que ha cambiado la conciencia acerca de endometriosis en tu país en los últimos 10 años?
¿Cómo creo que ha cambiado la conciencia? Pues la concientización en realidad ha venido en aumento por parte de AendoCR. En realidad, pues nos hemos encargado de dar bastante pues, información a través de medios, de redes sociales, en plazas públicas, compartimos mucho, tratamos de concientizar. Y también nosotros, pues como pacientes empoderadas, ¿verdad? Que AendoCR nos ha, pues, y pues preparado para eso, pues hemos dado un poco más de concientización, porque realmente yo fui diagnosticada hace más de 20 años y era una enfermedad, incluso todavía a algunas personas uno le dice que padezco de endometriosis y es endo qué, ¿verdad? No saben qué es la enfermedad, pero sí está un poco más conocida. Hay un poco más de concientización sobre la enfermedad, tanto en los familiares como en los allegados, por lo menos de las pacientes. Y ahí se va pues trasladando a los demás, ¿verdad?
Ok, muchas gracias. La segunda pregunta es, ¿cómo cree que está la disponibilidad de especialistas y cirujanos en endometriosis en tu país en este momento?
Uy, esa es una muy buena pregunta. En realidad tenemos muy pocos especialistas y la mayoría de especialistas que tenemos, que como le digo son muy pocos, están concentrados en el área metropolitana, o sea, en el centro en la capital, en el centro del país. Y las pacientes que viven pues en zonas alejadas es muy difícil pues, que tengan la atención debida porque no existen especialistas en la enfermedad, ¿verdad? En zonas alejadas.
Ok, muchas gracias. Y la tercera pregunta para ti, ¿crees que hay algún cambio en las pólizas o en educación acerca de esta enfermedad de endometriosis en tu respectivo país?
En las políticas. En las políticas no, estamos trabajando en eso, ¿verdad? EndoCR está trabajando pues en concientizar, en dar a conocer, en informar, en empoderar tanto a las pacientes como a sus allegados, ¿verdad? En este gobierno, casualmente el gobierno que tenemos actualmente, pues hemos recibido un poco más de apoyo, bueno, hemos recibido apoyo en realidad porque nosotros estamos trabajando en esto de eh, entregar la entrega de un medicamento para las pacientes con endometriosis. Y este gobierno pues nos ha respaldado mucho, bastante en realidad.
Ok, qué bueno escuchar eso. Y ya la última pregunta para ti sería si hay algún proyecto en el que están trabajando como equipo en este momento o algo que quieras darnos a saber.
Bueno, casualmente es este proyecto, el del medicamento para las pacientes con endometriosis, ¿verdad? Nosotros estamos trabajando, en realidad ya es una realidad. Ya, como le digo, el gobierno, este gobierno en curso, pues nos apoyó mucho y pues se ha dado la orden por medio del gobierno que sean pues las pacientes de endometriosis que así lo necesiten, pues beneficiarias de este medicamento. Sin embargo, es un proceso, ¿verdad? Como todo, ¿verdad? Lo que tiene que ver pues con un medicamento y con un padecimiento, sabemos que los organismos todos no son iguales, ¿verdad? Entonces, obviamente no es que porque yo diga que soy paciente de endometriosis, ya soy beneficiaria al medicamento como cualquier otro medicamento, digamos, pues más accesible. Es un proceso que lleva el poder adquirir el medicamento. Entonces, seguimos trabajando. Ya logramos que nos lo den, pero no a todas las pacientes se los han dado. Entonces es un proceso que seguimos trabajando, un proyecto que seguimos trabajando.
Muchas gracias, Nancy. Gracias por tu tiempo. ¿Alguna otra cosa que quieras añadir o nada más despedirte del video?
Muchas gracias a la organización. De verdad que estamos muy agradecidos desde el momento en que nos dimos cuenta que pues existía esta gran organización, ¿verdad? A nivel internacional y pues ser parte de EndoMarch cada año es un gran orgullo para nosotros como asociación y como pacientes, el alzar la voz, el que nos escuchen, el romper el silencio del padecimiento que es pues esta enfermedad, ¿verdad?
Ok, buenas tardes. Estoy aquí con Marianela y si gustas te puedes introducir y decirnos un poco de ti.
Buenas tardes, mi nombre es Marianela Rey Sánchez. Soy de Costa Rica y represento a la Asociación de Endometriosis.
Muchas gracias y vamos a ir a algunas preguntas que tenemos para ti. Con la primera, nada más es para saber cómo crees que ha cambiado la conciencia del endometriosis en tu país en los últimos 10 años.
Si bien es cierto que la endometriosis no es una enfermedad realmente muy conocida, nosotros sí nos hemos dado la tarea en los últimos años de concientizar a nivel nacional a todos los pacientes y no solo a pacientes, sino también a los familiares. Esto ha ayudado a que el impacto psicológico de las pacientes sea un poco menos. Hemos tenido nosotros en la asociación casos de pacientes que no aguantan el dolor y ver que hay mucha desinformación de la misma y pueden tacharnos de exageradas y de mil adjetivos más, que eso nos ha llevado a una depresión muy profunda y como todos sabemos la depresión es otra enfermedad que requiere una atención muy especial.
Ok, muchas gracias. La segunda pregunta para ti es que ¿cómo está la disponibilidad de especialistas y cirujanos en endometriosis en tu país?
Bueno, nosotros contamos con muy pocos especialistas y cirujanos que se dediquen especialmente a la endometriosis. A veces de personas, de ciudades muy alejadas a la capital, no cuentan con estos recursos y tienen que hacer viajes a veces de más de 5 horas para lograr tener apenas una cita. Y muchas veces esas citas han sido canceladas, han sido reprogramadas y no en días ni en meses, pueden ser que sea el año siguiente o hasta los años.
Muchas gracias. La tercera pregunta, ¿hay algún cambio que tú hayas visto en las pólizas o en la educación acerca del endometriosis en tu país?
No, no he visto ningún cambio en ninguna de las dos situaciones.
Ok. ¿No crees que ha cambiado en nada como en la educación? ¿No le están enseñando más o abriendo más pasos?
No, ha costado mucho. Bueno, de hecho nosotros como asociación dimos un gran paso, pero fue una lucha de mucho tiempo, de muchos años, en lograr que las pacientes les dieran un medicamento que había que comprar. El medicamento acá en Costa Rica rondaba entre los 16,000 colones a los 21. Muchas se los podían comprar un mes, al mes siguiente, ¿no? Y todo eso retrasa mucho el proceso de la endometriosis. Y bueno, nosotros logramos, la asociación logró que la Caja Costarricense del Seguro Social le pueda brindar este medicamento a las pacientes.
Muy bien. Y la última pregunta es, ¿hay algún proyecto en el que están trabajando como equipo en este momento?
Nosotros lo que sí trabajamos es continuamente y casi los 365 días del año es en seguir dando a conocer la asociación como ayuda a pacientes con endometriosis y en dar a conocer la asociación, los fines que nosotros tenemos. Bueno, la asociación es una asociación, valga la redundancia, sin fines de lucro. Por lo tanto, nosotros hacemos diversas campañas, ya sea con municipalidades, hacemos el EndoMarch, que es en todos los años, volantes con información acerca de esta enfermedad Tenemos chats que son para socias y chats para pacientes. Ambos están abiertos y pueden acceder tanto a información y también sirve para desahogo de las mismas pacientes.
Usted.
Como paciente de endometriosis, quiero pedirles el apoyo a todas nosotras, compañía, un abrazo, eso es suficiente. Yo con esto me despido. Mi nombre es Marianela Ley, pertenezco a la Asociación Costarricense de Endometriosis. Muchas gracias.
Ok, si gustas decirnos cómo te llamas y algo acerca de ti.
Bueno, mi nombre es María José Solano. Yo formo parte de la junta directiva de AENDO-CR y bueno, tengo 23 años, soy relativamente joven y bueno, he trabajado continuamente con ellos.
¿Qué país representas?
Costa Rica.
Costa Rica. Ok, y vamos a comenzar con las preguntas. Primera pregunta para ti es, ¿cómo crees que ha cambiado la conciencia acerca de endometriosis en tu país en los últimos 10 años?
Bueno, para nadie es un secreto que hoy por hoy todo el país es muy tecnológico y claro que se ha visualizado mucho la endometriosis. Por lo tanto, considero que actualmente el país ha estado muchísimo más informado acerca de lo que es la endometriosis, qué problemas produce, digamos, la enfermedad. Entonces, considero que hoy por hoy están muchísimo más informados que en los años anteriores.
Muchas gracias. Segunda pregunta es, ¿cómo crees que está la disponibilidad de especialistas y cirujanos en endometriosis en tu país?
Bueno, especialistas y cirujanos en Costa Rica son muy pocos aquellos médicos que se han especializado el 100% con endometriosis, incluso pues tal vez sí conocen de la enfermedad, pero no se han dedicado a estudiar profundamente lo que es la endometriosis. Por eso muchas personas que viven lejos han tenido que viajar incluso a la capital para poder ser atendidas de la mejor manera, incluso con costos muy elevados.
Ok, muchas gracias. Y tercera pregunta para ti. ¿Crees que hay algún cambio en las pólizas de seguro médico o educación acerca del endometriosis en Costa Rica?
En seguros no cambia nada, realmente no cambia nada. Como te dije anteriormente, muchas personas han tenido que viajar a lugares muy lejos para poder ser atendidos con un costo muy elevado. En educación, pues sí, en educación sí. Em, la enfermedad se ha visualizado, incluso muchas mujeres se han enterado de la enfermedad, eh, como te dije anteriormente al principio, porque muchas personas se han encargado por medio de las redes a visualizar la enfermedad, pero en seguros realmente no cambia nada.
Muy bien. Y última pregunta para ti, María. ¿Hay algún proyecto en el que están trabajando como equipo en este momento?
Claro, Endometriosis de Costa Rica, EndoCR, trabaja continuamente en entregar volantes. Hemos trabajado de la mano con las municipalidades de Costa Rica, que realmente nos han apoyado bastante. También estamos trabajando sobre la Visani. La Visani es un medicamento pues un poco costoso. Se ha trabajado continuamente con eso, se ha conversado con directores de hospitales y demás para poder y para poder entregar formularios a todas aquellas pacientes que lo necesitan.
Muy bien. ¿Y alguna otra cosa que quieras agregar o decirnos para despedirte?
No, de verdad que muchas gracias por habernos tomado en cuenta acerca de EndoMarch. De verdad que estamos muy agradecidos y no trabajar fuertemente para hacer más visible la enfermedad y para poder ayudar a todas aquellas mujeres que lo están necesitando.
Ok, muchas gracias.
Good morning and good noon, good day, good afternoon, good evening, and good night to all over the audience and listeners around the world. I would like to welcome all of you to our monthly meeting that we are resuming again for the year 2021. On behalf of myself and all the other co-founders of the worldwide EndoMarch, I wish you the greatest 2021. I wish this year is going to be much, much better than the last year, and I have no doubt that every one of you are going to have a much, much better year this year than the year past. And I wish you great health. These meetings, as you know, has been very successful around the world to raise awareness about endometriosis. This has been the goal of worldwide EndoMarch, to help young girls and women with endometriosis everywhere, to promote better health and raise awareness about endometriosis as much as possible, and hopefully find better ways to diagnose it and a way to prevent it, and hopefully a way to cure it. Worldwide EndoMarch is a completely charity foundation and is here to help you. You are welcome to participate in it in any way you want. It has an app, has created an app that you can download it for free and diagnose endometriosis very, very easily and completely for free. And if that would help your friends, your colleagues, everywhere. You can use it all around the world, and it would help you if you need to go and see a doctor or somebody to help you. And all the other previous sessions are also available online, that endometriosis of the reproductive organs, extragenital endometriosis, all of them, you can download them for free, and it is on YouTube. Endometriosis of the uterus, tubes, ovaries, bowel, bladder, ureter, diaphragm, lungs, liver, all of them. We have discussed it before, and it is available for you, and you can download it. For the next month, we are going to have another session, and the session is going to be about misunderstandings, myths about endometriosis, and we welcome you to understand what people think or say, which one of them are correct, which one of them are not correct about endometriosis. And that would be also of interest if you look at them. We are very, very lucky for this month. We have a very wonderful group of our patients and friends that they have had all endometriosis from their teenage years, and they have been dealing with this issue for years, and they have shared and volunteered to share their stories with you and help you how to deal with endometriosis. And we thank them immensely for participating. And also, you are welcome to send your questions. We have some of your questions. Doctors Fars, Sina, and Azad and Nijat, they are going to address it. And they have tried to combine all the questions in one place, and each of them are going to address it as we go along. And saying so, I welcome you again, and I wish all of you a great day. And I would give it to Lily. Lily Cooper is one of our former speakers, and also she has been a patient of ours, and she is going to introduce our other patients that they are going to be participating. Also, Dr. Far Nejad, Dr. Sina Nejad, they are going to introduce their own patients, and I would jump in and also whenever I wanted to give a comment and so on, address it. Thank you very much again. Ms. Lily?
Hi, everybody. So Jennifer's first. So hi, Jennifer. It's so nice to meet you. Being here.
Would you please speak louder, Lily?
Yes, absolutely. So how old were you when you started experiencing symptoms, and when were you first diagnosed?
So the first speaker is Jennifer, one of our patients. Welcome, Jennifer, and go ahead, please.
Hi, nice to meet you all. As I said, my name is Jenny Esch, and I first started experiencing symptoms of endometriosis when I was probably about 10 years old. I had intestinal issues, which then when I was about 13 grew into cramping very severely, where I had noticed it was more than just a regular problem. And it progressively grew over the years.
And when were you diagnosed?
I was not diagnosed until I was 21 years old.
Okay, wow. And how has endometriosis impacted your life, socially, academically?
So it affects a great many aspects of your life, because when you start dealing with chronic pain, it begins to feel very helpless when you go constantly try to get help to find relief for it, and you're unable to. And so you go from trying to exercise, eating healthy, trying yoga, different ways of life, sleeping it off, medication, and when nothing helps, I personally started to withdraw socially. So I went from being a very social person to kind of trying to avoid all social circumstances, because you never know when the pain is going to come up, and it's very intimidating. It's a struggle to deal with for sure. Academically, it definitely brought me from school, and I would stay homesick, and it was a challenge in college as well.
So what has been the biggest challenge you faced while dealing with endometriosis, pre or post diagnosis?
I would say that the biggest challenge for me would be, along with that chronic pain, I started to develop a severe depression. I was diagnosed with major depressive disorder, and I think a big part of that was dealing with that pain that was kind of covered up and not acknowledged and not confronted and not believed. And so it was a very hard time when you feel like you're at a loss and nobody can help you. So I think the depression, along with that pain, was the most challenging for me.
Yeah, absolutely. And what was it like for you to be in excruciating pain and told you were simply being dramatic and making it up?
It was very belittling, to be honest. You feel very small, and you actually begin to question yourself as well, because you're like, am I making this up? Is this in my head? And the minute you feel that pain, you're like, this is real. I know something is different inside of me. And until I met Dr. Najat, nobody could explain that to me. Nobody understood it well enough to be able to comprehend it and to believe me. So that was life-changing, to say the least.
Yeah. And the last question I have for you is, what advice would you give to other teenagers who might be going through the dismissal that you went through as a teenager?
I would say, first off, to download the app Dr. Najat came up with. And I would say, if you're experiencing those symptoms, to go to a specialist. I would reach out to Dr. Najat because it took so many years to diagnose for people who don't understand it and don't know how to approach the endometriosis as well. That if we would have known what we know now, then I mean, I could have gotten diagnosed and been out of that chronic pain years ago, because after the surgery, it's night and day difference, the way that I feel inside my body, my mentality, my everything. There's so much more hope knowing that it's real, knowing that there's a way out of it.
Well, I just like to thank you so much for sharing your story. You're so brave, and that was really helpful advice.
I'm sorry, Lily. Miss Lily, I am sorry, Jennifer and Lily. Lily, please you speak up higher because we don't hear you. I am sorry. It is better if you speak up much louder. And I want to give one comment here that Jennifer said that all the teenagers, young women, please, as we have said it for years, pain is not normal and it is not in your head. You need to be evaluated and be courageous like Jenny. Just seek advice and help is there for you. So I wanted to jump in and say that again. The app, you can see it. It is completely free. It is called Endometriosis. It is on the Worldwide Endometriosis website. You can easily go ahead and download it. Go ahead, please, Ms. Lillian, speak up, please.
Okay. So the next person I'm interviewing is Samantha.
Hello.
Hi.
Hi, Samantha. Samantha, thank you for being on the program. And Jennifer, thank you so much. Go ahead, Ms. Lily. Ask Samantha the question.
Okay. So thank you, Samantha, for being here. The first question I have is, how old were you when you started experiencing symptoms, and when were you diagnosed?
So at the age of 13, I started to experience gynecological problems. I was in very frequent pain and was struggling, especially when I was on my period. There were multiple times where the pain would actually lead to epileptic seizures and episodes, and I struggled with just constant pain. And at this point, all of my symptoms were brushed off and they weren't dealt with. I went to many doctors and no one could tell me what was going on. And finally, at 15, I went to see an OBGYN and she performed a hymenectomy. And the goal was to remove any excess tissue and alleviate pain vaginally. And that ended up being unsuccessful. It just grew back and I continued to be in the same chronic pain that I had been prior to my surgery. Years passed, and because of my other medical conditions, I was seeing a panel of specialists in Fresno, California. And it was my cardiologist from this team, Dr. Nair, who brought up the potential of endometriosis and transferred me to Dr. Najat. And she had a patient with the same conditions as me who went to see Dr. Najat and saw dramatic improvements. 75% of her symptoms disappeared after her laparoscopic surgery. So me and my mom jumped on this possibility and we wanted to do anything and everything that could help. And that's what led me to Dr. Najat.
That's great. Yeah. How has endometriosis impacted your life, socially, academically, and personally?
So endometriosis has impacted every aspect of my life, but I feel the most difficult has been the combination of my illnesses attacking my body at the same time. My peers and classmates would tell me that it was all in my head and make fun of me when I had to leave school or was in the nurse's office multiple times a week. I knew this wasn't true, but it always made me question if it was all in my head. I had never had the energy to get up or keep up with my friends socially, And even though that's something I so desperately wanted to do, I would often spiral into depression because I wasn't like the rest of my peers and had never met anyone else that was experiencing the same things that I was. But despite dealing with so much, I was able to maintain my grades, and I learned the importance of communication and being an advocate for myself. So it was a blessing in disguise to learn these things, and I know it will prepare me for my future.
That's great. So what has been the biggest challenge that you faced while dealing with endometriosis, pre or post diagnosis?
So the biggest challenge I faced while dealing with endometriosis is definitely the chronic pain that makes it so difficult in day-to-day life, as well as the fact that it's such an invisible illness. You would never look at someone and automatically assume that they have something wrong with them. Someone looking at me would just never know that I was sick or struggling with such a massive amount of pain on a day-to-day basis. And they often think that I'm lying if I tell them that I am sick. I've never heard this. I have heard this over and over again by people around me, even my closest friends. No one understands what I battle, and they have such high expectations for what I'm capable of, and not understanding that some things are much more difficult for me than the average person. Even after my surgery, my peers would still tell me it's in my head and have little to no empathy.
So what other illnesses do you have that accompany endometriosis?
So aside from endometriosis, I have interstitial cystitis, dysautonomia, and postural orthostatic tachycardiac syndrome. I have the MTHFR genetic mutation, and then the most recent one is CCM2 genetic disorder. I also have Rolandic epilepsy and ASD in my heart, and then I have reflux.
And what do you want people to know about endometriosis?
The biggest thing I want people to know about endometriosis is how it affects my body as a whole. Oftentimes, POTS and endometriosis are linked in women as estrogen plays a huge role in both disorders. There have been so many studies that I've found that if someone was diagnosed with one, they often have the other. And so if it weren't for my cardiologist, I would have no idea of endometriosis even being a possibility of an issue. I went years and years trying to figure out all of the different little things that were attacking my body and what we could do to help it. So I want to be an advocate for other women searching for answers, even post-surgery, if they're still feeling sick, and just lead them down a path of autoimmune issues that could also be the culprit, along with their endometriosis disorder. So if these things are more able to be commonly linked, it may be easier to get help and alleviate the extreme length of time and pain it typically takes to get diagnosed.
Thank you so much, Samantha, for sharing your story. It's so important for everyone to understand that diseases are so connected, especially with endometriosis, and that they can all coincide. So thank you.
Thank you.
Samantha, thank you very much for your contribution and your very well said story, and what it was said by Samantha again, and you can see, and for all of you, is that it is not in your head. And because endometriosis does not show on ultrasound or MRI, usually, and you cannot feel it or touch it, and the only way to diagnose it, the best way, is by looking inside of the abdomen by an expert. This is important because although all of the physicians are excellent, very, very good, but it has to be somebody who is dealing with endometriosis all the time, because it is not only adequate for a routine or person who is gradually and does a laparoscopy. That is not adequate. It has to be somebody who is dealing with it regularly and would help you. Because unfortunately, sometimes we see patients like Samantha or Jennifer, and then you will see the rest of the patients that they have been sometime in laparoscope and they had missed the endometriosis. They mean well, they have very good intentions, but endometriosis could have different variations that should be diagnosed by an expert. So thank you again. And now we proceed with Abby. Am I correct, Lily? Go ahead and ask questions from Abby.
So Abby.
Yes, I'm here. I just cannot
the host has stopped my video. So hopefully that can be fixed in just a second.
Oh, no. Okay.
Okay, so Zoe, let's get Abby on the video. Oh, here
Is
you
it,
are.
is it,
I'm here.
hi, this is Sina, Dr. Sina Nejad. Is it possible just give a brief introduction of each speaker, although we read their bio? Just briefly tell us who they are.
Yeah, it is my fault. I am sorry. I apologize. I have what we have decided. I have taken care of. So you will forgive me. So Jennifer and Samantha and Abby, they are my patients, and Gemma is your patient, and Hannah is my brother, Dr. Farnij's patient, and these are all extremely intelligent, educated, young women who have suffered from endometriosis from their teenage years. And they have undergone years of misdiagnosis or no diagnosis. And often these patients have been assumed that it is in their head. So now that is what we are dealing. And meanwhile, when they say their stories, I like you, Dr. Farnijad, Dr. Azadeh, and Dr. Sina Nejad. If you like to give a comment, please come in. I know Dr. Sina Nejad recently published a book all about endometriosis in teenage years. And I asked him later, he's going to address it himself and discuss about it. And that could be very helpful, those of you who want to read it also. So go ahead, and Lily is another patient of ours that she has been on this program before. And we thought to make it more comfortable, Lily is asking the questions from our patients, and you don't have to be very formal. You can, any way that you think you can help other of your colleagues, don't be shy to tell them. Now, go ahead and Lily ask Abby the questions.
Can I ask one question? I appreciate Dr. Azadeh Nejad say something about because you and Dr. Azadeh Nejad working in the same practice, and she's heavily involved with your practice and knows your patients. So if she has any points to address in the same time, I appreciate she does it.
Perfect. Is Dr. Azadeh Nejad on? Yeah,
yes. Hi. Sorry, had to print a question.
Yes, Dr. Azadeh, would you please sometimes, because you are in the same practice, and if in case have any opinion, express it, because also you're a woman, and also you have a different perspective of the women and the pain. I appreciate.
Of course, of course.
Yes, and also you have a teenage daughter, almost teenage daughter. So your point is very well important. Thank you, Dr. Farnijad, for bringing it up. So perhaps after Samantha, perhaps Dr. you can address some questions, or if you want, you have the question already, because you were assigned. There are so many questions in the same pattern that we combined it for you. If you address it, we appreciate it. After Samantha.
Sure. Of course.
Go ahead, please.
Who's going to
Lily, go ahead and ask Samantha her story.
Okay, so Abby. Hi, Abby. Welcome.
Oh, Abby, I'm sorry, Abby. Yes, Abby. Yes.
Okay. So, how old were you when you started experiencing symptoms, and when were you actually diagnosed?
So I was a unique case in that for a few years of my teenage life, I had amenorrhea, meaning I did not have a period. So some of my symptoms were definitely suppressed at that point. Once I got my cycles back and I started ovulating again, symptoms popped up around age 18 or so. And I was recently diagnosed, actually earlier this month. Dr. Cameron Najat performed my surgery the 7th of January. So I am now 22. So age 22 is when I got my official diagnosis.
So how has endometriosis impacted your life socially, academically, and personally? Although I know it's pretty new.
So I have a very similar story to some of what the other young women have already shared. It's hard to explain what you're experiencing to close friends or family. So it becomes kind of both the burden and opportunity of self-advocacy, figuring out how to identify what you're experiencing, put it into words, and also share that in a way that is constructive with the people who care about you, and figure out how to kind of create a path forward for yourself. In addition, dealing with the symptoms itself, fatigue, it impacts every aspect of your life. Pain, as other girls have mentioned, just kind of learning how to stay present and kind of breathe through those moments, both metaphorically and literally, is something that you kind of learn with time. And then kind of the fear and uncertainty of the whole thing, because it is so challenging to diagnose and it takes so long for it to be figured out. So it kind of infiltrates every aspect of your life as you figure out how to cope. But as has been mentioned, it also creates a big opportunity for growth.
Absolutely, yeah. So what has been, I guess, the biggest challenge you faced while dealing with endometriosis, pre or post-diagnosis?
I would say pre-diagnosis, it would be that, self-doubt and the challenge to my self-esteem, both just not, having full trust in my body and not having full trust in myself. You go on a wild goose chase search for answers. And when you're doing that and people are questioning you or unable to provide answers or hope, it starts to feel like a never-ending search with very little to no hope. I will say I was really lucky in that, my family has health insurance, and I had a mom who had endometriosis, and so I was familiar with the condition. Even with that knowledge, however, I was definitely shut down multiple times when suggesting, could it possibly be this? Or, my mother experienced this, my sister may also be experiencing this, could this be what's, plaguing me at this point? And so having those experiences and knowing that this was something I needed to pursue, and finding Dr. Najat, that's, I think, really lucky and unique among patients, because if you don't even know that it exists, there's no way for you to, be looking for it. So I had to deal with the self-doubt and the self-esteem issues, but I definitely had that blessing.
Yeah. And then as you very recently received your diagnosis and had your surgery this month, everything is very fresh. So can you share your experience about what it was like for you to have just found out that you have endometriosis after being told you couldn't have it due to your young age? As we all know, that is a misconception. And how do you feel fresh out of post-op?
I feel great fresh out of post-op. Every day I'm getting a little bit stronger. Obviously my symptoms are not completely eradicated, but I have far more hope, and I'm getting stronger every day. Having, just received my diagnosis, it's strange to be grateful for finding out that there's something that is wrong with you. But I do feel a great amount of relief and gratitude, because it's far better than the uncertainty that was coming before. And with that comes, gratitude for being in the right place at the right time and having the financial means to pursue kind of the treatment that was necessary. And also, a little bit of pride in my own ability to advocate for myself. And that's something I would hope that any young girl watching this, experiencing similar, symptoms, would know, that if there's something wrong and you feel there's something wrong with you, you're probably right. And it's perfectly wonderful to advocate for yourself, because you might,
be on the right path, even if you don't know it.
Absolutely. Well, thank you so much, Abby, for sharing your story. And I'm so glad that you're feeling better. And I wish you luck on the rest of your healing journey.
Thank you so much.
Abby, and thank you very much, Abby and Jennifer and Samantha. And please don't leave, because later we have some questions and we want all of you to address it. We appreciate it very much. And I asked Dr. Azadeh-Nejad that please, there is a question that we have many people have asked. And Dr. Azadeh-Nejad is our niece, and she is practicing with me. She's an excellent endometriosis specialist that she is in the OR with me, and we work together for the past many years, and it is a privilege to have her. Go ahead, Dr.
Good morning, everyone. So my question is, the question was addressed to me. It says, I suffered from endometriosis since I was 16. My daughter started her menses 1 year ago at the age of 13. Several months later, she began experiencing sharp shooting pain around her urethra while urinating, almost always on day 2 of her menses. She also experiences bad cramping and tries to manage the pain with Motrin. I grew up with severe pain. I would like to mitigate and troubleshoot my daughter's issue. She's only 14. I'm not sure what's the next step to determine if she has endo. So my answer to this question is, of course, we now know that the endometriosis has a familiar hereditary basis to it. The fact that you had endometriosis at early age, it makes the endometriosis very likely cause of her pain, your daughter's pain. So I would say the next step would be, there are many questions that a experienced physician would ask, or a pediatrician or pediatric gynecologist should ask your daughter, for your next visit, hopefully soon to them, is that did she have any, was there any a neonatal problem during your pregnancy or the time that she was born, first of all. Second of all, there are a lot of other things that they might recommend initially to try for her pain would be probably ibuprofen before her menses starts. Also, they may recommend birth control pill for periods of time to see if that would resolve her pain. But ultimately, the fact that you had endometriosis, it makes endometriosis very likely for your daughter's diagnosis. So those are the things. And you had asked, when would you be seeking help? I would say right now is a good time to start trying, because as Cameron said, Dr. Cameron said, it's not normal for adolescent girls or teenagers or to have this much of a pain. Pain that is not resolved by simply ibuprofen or some mild pain medications are not normal. And not every adolescent or teenage girls would have or does have pain with their period. So if you did the initial things and it does not resolve her pain, that by itself makes endometriosis a very likely cause.
Thank you very much, Dr. Azadeh-Nejad. I appreciate it. Thank you very much. Also, what it could help you, please go download the Nejad Endometriosis Advisor. It is a free app. Please download that. And if you see that app is suggestive of endometriosis, definitely seek help. Now, I will go to Dr. Sina Nejad he just published a book about endometriosis in teenagers, and with Gemma. Go ahead, Dr. Go ahead, Sina.
Well, thank you very much. I'm Sina Nejad from Atlanta. And actually, this is a very good timing considering all the stories you heard and the questions you heard. The endometriosis could be diagnosed even in the infants. So for the mother who asked the question, or a lot of patients, they ask, when should I suspect endometriosis? Whenever there is a symptom, there is suspicious. The book that we mentioned, it's the first time a book written on adolescent endometriosis. And this book is geared towards pediatricians, the therapists, nutritionists, and all the specialties, in addition to for the patient. And it is my pleasure to welcome Ms. Gemma Ziegler, who I've had the pleasure of being involved in her care and from early on. She wrote the chapter in the book, her story, that I call it the story of hope. And her mother, which I compliment because of her affection and awareness that she did not want the same thing happen to her daughter, and had early awareness about this possibility, also have written a chapter. So I encourage everybody to consider looking at that book. On that story, Gemma, I invited her to be here as a symbol of hope for all the teenagers. And I'd like her to come and tell you the story. Gemma?
Hi there. Thank you, Dr. Nejad. And thank you to all of the brothers for being such advocates for us as well, because we need it. You know, it's been an interesting journey, but like Dr. Nejad said, Dr. Sina Nejad said, my story is unique in that my mother dealt with endometriosis. And so I was being tracked from a very early age, from about age 11. And I started showing signs around then. And then at age 13, that was my first gynecological visit. And it wasn't until 16 that I had my first laparoscopic procedure, but it was, you know, it was tremendously challenging in a sense as well, because, you know, when you're young and you're, of course, like all these other girls, looking forward to the, you know, the frontier of your life, to know that you're going to have to deal with endometriosis for the rest of your life, it's going to be ongoing, and you're told that. So at first, at this young age, kind of feels like a death sentence, you know, a little bit. And I'm sure a lot of the ladies can relate to this. And so again, while I was so blessed to have Dr. Nejad there, and truly just so kind and loving, and really held my hand through the process, that was challenging. And to be in school and dealing with this and loving my friends, wanting to connect with boys, but wondering, am I going to deal with pain forever? Am I going to want to be intimate with a guy one day? You know, with girlfriends, them just not understanding. And so you're constantly kind of trying to will yourself up to hang out with your girlfriends, and, you know, and you're just not feeling it. So endometriosis really requires deep, deep, deep self-love, just like life does in general. But it really brings you back to this place of needing to reconnect to a place of deep self-love and a place of deep inner rest, which we're just not taught. And so I would say that what ultimately I was brought to was this real deep sense and deep awareness that as human beings, we're and I know this may sound a little boohoo, but it's just the truth. Whether it expresses through endometriosis or not, we're on a healing journey. And, for me, it's been my blessing ultimately, because I've really had to access some really deep, deep places inside of myself that have been very painful at times. But ultimately that's been, the blessing and the contribution. And Dr. Najat has been there the whole way, through this whole journey. So I'm very grateful.
So Gemma, thank you so much for sharing your story. And I'd just like to ask you some questions. So
Yeah.
what are the life lessons that endometriosis has taught you?
Yeah, like I said, sometimes things that feel like they're happening to us, it's really been about learning that things that are happening to us ultimately on some level are really happening for us. And so it gives us, for me at least, endometriosis was kind of about learning how to raise my own self up. I think for so long it felt like this was something that was happening to me. And learning how to live with something and to embrace it, like endometriosis, and integrate it as part of who you are. Compassion for myself. And again, there have been tons of physical symptoms that have accompanied it, but when you're learning how to live with something, you have to find the ways to manage it on the regular. And for me, again, while I am so grateful for the doctors, I've learned how to manage it without any kind of procedure and it's been many, many, many years now since I've had 2 surgeries. And so it's been many years, and I've found the way to manage myself and to regulate myself and find homeostasis kind of within my own body and within my own expression. And yeah.
So how did you reprogram yourself to stray away from the negatives of endometriosis and try and think positively and holistically? And how did you fully embrace endometriosis?
Sure. So, I think that when you try and think positively, you're just not going to. It's like, think positive, and you just do the exact opposite. So for me, many tools that came in for me. And again, it was not just one thing, but hypnotherapy was one of the many tools. My mother became a licensed hypnotherapist, and so that was one way and one tool, and learning how to work with myself on that level. Through, again, it's not the only solution. These are just ways to manage, and they kind of all came together to create this tapestry that led to the healing. Yoga, I became a certified yoga instructor, qigong, breath work, nutrition. I have discovered through many friends through time, many women, I've just made the observation, a lot of these women who deal with endometriosis are tremendously creative. I'm an actor, I sing, I write music, and I've discovered that a lot of times women, just an observation, who deal with endometriosis are these tremendously creative, beautiful women who either are feeling repressed and they don't express and release it in a healthy way. And so, of course, energy unexpressed is going to shoot back inward onto oneself. And if we don't deal with all that energy, which is life force, it's creative energy, it can wreak havoc in the body. And so that's another tool and another mode. Let me see if there's anything honestly, doing the deep inner work, the inner looking, the inner excavation. And again, it may sound woohoo, but doing the psychic surgery on ourselves, this laparoscopic blessing that we have this procedure. You know, you don't necessarily, it's non-invasive, and that's the same way that we need to, or for me at least, post first surgery, after my first surgery, my recovery was quite rough. If I'm honest, and going back to high school and dealing with that. So for my second surgery, I just decided never again. This is going to be, I will heal, and I will heal quickly. And I just got really serious about my healing and really went inward and found the way to access my own gifts as a, you know, as a healing artist for myself, which we all have. Just sometimes we're given a little bit more of a nudge into them.
Well, thank you so much, Gemma, for sharing your story. It's so interesting.
Thank you, Lily.
About all the ways to cope with endometriosis. So thank you.
Thank
Gemma,
you.
thank you very much, Gemma, for your
my pleasure.
Wonderful, nice story, and thank you for sharing your story. There's a lot of questions, or there are a lot of questions about the role of the hereditary, or the role of, is this endometriosis really hereditary or not, or what the situation is. And as I mentioned, there was a book exclusively written for endometriosis in teenagers that Gemma and her mother also contributed it. This is by Dr. Sina Nejat. And Dr. Sina Nejat, Sina, would you please address the role of mother and daughter or sisters, if you can, because there are many questions in this regard.
Absolutely. Well, as I mentioned, endometriosis is multifactorial, and we have addressed all these possibilities that could cause endometriosis, but definitely there is a hereditary component in it. So the awareness of the family history is important, and that's what I reemphasize, the role of the parents. It's not just the mother. I have had fathers who have investigated endometriosis, and they call me with their teenager or young children. I have had diagnosis of endometriosis at the age of 13. I have managed them to the point conceive, having children, and for some other reason, we've gone back and done surgery on them, and nothing has been as bad. So I know we have one more panelist that we like her to get involved, but as she's coming on, I'd like to address one question to all of the panelists. What is your advice to a 17, 18-year-old girl who has been diagnosed with endometriosis, and she comes and asks to have a hysterectomy and removal of her ovaries, and she wants to go to menopause? What would you tell this, knowing some of you who have been diagnosed 15, 16 years ago and still doing great? Please address this. As soon as the next panelist spoke, all of you please address this question to all of our patients.
Thank you very much, Dr. Sina Nejat. Dr. Far Nejat is going to introduce the next panelist, Hannah, and and after that, we would like all the panelists, Samantha, Jennifer, Gemma, Abby, that think about it, and all of you say that. Tell them, what is your advice for young teenagers or early 20s who come and beg you to remove their uterus and tubes and the ovaries because they have so much pain? That would be very insightful if you address them. Go ahead, Dr. Parmesan.
Thank you very much. Thank you very much, Hannah. I will ask Hannah herself to explain her story about her journey with endometriosis. But one thing that maybe about Hannah was different than the other panelists was that Hannah was diagnosed with endometriosis before she comes to me. She had had laparoscopy and and some hormonal therapy before, but unfortunately did not have adequate results. And so that was a little bit different. So Hannah, go ahead, please. Tell us your story.
Hi, thank you. Yes, I was diagnosed by Dr. Farnajah. I saw a specialist before him who diagnosed me when I was 17, and she said that I had endometriosis. So that's when I got my first surgery. I had a laparoscopic surgery, and she took out the lesions. And it was a hard recovery. I've never undergone anything like that before, and I just kept having pain. There was no sign of anything getting better. And she just said it takes time, it'll get better. And that's what many doctors have always told me. And I just didn't see the light at the end of the tunnel pretty much. And I wasn't until 2 years later that I found Dr. Najah, and he was able to perform another surgery. So I've had 2 surgeries, and I have been pain-free ever since. And that was this past summer. So that was great.
So how old were you when you started experiencing the symptoms, and when were you diagnosed acne?
So I first started experiencing symptoms when I was 13 years old, when I first got my period. And it wasn't until I was 17 when I was actually diagnosed.
Okay. And how has endometriosis impacted your life, socially, academically, and personally?
So throughout high school and even my first few years of college was really hard. All of my friends would always want to go out and do stuff, and I just kind of had to push through because I didn't want to be that odd girl out. Why isn't she doing anything? Why is she just staying at home all the time? Does she just not want to hang out? Is this even real? Just kind of wanted to keep up with everyone and do what everyone else was doing. And I played a lot of sports in high school, and I would have to stay home from school or have to stay at home and not be able to do any of the sports because I was always in so much pain. I'd miss out on the games and the practices, and it was hard because everyone was bonding and becoming friends, and I was just at home. I couldn't push through the pain. And my dad and my mom would have to pick me up from school because I just couldn't sit there for 8 hours a day, just sitting there in pain. And it was just so hard not being able to do what every other teenage girl wanted to do.
Yeah, absolutely. And what has been the biggest challenge that you've faced while dealing with endometriosis pre or post diagnosis?
I think my biggest challenge was probably just being dismissed for so many years. I saw multiple OBGYNs saying that I was having so much pain, and they just put me on birth control. They're like, "Oh, it's normal. You're just one of those girls who gets bad cramps. It'll go away. Just put me on birth control." And I believed them, they're the doctors. I believed them. And I saw multiple OBGYNs, and they just kept saying the same thing. And I think just not getting the answer I wanted for so many years was definitely a really big challenge.
Yeah. And what are a few things that you found helpful along your endometriosis journey?
What was really helpful for me was keeping track of my pain. I know that Dr. Farnajah always enjoyed seeing my little log of everything that went on, because for me, since I was in pain every day, it just blended together. I honestly stopped keeping track of it. And he would ask, "When was the last time you're in pain?" And I was like, "I don't even know." It just blends together for me. And I'm sure a lot of other young women can relate to that as well. And it's helpful to not only me to look back on it and see when I was in pain, but for the doctors as well to keep track of your periods, pain, and even if you want to keep track of what you eat too is also super helpful, because there could be a flare up for some type of food. So that was definitely something that really helped me and Dr. Farr as well, to see when I was in pain and what caused the pain.
Thank you for sharing that. So what were you told before finally being diagnosed, and what do you wish that you knew?
Before I was diagnosed, I was just told that I had painful periods, and that was it, and that would go away. I wish that I knew what endometriosis was. I had no idea what it was till I was diagnosed at 17. I wish I knew what it was so that I could do research and be able to advocate for myself more on that. I wish I knew that I had a retroverted uterus. Dr. Farnajah was the one who first told me that. I didn't know I had that, and that was a big cause of my back pain. I had not only bad cramps, but really bad back pain, and all the doctors that I saw never mentioned that to me, which could have been really helpful to know that I'm not going crazy. I have bad back pain, and that was the reason why. So those are definitely things that I wish that I knew.
Well, thank you so much, Hannah, for sharing your story.
Thank you.
Hannah, thank you very much. I'd like to thank Hannah, Gemma, Samantha, Abby, and Jennifer once more. And I tell you that these are all stories of hope for all of you who are watching, and see that they are sharing their story to let you know that if you have pain and it is not in your head, you need to be evaluated, as we have been saying it for years and years. Endometriosis is a whole body disease. It could attract or be involving multiple different organs of your body. So you need to be seen and evaluated. And we are, or all the patients, we are getting, the technology has been very, very helpful, and we are in a better time. Years ago, it was impossible. For many, many years, all young women like yourself would go through a lot of more doubt even, and they would end up with large masses, sometimes very bad emergencies. But since the introduction of the video-assisted endoscopic surgery, the revolution of surgery, it has significantly helped young women like yourself, and the technology is improving more and more with all the, for example, different methods of photodynamics, augmented reality, 3D vision, all of them that they are on the horizon or more and more coming to the picture. We can make the diagnosis of endometriosis even easier and hopefully better treatment. So this was again one of the questions, that how augmented reality or other high technology could help endometriosis, the same way that suddenly before we had to make very, very large incisions after it was an emergency, and video-assisted endoscopic surgery has revolutionized the whole discipline of surgery, and especially for endometriosis. You can look at every small little space in the body from the head to toe and see if there is endometriosis. The same thing is with other technology that are coming in, robotics, augmented reality, photodynamics, and computing technology that are going to make it even better and easier. So now we like to see if there is any questions that, or anything that Dr. Farr, Dr. Sina, and Dr. Azadeh want to address. If not, we would like the panel, and we will start with any of them. Please jump in. How would you deal? What do you tell to a young woman who comes to you as a friend and asks you, hey, Jennifer, hey, Abby, hey, Gemma, hey, Hannah, and what, she wants to have hysterectomy and remove her ovaries removed. What do you say to them? Let's start, Gemma, we'll start with you.
Yeah, you say, my love, I completely understand, and I know how it feels. So you're not alone. Let's start there. I'll hold your hand. Give me a ring. I'll be a good friend for you, and we can talk through this. I mean, having a hysterectomy, a total hysterectomy, is extremely extreme, and I know that the pain that you're feeling is on the level that you would want to have that, but I what I would say would be pretty deep, and I would just want to talk to that person directly and hold space for them, and work through this with them as a friend, because I would not want to deny that person's pain and their suffering, but I would also, that's really crucial and important, but I would also, want to say that there is hope, and that there is a way, and that I mean, I'm not a doctor, I'm not the doctors, but I don't know that that needs to be the way for you. Yeah, I can't give medical advice, but I would be happy to share with you one-on-one and, you know, work with you as and let you, you know, walk with you through this.
So Gemma, I know this thought crossed your mind often, and you have been able to deal with it, manage it. Looking back, aren't you happy you made that decision, or you wish you had it done and be done with it?
Oh, no. I'm very grateful that I chose that we chose to have the laparoscopic procedure, you know, with you, and then of course also to learn how to manage life. You know, like I said, I think culturally, our culture, and one of the other ladies, it may have been Abby, was talking about, you know, wanting to push yourself to do these certain things. And there's just a way of operating in our culture, and we're moving so quick. But there's another way to be where we can still be in the world and really active and engaged in the world and don't have to feel like we're missing out. And we can, at the same time, tune in with our bodies and find a new way, and then help others find this, you know, this way. And again, I know I'm speaking kind of abstractly, but I have no regrets, because what my path has brought me to, and working through endometriosis in the way that I have, is really, it's like lifestyle. It's learning how to live, and it's finding a lifestyle that works for me and in the world. I'm super dynamic. I've an exciting life, and you can have that too. You know, it's not a death sentence. You just have to find the way to make it yours and your path, and you can do that. You don't need to just cut it. It's like cutting your arm off. If you cut your arm off, now you're left without an arm. You know, there's a way that we can, it's like a part of your body that's screaming, that's, you know, wanting to be heard. And we don't just cut this out. You know, we don't just, you know, we need to listen to that part of ourselves in a really honest way. And sometimes it takes us getting really quiet within ourselves. And even though it's screaming with the pain, I know it's like screaming profoundly and you just want it out. But, you know, and the opportunity is for integration. And I know it's not, you know, I know it's hell. I really do.
Thank you
You're
very
not
much.
alone.
Thank you very much, Gemma. Because there's so much interest, traditionally we usually stop at 10 o'clock, but because there are so many interests and so many people even joining now, we will continue for another 15 minutes perhaps. And I wanted to ask the same question from Lily. Lily is, she would be excellent person to also answer that question. Lily, please.
So if someone came to me and said that they were in so much pain and wanted hysterectomy, I would first make sure that they knew that the pain was real. I would say that I understood why they wanted the hysterectomy. I've been there. I've wanted everything out just so I couldn't be in pain. But I would also, with my knowledge of endometriosis, tell them that hysterectomy is not a cure to endometriosis, that it helps adenomyosis, but it is not for endometriosis. I think I try to educate them with everything I knew about endometriosis. The gold standard for endometriosis is laparoscopic surgery. So I guess I would recommend to them that they do have laparoscopic surgery and get taken out the parts that are adhesions or cysts or things that are hurting them, but not necessarily the hysterectomy. You know, you can have that later in life, or if you have adenomyosis, which you can figure out. And then there was something about menopause possibly in that question. And that is an option for some people. It does help some people with their pain and help suppress the endometriosis from growing for some people, but it really depends on case to case. So it would definitely refer to a specialist and see what they have to say. But just like acknowledge that their pain is real, not in their head, and that there's hope and options for them.
Thank you very much, Lily. All of the audience, we just want to realize that these are all discussions. Nobody is giving specifically opinion that how you should be treated before you be examined by a physician. And it is realized, it is very important that removing of the ovaries in a young age, it has to be done when there is an order from God or an act of Congress. Because if you remove the ovaries, there is going to be a lifelong side effects of problems with the heart, with the bones, with the emotions, a risk of dying earlier. So that is a very, very serious issue, that removing the ovaries. Even if you save the ovaries and remove the uterus, simply removing the uterus increases the chance of a young person, a woman going through menopause, earlier menopause, and lack of hormones, especially estrogen in women, has been associated with more heart disease, bone problems, and other issues, cognitive problems with the Alzheimer's, etc. So it should be avoided at all costs, removing of the ovaries. So any of the, I know Tiffany wants to ask questions from the panel. Tiffany, go ahead and ask questions. And if the other members of the panel want to say something about this, please jump in.
Thank you. And just to piggyback on what you were just talking about, I actually am someone who has had a hysterectomy. I had my uterus out from endo at 29 years old. And then I had my ovaries out years later. And it definitely did, challenge a lot of my health issues, having that done so young. Definitely increased a lot of other things going on with my body. So I 100% agree with everything you said. And I was one of those girls at a young age that was told, oh, maybe you should just get everything out because of the pain that you're in. And, it's a very big decision. So I just to agree with that. But my question for all the girls is, or women, young women, I should say, have any of you at any time heard about endometriosis or were educated on it in either health class or by a nurse or by anything in school at any time, like when they're teaching about menstrual cycles and things like that? Have any of you ever learned anything? No, I'm seeing a lot of head shaking. No one ever has. Okay, I mean, I thought that would probably be your answer, but this is something that part of what the Worldwide EndoMarch does is we're trying to get more education in schools so that young girls could know about it a little bit sooner. So I was just curious, since you're all from different areas, if any of you ever learned anything about it. So thank you for sharing that.
I think I was the one educating my friends, and I'm sure all these ladies, once they found out, is the same thing,
Right, absolutely. Thank you.
So Abby, do you have any questions? Do you want to say anything, Abby?
I think just to reiterate what so many people have said, like there really is hope. The doctors here and the women here are great examples of that. And I think what the Worldwide EndoMarch is doing is also on the path towards hope. Awareness is key. Trusting yourself is key. Just learning how to be with yourself and be with this new reality if you are diagnosed with endo, or even before. It's a personal process, it's a physical process, it's a mental process, and it comes with a great training in patience, which is not exactly something that comes easily in a very fast-paced American culture that wants everyone to be strong all the time and ready to go, and 9 to 5 and all of the things. But there are ways to move forward and be authentic to yourself and true to your experience. And I think this is a really great example of a good place to start.
Thank you, Abby. How about you, Jennifer?
How about me? In what way?
Do you have anything to add, or would you advise a young woman who is coming to you as a friend? She says she wants to have her uterus or ovaries removed. What would you tell her?
So I feel I had maybe a different experience than some of you, and very similar in other ways. But when I had 2 prior surgeries before, and I had no help, no relief from the pain from those surgeries before I met Dr. Najat. And the second surgery, the doctor said there's endometriosis wrapped around one of your ovaries so tightly that I was scared I was gonna sever some of your bowels and other organs if I went in and got it, so I didn't take it. But I think you're too young to have your ovary taken out, and I won't do it. And I was in excruciating pain, and it had got to the point where I was in tears and laying in bed more often than not. It was a very challenging place to be. It definitely makes you go into your deep inner self and figure out who you are and what speaks to you in life, what makes sense, what matters. And I, with my last bit of hope I had in me, I went and searched and found Dr. Najat. And when he went in for surgery, I expressed very severely to him beforehand. I said, please, if you are in there and you think that my ovary is past saving, just take it, because I can't deal with this pain mentally anymore. I'm struggling, and I feel like I'm at the end of my rope. I feel like I'm hopeless. I don't feel like anybody can understand it. And now I'm seeing this community of people who absolutely understand it, and we're not alone. But he went in there, and after the surgery, I woke up and he goes, we did end up taking the ovary. The adhesions in my endometriosis had attached to that ovary and that fallopian tube like glue. He said when they went in there, he compared it to a cement block, which in my case, I begged to have it out, and I would go and I would do it again. And if I could have done that the very first surgery, that was my scenario. But everybody has their own scenario. And just as Lily was saying, I would tell that person your pain is real. And if a doctor or a medical professional is making you question that, you need to find a specialist. You need to find somebody who's going to listen to you and not make you question who you are, what you're feeling, because who are they to tell you that you're not feeling something when you're very aware and it's very much affecting your life that it is. So I would tell them to, as all of you wonderful ladies have said today, be your own advocate, and don't allow that to make you question yourself in a sense that you don't stand up for yourself. Use that as motivation to stand up for yourself, to raise that self-esteem and go, this is what I'm feeling. This is what I believe. I am worth fighting for. I am worth finding out if there are different life choices I can make that are going to make this better, if a laparoscopic surgery is the best decision for me. But you are worth doing that, and it's worth reaching out to a community like this so that you don't feel alone, because that sense of aloneness is so bewildering, and it's hard as a teenager. And people always say, well, girls are dramatic as it is. So being a teenager complaining about cramps, you're overlooked time and time again. That it really is a beautiful thing to look around and see that we do have support and we can raise awareness for something that's hurting so many of our women in the world, and that there is hope to give them.
Thank you very much. And specifically, that is what I wanted to ask you, because you need an expert. We are not giving you generalized information, and every patient has to be evaluated individually. We are saying that save the ovaries, the uterus, but sometimes endometriosis, unfortunately, is so bad, so advanced, so severe that just like in Jennifer's case, that could have caused problem even for the ureter and the kidney. When it is causing like that and could compromise the function of the ovary, the function of the kidney or the bowel at some time, and invades to it, we have no choice. So that is why you should see an expert to evaluate it. And if there's any way possible to save it, then you save it. But if not, unfortunately, sometimes you have to have that organ removed to save the other organs or to save the quality of the life. So that brings me to the fact that, again, every single patient has to be evaluated by an expert. Hope is there. Things are getting better and better. Endometriosis awareness is increasing all over the world. Since the introduction of the worldwide EndoMarch almost 8 years ago, you will see many, many support groups all across the globe. Even medical societies are dedicating a portion of their time in the month of March for endometriosis. We are all proud of the accomplishment globally that you are doing. Women, just like all the participants today that participated, and they share their story, and we thank them. For the next month, we are going to talk about some misunderstandings, some wrong ideas about endometriosis, and we are looking forward to be with you. And I'd like to thank all of the panelists one by one, and also all of you who listen. And I wish you great health and happiness, and we will see you next month. Bye-bye.
Karen, I'm sorry. There was one question was very important that had asked me to address it. There was a woman had asked that she has 2 teenager daughters that have pain and was concerned about endometriosis. I didn't want to not address that question. Definitely, we recommend your daughters to be evaluated by an expert in endometriosis, no matter how old they are. The youngest patient that we have seen is 9 years old with endometriosis. So please take your 2 daughters, the teenagers, to an endometriosis specialist to be evaluated to be sure there is no abnormalities. Thank you.
Well, thank you very much. Yes, I'm sorry I forgot that you had that question to answer. But thank you very much again, and have a wonderful, wonderful Saturday and Sunday. Bye-bye.
Bye-bye. Thank you. Thank you, everybody.
This surgical case presentation is titled Robotic Assisted Laparoscopic Resection of Rectovaginal Clear Cell Carcinoma Mass Arising from Endometriosis. Introduction. Throughout the literature, there is increasing evidence indicating a malignant transformation of ovarian and non-ovarian endometriosis into mainly endometrioid and clear cell carcinoma histologies. Patients with known or suspected history of endometriosis that present with suspicious symptoms such as change in bleeding patterns, physical exam findings, or imaging studies should be further evaluated to rule out malignancy. Here, we briefly review our patient's history and surgical case, as cancer arising from endometriosis can be elusive. Methods. This is a surgical case report involving a single patient. The practice involves a single provider that has extensive experience in the treatment of endometriosis, GYN oncology, and malignancy arising from endometriosis. We will review the surgical technique and why a robotic approach, if available, is preferred. Patient case. This is a 50-year-old G0 with long history of endometriosis that presented to our office 2 months, status post a robotic total laparoscopic hysterectomy, bilateral salpingo oophorectomy with vaginal bleeding. Procedure originally done at outside facility for pelvic mass with suspicion for malignancy. All records were reviewed. Procedure was uncomplicated. Pathology was benign. Patient had a GYN history significant for prior laparoscopic treatment of endometriosis. She also had a trial of oral birth control pills, GnRH agonists and antagonists without success. Besides endometriosis, she had a BMI of 45 and supraventricular tachycardia, and currently was on a GnRH antagonist as well as atenolol. Physical exam done in our office was notable for friable tissue at the vaginal cuff, and biopsy was performed. A solid mass was palpated at the vaginal cuff as well as on rectovaginal examination. Mass was non-tender and non-mobile. In-office sonogram images are displayed showing complex cystic lesion. Outside facility MRI showing a complex cystic and solid lesion at the vaginal cuff. Palmer's point was used to insufflate the abdomen due to prior operative report noting significant adhesions. Upon entry into the abdomen, exploratory laparoscopy revealed no evidence of intraperitoneal metastasis. The surface of the diaphragm, liver, and stomach were completely normal. Pelvic washings were performed. The pelvis had evidence from recent surgery, status post hysterectomy, and BSO. However, rectosigmoid colon was severely attached to the back of the vagina and the bladder, as well as to the left pelvic sidewall. Before docking the robot, cystoscopy was performed. Bilateral ureteral catheters were then placed. Indocyanine green was placed in each catheter so that Firefly method could be used to identify bilateral ureters during the surgery. Extensive adhesiolysis was performed. The rectosigmoid colon was mobilized. Care was taken to identify the ureter all the way from the pelvic brim to the back of the bladder. Firefly was used consistently to identify the ureter to avoid any damage. The right pelvic sidewall was then dissected, as well as the pararectal area, to identify the right ureter. Again, Firefly method was used to avoid damage to the right ureter. The mass was identified below the uterosacral ligaments at the level of the levator ani muscle. Frozen section of the mass was sent to pathology, which confirmed malignancy. The mass was then completely resected from the wall of the pelvis and off of the surface of the rectum. During extensive dissection, assistant performed rectovaginal examination and used EE Acizer to avoid injury. With the aid of the surgical assistants, partial vaginectomy was performed to remove the mass that was inside of the vaginal wall. Care was taken to remove areas of all diseased tissue to have adequate margins. All specimens that were removed were placed inside of a laparoscopic bag and removed from the vagina. Extensive vaginal irrigation was performed. Next, the ureter was identified, and the vagina was repaired using a 2-0 V-lock suture in a running fashion. After completion of vaginal repair, cystoscopy was performed. Adequate flow was noted from both ureters and no injuries to the bladder. There was a suspicious lesion found on the rectosigmoid colon and was resected with the shaving technique as shown here. Upon further evaluation, there was a suspicious lesion found on the appendix and on the ileocecum, which was also resected. The patient tolerated the procedure well, with an estimated blood loss of 150 cc's. Pathology results were significant for the vaginal area and vaginal cuff with clear cell carcinoma with negative margins, the ileocecal area and appendix, showing endometriosis and atypical glands that were suspicious for malignancy. Multidisciplinary planning recommended systemic chemotherapy with carbotaxol, followed by whole pelvic and vaginal brachytherapy. 6 months after patient's debulking surgery, she was seen in the office and was doing well with no evidence of disease. Management of patients with cancer arising from endometriosis can be challenging. Patients with endometriosis should be evaluated for malignancy with suspicious imaging findings. Optimal surgical reduction followed by adjuvant chemotherapy and/or radiation is the current treatment recommendation. Robotic-assisted laparoscopy is feasible and may be preferable for debulking or resection of complex masses in the rectovaginal space, especially in obese patients.
Hi, my name is Roya Tagavi,
And my name is Gerard Polian.
and we're Worldwide EndoMarch Headquarters volunteers. Here today with the EndoMarch representative of Team Vietnam, Ha. Once again, it's very nice to meet you, and thank you for taking the time to answer some questions today. Just to start off, how did you become involved with EndoMarch?
Nice to meet you. My name is Ta. So first of all, I know about EndoMarch because I know Surita, the team leader of My Endo in Malaysia. And then I talked to her and she introduced me about EndoMarch worldwide, how it is established and how it works. So I'm really interested in joining the EndoMarch worldwide so that Vietnamese patients can have updated knowledge about the disease and have an interact with the global patients community and doctors.
No, that's amazing. We always want to spread our team and increase our membership. So we're happy that you want to spread the word in your area, and you guys are doing and I know you guys must be doing a very, very good job. I actually wanted to ask you if you could tell us about any specific events in Vietnam that have been successful with the public.
Actually, in Vietnam, we have a group of 8,000 patients. It's like a Facebook group, so that we often discuss about how we treat the disease. It's not, like an event that we organize, for example, in a place and then everybody talk about endometriosis. It's just like a public group, online public group. But everybody talk about that, and then we have chance to discuss about it. We also have a smaller group of people, including me, another admin group of the Facebook, and then we contact with the doctor who are like the leader specialists in Vietnam, who often treat endometriosis patients, and then they will join the program, or they will ask us to join their program to talk about the disease on the television. That's how it works. And I might appear in the next healthcare program in a month to talk about My Endo Vietnam, if this program success.
That's very cool. So Who are you could you tell us a little more about this program? Is it aired on TV?
Yes, it will be aired on TV.
Okay, that's very cool. So in your opinion, is it currently easy or is it difficult to find an endometriosis specialist in Vietnam in your area?
I must say that we have many hospitals around the city because I live in Hanoi, in the capital of Vietnam. But I also live and work, like previously, I also live in the south of Vietnam, another big city like Ho Chi Minh City. And then most of the time I live in Hanoi. But I think that it's not so easy for patients, in other areas of Vietnam, in other parts of Vietnam. Vietnam has 64 provinces. And I know that among the provinces, there are so many adenomyosis patients. For me, I work here, and when I was diagnosed with the disease, I was in Hanoi. At that time, it was clearly to the doctors that I have adenomyosis because of chocolate cyst. But if the patients, they live in other areas of Vietnam, and maybe they just have, like the pain in their belly, they just diagnose it as okay, you have belly pain, a normal pain from the period. It's not exactly the adenomyosis. Meanwhile, I know that it also takes a very long time, like 7 or 10 years, for a woman to know that they have the disease inside them. So I think,
go ahead.
Yeah, I think that it might be a bit easier for how can I say, women in the big city to access to the healthcare service here. But to say that to find the experienced doctor with adenomyosis, there are only maybe just some doctors here in the whole country, not really like we have a big team or
Right.
You previously talked about this Facebook community with over 8,000 people. What are some common topics you hear this community talk about?
Yeah. Apart from this 8,000 community Facebook, I also have another 13,000 Facebook community where people often talk about like how to treat the disease, or they often, like complain about the disease. They also shared about the doctor talk about the disease, and they share, like in Vietnam, because in order to use the medicines, they do not need to go to the doctor. They can go directly to the pharmacy store to buy the medicines. So they just need to go directly to the store once they know the name of the medicines. It's a bit unsafety like that. So they even shared about the kind of medicines they use in those groups. And because of that, I think that is very risky for the patients, because every kind of medicine has like side effects. So I want to have, I want to create a group of patients that has knowledge about the disease. I know that it is uncurable now, but I wanted to let them know that there are other scientific ways or more healthier way to kill the disease, not to use, like every way to destroy the body.
Right, absolutely. Of course, like we need to increase knowledge across across Vietnam and just everywhere in general. But with that said, you can't just jump to conclusions based off just what others are saying, and every medication affects everyone differently, and people need to be consulted by specialists in their fields, in the field of endometriosis. So hopefully there will be a time where it's easier to access. I wanted to ask, in your opinion, what changes do you think are still necessary to aid in furthering public knowledge about endometriosis? What can we change?
I think that First, the labor law of every country, because I'm a person who works in the legal field. So I think that, for example, nowadays in Vietnam, women can take a half day for their period if they are so sick. But for example, for endometriosis patients, like especially for those with severe symptoms, they even takes like maybe half month or a week or 3 to 5 days just to lie down in their bed because they're so painful. So I think that first the law should be changed. Once the laws is changed, so people will raise the awareness about their rights and they know about it well. But it's very hard because I know that is the story of the National Assembly or the national policies. So it's not easy to persuade all the lawmakers to change their law. It's not so easy. That's the first thing. The second thing, I think that now we have so many, like social media platforms. We can spread the knowledge to the people, like, okay, EndoMarch worldwide, you have a very rich source of knowledge to spread it to the patients. But for example, here in Vietnam, English is the second language. So for example, even if I interact with EndoMarch worldwide, I still have to translate those things to Vietnamese patients, especially who don't speak English, so that they can know that, okay, here and there, they have the doctor, they have the techniques, they have the skills to treat the disease. How did they do that? They need to know about that. So I think that those are the two things we should do to spread to the world that, and let them know that there is one disease called adenomyosis or endometriosis, and they really affected people health, so that everybody can, like sympathize with the disease, with the patients, and then understand what the disease is, and can give, like community or personal support to that kind of person.
Right. I think.
I definitely. Also, I definitely agree in the sense that we definitely need to, by establishing these policies that you're talking about, we'd be able to, you'd be able to educate the public in Vietnam and bring the knowledge of endometriosis to those who are completely unaware of the condition. And as you already know, it's not only do we have to educate the adult and older age group of the population, we also have to work with the younger population in the world. So when you do establish a big team and you're able to outreach to more people, how do you see your team bringing this disease to the forefront of the younger population's minds?
To the younger population mind, first, I still use the Facebook, like as the main social platform in Vietnam, because, like even me myself, I'm just 13 years old right now. So when I have the disease, I just start to type like, what is adenomyosis, what is endometriosis in Vietnamese first. But at that time, like there was no source of knowledge about the disease, and I cannot use it, and I have to read them in English and then in Chinese and then in other language so that I can understand what is it and how to cure it. It's like that. So I think that the first way to approach the younger population is through the social media, and the second way, maybe I can approach the like the school program, like in their extracurricular activities. I might approach the president of the university or the teachers, just to let them know that there's one program called EndoMarch, where people can raise their awareness about the healthcare issues of the younger girls, because this really affects them, right?
Mm-hmm. Yep, absolutely.
Definitely.
I think, like you said, it seems from my understanding, Facebook is a big thing in Vietnam, and you are spreading awareness through that platform, which is great. And I was going to say, yeah, the younger population, they're heavy on social media. So
Yes.
utilizing social media as a really great target for that audience. And it's a great preventative measure too, because education is really important in the younger population who may have not been affected by endometriosis yet, or maybe they are and they just don't know. Back to national policy and laws. Are you aware of any any national policies or laws being worked on to further further maybe education of endometriosis or bring about awareness for endometriosis?
No, because even the name of the disease is still new here. Not so many people know it until they have it, you know. Like you have a disease and then you go to the doctor and then doctor tell you that, oh, you have these patients, you have this disease, you should go home and then drink some medicines or birth prevention pills until your period gone, or it's just like that. And then they just hold the pain and they ask everywhere, like, how can I treat this? Why nobody knows how to treat this? Because they also go to the doctor and then they go home with the hopeless feeling that there's no way to cure it. Because I myself was facing that situation when I went to the hospital. So I think that there should be some kind of general knowledge so that we can have a peer support system, like, okay, I have the disease, and then I can tell you like how to help yourself with the pain during your period, who to approach with if you have severe symptoms, who are the best doctors in the country you can find. Because I think that even in United States, it's not easy to find an experienced doctor who is a surgeon in terms of endometriosis or adenomyosis, right?
Yeah.
The same here. Like it's not easy to. You can go to the doctor and then you said that I have this disease, but to tell them like, may I have an experienced doctor, because I also experienced with an unexperienced doctor. He tried to, like cut my adenomyosis, but from that small surgery, my pain level increased since that day until now. So I think that without the general knowledge, the public or even the individual patients might get the worst situation like me in the future.
Right. I'm so sorry to hear about your what happened and your surgery outcome. I'm really sorry to hear about that. And I agree, it's very hard. It's very difficult to seek out an endometriosis specialist, not just in the United States, but everywhere, like you said, Vietnam. Thank you again, Ha, for joining us today and answering all our questions. And we can't wait to see what Team Vietnam continues to accomplish. But before we end here, I just wanted to see if you would like to share anything else, any last words.
I hope that I can learn a lot from the US team and the global team about the updated knowledge of endometriosis. And then I can share it with the Vietnamese community about how it is developed. And I also can raise awareness for younger girls here about the patients so that they can protect themselves. That's what I really hope when I spend my time voluntarily joining the program, both in Vietnam and with you guys.
100%. And thank you so much for your time. We cannot wait to hear about all your amazing impacts you're going to have on policy, with public education, with decreasing the diagnosis time. We know that everybody in your team will fight endometriosis with 100% of their power. Thank you so much.
Thank you. Have a great rest of your day.
Yeah, thank you so much, Roger and Jera.
All
Yeah,
right.
okay.
Bye.
In this video presentation, we demonstrate robotic-assisted laparoscopic tumor debulking for an unusual case of metastatic mesonephric-like carcinoma of endometrium. Patient is a 60-year-old woman with past medical history of endometriosis and uterine fibroid, which in the past has undergone bilateral salpingo-oophorectomy and treatment of pelvic endometriosis in 2016. She was treated for pelvic pain and postmenopausal bleeding, and transvaginal ultrasound revealed enlarging uterine fibroid. Had pelvic MRI, which showed enlarging uterine mass and also right pelvic sidewall external iliac lymphadenopathy. PET-CT scan confirmed the above findings. With the concern for metastatic peritoneal disease, patient was taken to the operating room for exploratory laparoscopy and tumor debulking. Procedure lasted 3.5 hours. Estimated blood loss was 150 cc, and patient was discharged home the same day. Exploratory laparoscopy, you could see uterus enlarged with multiple fibroids. There are peritoneal metastatic disease on the right side to the mid-abdomen. However, the upper abdomen, including surface diaphragm and the liver, are normal. There is a small benign liver cyst can be appreciated. Robotic apparatus was docked over the patient and proceeded with the tumor debulking. Appendix has been evaluated and it is normal. We started debulking of the peritoneum from the right side, away from the peritoneal disease, with a adequate margin from visible peritoneal disease. Electrosurgical scissor is used for sharp dissection. Ureter identified at the level of the pelvic brim, and dissection starts above the external iliac artery. Traction and contraction is being used to be able to mobilize the peritoneum and excise all the metastatic visible disease. Psoas muscle can be appreciated laterally, and metastatic disease is being grabbed with the grasper, pulled away from underlying disease, including the ureter posteriorly and external iliac artery laterally. Complete dissection of the metastatic disease on the right pelvic side wall is being performed and a specimen is removed. Since patient had bulky metastatic lymph node, the mobilization of the external iliac artery is started. After the nodes are being identified, the external iliac artery is being mobilized laterally and using combination of the traction and counter-traction, the upper portion of this conglomerate metastatic lymph nodes between the ureter posteriorly, external iliac vein and artery laterally is being gradually mobilized. Assistance suctioning the blood to clear the field. This portion of the lymph nodes are being removed. Attention is made to avoid fractionation as much as possible. There are more bulky lymph nodes between the internal iliac vessels and obturator nerve that has to be removed. Again, gentle traction and counter-traction and minimal amount of the electrosurgery is being used to remove these lymph nodes. You could see the obturator nerve gradually being separated and all the lymph nodes is being mobilized. Here you could see the uterine vessels being electrodesiccated and cut using the electrosurgery, and all the lymph nodes removed, confined to the laparoscopic bag and removed from the abdomen without contamination of the incision. You could see the pelvic sidewall, the obturator nerve, external iliac artery, vein, and the ureter. Since there is disease in the pararectal area and uterosacral ligament and posterior cul-de-sac, we proceeded with the modified radical hysterectomy. Here you could see the ureter is lateral, the uterosacral ligament is medial, and pararectal area posteriorly with metastatic diseases. All this area had to be resected. The ureter is completely mobilized to the urethral tunnel. And that is the stump of the uterine artery, which has been electrodesiccated and cut. So here the purpose of radical hysterectomy is all to remove all this peritoneal and retroperitoneal disease. Nerve sparing technique was utilized, similar to the section of the peritoneal endometriosis, to protect inferior hypogastric nerve. Now attention was made towards the left side, the anterior abdominal wall. We started dissection on the anterior cul-de-sac towards the left side, opening the left pelvic sidewall, identifying again the external iliac vessels and the entire peritoneum with metastatic disease is being resected. Here the round ligament on the left side being electrodesiccated using bipolar electrocoagulation and cut using electrosurgical scissors. This is a round ligament on the left side. The uterus is medial. Here, attention has to be made that you don't get to the external iliac vessels. Now, the ureter on the left side was encased with the metastatic disease. So first, the ureter is being mobilized from the rectosigmoid colon by getting to the pararectal area. Again, combination of the traction and counter-traction is being used with minimal amount of the electrosurgery to avoid damage to ureter. You could see the distal portion of the ureter is encased with the metastatic disease. And all this disease has to be resected. So this is the uterine vessels coming from the hypogastric artery, which is involved with the metastatic disease. The ureter can be seen below it. Again, combination of the traction and counter-traction, and mostly blunt dissection is being used to mobilize the ureter from this metastatic disease, and also here the uterine vessels have been coagulated and cut. The ureter is completely mobilized. The uterine vessels electrocoagulated here. You could see the ureter has been completely mobilized from the ureteral tunnel. And this portion of the metastatic disease, including the uterine vessels, is going to be electrodesiccated, cut, and removed separately to make the exposure easier and the operation easier. This patient imaging study did not show any bulky lymph nodes on the left side. However, here we open up the pelvic side wall and we did limited lymphadenectomy. Again, external iliac artery and vein are identified, and these lymph nodes are being mobilized. Mostly bluntly, and electrodesiccated using bipolar forceps, and cut using electrosurgical scissors. You could see lymphadenectomy is performed. The ureter is lateral, but there is more metastatic disease on the posterior cul-de-sac, and also left retrosacral ligament and left parametrium. And again, all is being completely resected, and some small area may be completely ablated. Here, posterior cul-de-sac disease completely has been resected. Left pelvic side wall, lymphadenectomy performed, and the right side tumor debulking has been performed. And finally, attention is made towards the anterior cul-de-sac tumor debulking. Here, the round ligament on the right side being electrodesiccated and cut. There are some metastatic disease here that is going to be ablated, similar to using argon beam coagulator. All the lesions completely ablated until the peritoneal fat can be seen. Now here we are doing anterior cul-de-sac dissection, and since there is severe attachment of the bladder to the cervix and the lower uterine segment, we are entering to N space, which is lateral to medial, and was described by Dr. Cameron Najat. Here you could see the N space. Here you see N space. On the right side, it's a very safe space coming lateral to medial, and that is the left side. You could see the N space here, and the bladder has been pushed down off the cervix and lower uterine segment. You could see the bladder all the way is down. And now this adhesive disease between the bladder and the uterus can be safely dissected without damaging the bladder. So the bladder is all the way down. This is the right side of the parametrium, and the remaining blood vessels here are electrodesiccated cut. You can see the ureter is completely lateral all the way to the bladder. Of course, this is not for cervical cancer, and the purpose of this radical hysterectomy is to remove all the metastatic disease from the peritoneum. You could see the part of the parametrium here, which has been completely mobilized. We try to do nerve sparing as much as possible, and all the metastatic disease has been removed. The remaining parametrium electrodesiccated cut here. The ureter is completely lateral. Now we're doing colpotomy, resecting the vagina over the uterine manipulator cup. Again, this is not for cervical cancer, this is radical hysterectomy. So the specimen is confined to laparoscopic bag and is removed from the vagina. Also, we did infertility omentectomy, bipolar used to electrodesicate and cut the blood vessels. An electrosurgery scissor was used to cut. Infertility omentectomy is performed. You could see the transverse colon very well. And infertility omentum was removed in pieces and removed vaginally. The vaginal cuff was closed as a routine manner. Pelvic cavity was evaluated. There was complete hemostasis. Cystoscopy was performed and the bladder was intact. Here, hemostatic spray was applied in the raw surface area. As I mentioned, the estimated blood loss was 150 cc. The procedure approximately took 3.5 hours, and the patient was discharged home the same day. The final pathology showed stage 4B, mesonephric-like carcinoma of the endometrium and patients undergoing chemotherapy with carboplatin and Taxol. Thank you very much for your attention. Good luck with your meeting.
Good evening. My name is Marion Smith, and on behalf of the Worldwide EndoMarch and the American and Global Congress of Endometriosis Subspecialists, I'd like to welcome today's guest all the way from Wales, Ms. Carla Edwards. Good evening. How are you doing this evening, Carla?
I'm good. How are you?
Fantastic. We are truly grateful that you're taking time away to join us to talk about a disease that is very, very close to both of our hearts. I know that we both share passion in raising endometriosis awareness. Can you start and tell us a little bit about your journey with endometriosis?
My journey started when I was around 10 years old. And I was constantly going back and forth to the doctors, having pains in my back and my side. And at the time I hadn't started my period because I was a late starter when it came to my period. So obviously, you know, they was taking wee samples and things like that. And obviously there was blood found in there. So they automatically treated me for kidney infections and water infections every single time. And I was going back for about 10 years, something like that. Wow. And nothing was done whatsoever. And I was in my early teens and, you know, still nothing was happening. The pain was getting worse. And, you know, I started my period by then. The period became heavier. You know, the normal endometriosis pains, I suppose we say normal to us, but you know, to other people it's not so normal. But you know, the stabbing started, and then the rectal vaginal pain started. I was around 21 or 22, and I was going back and forth to doctors, and I was saying, no, I need to see a gynecologist because I think something's wrong. I'm having all these pains, and it was basically I was just being dismissed. Oh, there's nothing wrong with you. You know, you're too young for anything to be going on down there, as they put it. And like my auntie had endometriosis as well. And I said to them about it, and it wasn't until I mentioned that my auntie had endometriosis that they actually acknowledged me then, so to speak. So by the time I started going from the doctors from a young age, so say from like primary school, so from 10. And I think I went into my see and treat lap when I was 26. So it took me over 16 years to get a diagnosis for my endo anyway.
Yeah, and just incredible listening to your story. Brings back, you know, memories of my own of the pain that you're mentioning, back pain, pain going to the bathroom, bladder pain, bowel pain. It's just, it's really heartbreaking to hear your story. And I know I can empathize with you, and I'm sure so many other sufferers that are listening also can, you know, sadly know your pain. 16 years to get diagnosed. How was it to find specialists in the area of endometriosis in Wales, you know, to find physicians that are skilled in diagnosing it and also in treating it? Is that an easy find?
No, it's quite hard because there is only 2 surgeons, and they're only in one hospital. So they don't, you know, they work the same team, so they just have the one hospital. But no, I went to gynecologists, and I had, they told me, see and treat, and they said that I had endometriosis, and it was on my bladder, my bowel, my ovaries, pouch Douglas, it was just everywhere. My bladder was stuck to my bowel was stuck to my uterus, and my uterus was stuck to my abdominal wall. So, you know, they was just cutting the lesions away as I did through the years. And I think I had about 5 operations, I think, before I actually started to know and to get, well, to know actually what was going on, rather than them just telling me what was going on. And then I started to do my own research. And then when I started to do my own research, and then I started to question, I petitioned, not sort of petitioned, I went back to my doctors and I said that I wanted to be referred to a certain hospital and to certain gynecologists, because there's only 2 qualified surgeons in Wales, and I don't want to be seen by another gynecologist who just performed pointless procedures and done more damage to my insides rather than doing any good. And I went down, and they finally referred me down to there. But when I went down to there, a lot of happened, I suppose, on my endo journey, because I got down to Cardiff and then I had a seizure and I was in coma for a few weeks in ICU on a life support machine. And I was through a seizure, and I think, I'm not too sure, I was found, I wasn't breathing, so I was unconscious, and they had to put me on a ventilator because they wasn't sure how long the oxygen would stop going to the brain, or they didn't know how I was going to be. They called the family in, and they wasn't too sure if I was going to wake up. But luckily enough, I did wake up a few weeks later. But then after coming out of the coma and having all the surgeries that I had, I stayed. They kept me down on that team then, even though I was in a different area. They said that it was okay for them, you know, for them to treat me. So I had 2 different surgeries down there. I had a full hysterectomy down in Cardiff. That was because of my seizures, because it's hormonal, obviously, and you know, estrogen, ovaries, so doesn't mix. So I had to have a hysterectomy due to even though it was due to my endo, but it was down to the epilepsy as well. Stop the estrogen sort of circling my body then. So because the more estrogen that goes into my body, the more seizures I'm likely to have. So I'm not on progesterone, I'm on HRT, fully menopausal. I've been for the last 9 years, unfortunately. I can't have progesterone because of seizures. I can have estrogen, but only a little bit. I'm not allowed a lot. And so, like, when it comes to the epilepsy, it's hard because I'm not allowed to do certain types of things. I'm allowed to do this, and then I'm not allowed to do that. Or I'm allowed to take this, and then I'm not allowed to take that. So, like, everything sort of crosses over as well, and like mixes up, which is quite hard because you can't do the one thing without doing the other. But then, you know, then like it could interfere with the epilepsy, but you haven't got a choice in it really. And you know, it's quite frustrating, the epilepsy part of it, because it's taking a lot of independence away from me. It's not just like one type of seizure I have. I do have about 10 different types of seizures. You know, going from myclonic jerking to a drop seizure where you just drop straight down, partial seizures, which is one side of the brain. It causes tingling and confusion. There's, you know, you stop breathing. They'd say it can decrease within the menopause, but if you've been diagnosed with another type of epilepsy, then it's less likely to go away, which I have been diagnosed with photosensitive epilepsy as well. So even though I'm going through the menopause, and the epilepsy could get better, it's not going to get better because I've got 2 different types of epilepsy. So the both of them stay and yeah, they didn't go. So that's for life now, unfortunately.
I am so deeply sorry and saddened to hear your journey, and what a strong person you are, Carla, for everything that you've endured and continue to endure. It's really powerful. You mentioned that throughout your journey, you were eventually diagnosed with hormonal epilepsy. Is that the correct diagnosis?
Yeah, catalemic is called catalemic epilepsy, which is hormonal, but catalemic is just the name that they've come up with for it.
And so basically, that was a result of determining that your endometriosis, or at the time that you would have your menstrual cycle, you would often endure seizures at the same time, or how did that? Tell us a little bit about that and hormonal epilepsy. I think that would be really something interesting to share with other listeners or sufferers of endometriosis.
The seizures, how they started off, I don't really know, because I was having them for quite a long time before I actually knew that I was having them, because I thought that I was passing out. Because I'd wake up on the floor, or somewhere, I'd be in the kitchen, and then I'd be in the living room, and I'd wake up and I'd be like, right, okay, I must have passed out with a pain, because I've done that a few times anyway. But obviously then, as I was being observed, and people were seeing me, and then obviously when I didn't pass out, well, I thought that maybe that I passed out. I didn't pass out. It was obviously a seizure. And like, I think it was about 3 or 4 years before I actually had my first witness seizure. Because I didn't know what it was. I thought, like I said, I thought I was just passing out, but I wasn't passing out. I was having a seizure.
And how many women would you say, or do you know off the top of your head, suffer from this hormonal epilepsy? How common is this disorder?
I wouldn't say it's very common. I don't know anybody. Only person I know is my auntie, who's passed away now, obviously, my nan's sister. But that's the only person I know. I don't know anybody who's got catalemic epilepsy.
Wow, well, really, you really bring some information to light for people that may be having similar symptoms to you. I thank you for sharing your story, because it's, I'm sure, very emotional and a difficult story to share, but you certainly are a very, very strong individual. I know you're also working as a global ambassador on behalf of the Worldwide EndoMarch, specifically Team San Francisco.
Yeah.
And as a woman who suffers from severe endometriosis myself, I know how grateful I am to people like you who devote so much of your time and energy towards helping to raise endometriosis awareness. What kinds of things are you doing as a global ambassador to get that message out there about this terrible disease?
Most of my awareness, like I said, is on social media. It's on TikTok, and I mostly getting all the symptoms out there of doing videos where you going to the doctors, or you're getting gaslighted. And I'll put certain specific captions up for gaslighting. I'll put it up for bowel endometriosis. I'll put it up for bladder. So I'll put it up for all different kinds of things. But I'll take the mick out of local health boards as well with the gaslighting, and I'll purposely tag them in the video that is quite sarcastic or along those lines, because yeah, that I like to take the mick as well out of a lot of the health boards.
Unfortunately, so many women have experienced gaslighting, trying to convince medical people that this is not in your head, that you really are suffering from this disease. So what you're putting out there is definitely helping so many. How can someone find you on TikTok? How would we locate you on TikTok?
I am Endo Warrior 420.
Endo Warrior 420, and you definitely are an Endo Warrior, Miss Carla. Endo Warrior 420. That's where we can find you on TikTok and see all the great work that you're doing.
Yeah, my main account would be Carla Endo Warrior 420.
Carla Endo Warrior 420.
Yeah, that's my main account. Yeah.
I can't wait to check it out. And once again, I want to thank you for sharing your story. I know it's not easy, but you're helping so many. And we wish you best of luck with your health, best wishes as you move forward, and continue to do the great work you're doing on behalf of Team San Francisco as a global ambassador to the Worldwide EndoMarch. Thank you so much, Carla.
No, thank you. No problem.
To all the viewers around the world, welcome to the 15th edition of the Endometriosis Explained, part of the teaching efforts of Worldwide EndoMarch, EndoMarch, to raise awareness about endometriosis. Endometriosis, a social problem, and its effect on the humans. At the outset, we thank every one of you around the world for your assistance in your efforts to put an end to the dynasty of endometriosis and its chokehold on people, on patients, their families, and the society. Every one of you in any organization from A to Z, every person in any shape and manner that you are doing this, we thank you very, very much. A special thanks to all the EndoMarchers around the globe that they have been volunteering, doing all the work, from the captains, president, ambassadors, every one of you and their family. We know how hard it has been for you. We know that you are volunteering to do this and you have no budgets. And I know some of you have asking if we can help. And I would like to let you know that Worldwide EndoMarch is doing its best to invest in education in many universities, many big societies. And we thank you for your effort, and we are sorry that we have not been able to financially support you, and we want to acknowledge how much it has been difficult for you. And despite all of that, you are doing it. Example of it, as I said, the accomplishments of the Worldwide EndoMarch France last month, Christina Zapparolo and President of France, Emmanuel Macron, that they contributed significantly, and we thank them again. Also, we like to thank the EndoMarchers and organizers in England, and also we want to give a shout out to the effort and the families of Sir David Amos, the member of the Parliament of England, that I had the privilege of meeting him and Secretary of Health in their Parliament and in a fundraiser to help the EndoMarch organizers and endometriosis patients in England. Some of you may or may not know that, unfortunately, Sir David Amos, who was a wonderful, wonderful man and a crusader for women in general and women with endometriosis in England. Unfortunately, he was assassinated by a ruthless person in England because of good he did. So we honor Sir David Amos, and we want to thank him and his families for his contribution. So we will continue and be forward we go with all of your efforts. What you are doing really makes change. As you can see, endometriosis is more and more being heard about everywhere. Even medical societies are very helpful and they have started to be very, even more active. I just want to let you know you are being heard. Many medical societies, like American Society of Reproductive Medicine, is making efforts to raise awareness and education. We are lacking adequate surgeons to help you because endometriosis is a surgical disease, and the best results for pain, for infertility, for organ dysfunction are by competent surgeons who are endometriosis specialists. And because of what you are voicing your concern, big societies like American Society of Reproductive Medicine, European Society of Human Reproduction, American Association of Gynecologic Laparoscopies, Laparoscopic and Robotic Surgeons Society in International Surgeon, and Society of Gynecologic Oncologists in the United States. These are all societies that are hearing you and they are gearing up to train more endometriosis surgeons. You have met some of them, Dr. Agrawal, Dr. Lee, Dr. Tavalloi, last time you met them, that they are specifically training to become surgeons to help patients with endometriosis thoroughly and properly the way that it should be done. That is all because of you and your interest. Because of your activities, the many medical universities, very big organizations, Hopkins, Harvard, Yale, Emory, Stanford, UCSF, Northwestern, Medical College of Georgia, University of North Carolina. These are some of the organizations that they were funded and they received awards from Worldwide EndoMarch to help them for their research, and we continue to elaborate. Professor Zandevan of Oxford University, she received that award, and also Professor Mizmer of University of Michigan, that they were heroes of the year 2020, they received awards. So these are all because of your interest and that we are making changes for endometriosis. Endometriosis is a social issue. It is not only a disease that has causes pain, or for some people it is not really, it is a debilitating problem, and it is not always pain. And a major portion of the couples that they want to have children in the world, and they go from doctor to doctor and they tell them you are okay, all of your tests are okay, and your husband is okay, your partner is okay, and they don't get pregnant. These patients, they think it is something their fault. I have had patients, they say, but everything is okay with me. Is there something I did wrong? No, of course not. Endometriosis, in more than 95% of the patients that they come to us and they have no symptom and they want to get pregnant, they have endometriosis patient. They have endometriosis, and if this infertility patient, which is a social issue in countries in Europe, In Japan, right now, the population is going down. So the birth rate is going down. It is going to happen in US the same way. So many of these infertility, these are because of endometriosis, far higher than medical societies know. We are in the forefront of this discovery. And I promise you, more and more, this issue would be recognized that we have to address endometriosis for infertility couples. What the mind doesn't know, the eyes don't see. Many of the infertility specialists around the world, they do not know the impact of endometriosis on infertility. And thus it is not being taught. But change is happening. Examples of our guest speakers today from New York and from here in California. I would let my brother, the co-founder of the Worldwide EndoMarch in New York, who is also a professor at Cornell and also NYU. He is, in addition being of an endometriosis specialist, he is a GYN oncologist. He will take over and he would introduce his guest in New York, and I will join you again later. Thank you very, very much, all of you, for joining. And if you want to watch the previous session, go to webinars of endomarch.org and go to webinars. Thank you again for joining us. Dr. Farnejad.
Cameron, thank you very much. Good afternoon, good morning, and good evening, no matter where you are in the world. Today's session is going to be specifically concentrated about the role of endometriosis on infertility. So endometriosis could affect the infertility in different ways. Briefly, could be some sort of anatomical destruction, like scar tissue around tube and the ovaries, that the egg doesn't get to the fallopian tubes, or the ovaries has large cyst and interferes with the ovulation, and that there are other issues that we will discuss it today. And we have two reproductive endocrinologists that will discuss, Dr. Talabian and Dr. Sanelu, and could affect the quality of the eggs, quality of the embryos, and also effect on implantations. So also we have, besides the infertility specialists, hormonal stimulation and surgery, there are some other aspects of the endometriosis has to be addressed. And Dr. Mary Sobo, she is an acupuncturist, and she works with Dr. Talabian, is going to address the other support of these couples using the Eastern medicine versus Western medicine. So to start the session, we have from New York, have asked one of our dear patients, Nina Pro, that she is a patient of Dr. Talabian and Dr. Sobo, and had infertility, and Dr. Talabian thought she had endometriosis, and she was referred to me, and I did surgery on her, and she had endometriosis, and she was treated, and she has given us the privilege to be here, and I asked her to share her story with us. And after that, we go with Dr. Talabian and Dr. Sobo to share with you how they do their practice to help patients like Nina. Nina, go ahead.
Hi, I'm Nina Piro. Thanks for having me. I'm very honored to be here, and I feel like I'm back together with my whole medical team here. I am very, very grateful. I am 7 months pregnant today, and I wouldn't be if it weren't for Dr. Nashad, Dr. Sabo, and Dr. Shlavian. I'll just give a brief timeline, kind of my story. I got married in 2018, started trying to conceive in about April of 2019. And by kind of August, September, I sort of knew there was something, I had a feeling just something was off. Didn't really address it until the beginning of 2020. And the pandemic happened, kind of gone to my gynecologist. And I think I'd had a preliminary call with Dr. Tlaib about maybe doing an IUI, did some preliminary testing in New York. But I was quickly kind of put in touch with Mary, and I was out in Southampton for the summer, worked with Mary. And I also just want to say Mary and Carrie and her team, such amazing help, not only from, I had just lost my father. It was the middle of the pandemic. I felt like Dr. Tlabian and Dr. Sabo sort of saw me and were willing to listen to me saying, there's something wrong. I don't know what it is, but it just doesn't feel right. I'd never missed a period in my life. I had never really had bad period cramps. It just everything seemed to be working, as Dr. Najat said, but kept on saying there's something off. We did an extremely successful retrieval with Dr. Tlabian in January of, I guess it was 2021. And we did we got 9 embryos. I mean, it was a great retrieval. And we did a transfer in May 2021. It was unsuccessful. And for Dr. Tlaib, I just don't understand. They were beautiful. There's just something else going on here. And I've been talking to Mary and Harry. And I just, I think throughout this process, I've really learned about advocating myself, but I've also seen the advocacy work that can go on from doctors. And, you guys really listened to me and also saw things in myself that I probably wasn't seeing. So we did the surgery, me and Dr. Najat, in July of 2021. And then we did an embryo transfer in August of 2021, August 18th. It was actually on our wedding anniversary. I was like, there can't be any more pressure for this to go right, but it did. And I just, I always sort of had this feeling that something was off, and we kind of got to the root of it. And I will never forget Dr. Tlabian on the phone with me that summer in 2020, kind of like the first conversation I had with her. I said, do you think it's my diet? Do you think it's something I'm doing? Am I running too much? She was like, are you asking me if you ate a cookie and that's why you're not getting pregnant? Like, no, it's not because you ate a cookie. And, this is something we need to figure out and get to the bottom of it. So I feel like we did get to the bottom of it, and I've had an overall really, really easy pregnancy, and I'm just knocking on wood to get through the next few months, 10 weeks successfully. And I hope that even that story can just bring light to just someone who's had the privilege of getting amazing medical care throughout my lifetime. Still, nothing was really flagged, nothing was really talked about because I didn't really have any issues. So I just want to thank you guys for really seeing me as and collaborating. I think you're incredible.
Thank you very much, Nina. One thing that I like you to express that, and I like it that you listen to your body, as you said yourself, that you thought there is something not right. And then you wanted to help somebody to listen to you, and Dr. Tlabian and Dr. Sobo listen to you.
Yeah, and I think that, to be quite honest, I think that after I had the surgery, I realized that there was probably, I wouldn't say necessarily pain with intercourse that was going on, but I was definitely more uncomfortable at certain points than I was sort of admitting to myself. That was probably one kind of listening to my body thing that I probably wasn't verbal enough about, and You know, other than that, there were so few kind of signs, but I think I wish that at, you know, 30, 31, when I sort of thinking about having a baby, I'd been more verbal about like, there's just something that feels wrong. But a lot of that, I know something's wrong is just, I don't know, I felt it in my gut a little bit. And I think I really, really want to thank Carrie and Mary. Carrie works with Mary in out in Long Island for also saying, you know, the gut, there just looks like there's something off with the gut too, just a little slightly. And I probably should have been more sensitive to that, kind of some of those gastro too.
Thank you very much. These are very important for us as a surgeon when the patient is referred to us to evaluate them for endometriosis. The way that we practice, number one, is to listen to the patient. And a lot of times the patient, when you listen to them, they will ask their own diagnosis. You have to be focused and ask them the right questions. Not everybody has severe painful period. Not everybody has severe painful intercourse. You have just subtle things that you have to pay attention and ask the patient the right questions, and then you do proper examination. And also you have to rely on the experience of the referring physicians, because those physicians, they have had a lot of experiences that they know that, for example, and I asked Dr. Talebi and Dr. Sobo to explain their experiences when they think and they raise a flag to refer the patient. So that's all that for us, it is important to listen to the patient and do a proper examination before we do the surgery. And I will talk about the surgery later. So Dr. Talebian, would you please tell us what did you see in Nina that you thought you should send her to us? Thank you.
So can everyone hear me? I just want to make sure you guys can hear me.
Yes, yes.
Yeah, okay, great. Okay,
yes.
So, you know, Nina, I will say is a very, very sort of classic illustration of the endo patient who can go unrecognized for a very long time. And what I mean by that is she's, you know, under 35, a history of, you know, this unexplained infertility, ovulating every month, not getting pregnant. And interestingly, she, her primary OBGYN, or maybe it was myself, ordered an HSG, which is the uterine fallopian tube test, after she'd been trying for a handful of months. And interestingly, and again, there was the pandemic, so there was a little bit of her not being in the city the whole time, maybe, you know, but nonetheless, she did an HSG, which showed a questionable blockage on one of her tubes. And that was a tip off to me. Okay, that's interesting. Why would a tube be blocked? You know, obviously endometriosis can do that, but nonetheless, you know, there was various things going on. She tried on her own for a fair amount of time. And eventually, you know, working with Mary and Carrie, you know, sort of doing the Eastern approach, trying on her own, eventually came back to the city, and we kind of jumped into IVF. And this is the other tip off. She made multiple, or they made, I should say, beautiful, high quality embryos that were chromosomally intact, like multiple from one round. And to me, that's another tip off, right? When it's, I always tell people IVF is therapeutic and diagnostic. When someone has unexplained infertility and they do IVF and they have a very high attrition rate, and at the end of the process, they only have one good embryo or none, then we know the answer. This is an issue with chromosomes of egg, sperm, embryo, right? But when you have a, you know, under 35 patient with unexplained infertility who makes gorgeous embryos, I always think there's something going on in that environment where this can't happen on its own and it's not implanting, and that could be endometriosis. And again, you know, I think Nina kind of feels bad that she didn't really discuss her GI symptoms or pain, but I think a lot of women, like, you're used to it. That's normal for you. So when a doctor is like, hey, are you in a lot of pain? No, I'm not. I'm a big runner. So, I always go see the doctor. They're like, oh, are you having pain? I'm like, no, I have no pain. And then they touch my foot and I jump up in the air, right? So I think at some point for a lot of women with endometriosis, their GI symptoms become normal and the pain they're having becomes normal. And so, and I remember speaking to Nina, I said, wow, you did beautifully. Let's go ahead and put one embryo in. When it didn't work, then I really knew. And at that point, I said, let's hit the pause button. Listen, some doctors would think I'm crazy to refer you for surgery, but this whole thing wrapped together, I really think you have endometriosis. And I said, listen, you've got multiple beautiful embryos. We can keep at it and see if it works. But I really do think that this is what's going on. And I think even just for you and I to have the information and the data and the diagnosis, I think it'd just be helpful. And thankfully, Nina was, and again, I don't take surgery lightly. I explain to all my patients that there's very few surgeons I refer to for this because it is such a technical surgery, and you can talk about this later. Surgery has risks, but again, knock on wood, I know in your hands that they're, going to be taken care of and the endo is going to be treated. And in many ways, it's like the fastest course to getting to that pregnancy once they have those embryos already there on the side.
Thank you very much, Dr. Talebian. So Mary, tell us, what do you do with these patients from your perspective, working with Dr. Talebian, using your expertise?
Sure. So I'm a doctor of acupuncture and Chinese medicine. And so I specialize in fertility, and I have a team of acupuncturists that work with me. We have a location in Southampton on Long Island, and then we also have a clinic location in Manhattan that I now share with Dr. Talebian. And we have developed this kind of integrative approach where, I work with women while they're trying naturally, and then I work with couples when they're undergoing IVF and other treatments. But I've been practicing about 15 years, and I've always loved Western medicine. And so right from the start of my career, I've always wanted to work in an integrative way. So using my tools of acupuncture, Chinese herbs, nutrition, lifestyle changes, evidence-based supplements with research backing them. Those are my tools, but my mind still kind of thinks in a Western medical kind of way. And so I really I can't do, in the state of New York, acupuncturists can't do blood tests or any sort of testing. And so I like to work with Dr. Talebian and her team at CCRM because they can do the testing that I can't see. So like, I can't see the blocked fallopian tubes that might indicate scar tissue that indicates endometriosis. And so these are tips that I appreciate to get direction for my treatment plans. But Dr. Talebian sent me Nina pretty early on. I think we did some IUIs, right? And, right from the get-go, when we see a patient, we don't just talk about fertility. We do talk about the menstrual cycle, and it gives us a ton of information on the health, their overall health. So whether they have menstrual cramps or not, just gives us information on their underlying pattern. So women with a lot of menstrual cramps might also have a lot of other stagnation in the body. So constipation, headaches, pain elsewhere, like neck and shoulder pain, back pain. But, endometriosis doesn't have to go along with those symptoms. And especially for us to treat it, we treat the overall body. So we also look at digestion, we look at sleep patterns, we look at energy, we look at their diet and how their body is processing it. So sometimes people think they're eating healthy. They might go vegan or they might be vegetarian, but we look at their digestion and their overall health, and it's not working for their system. And so we really work on a holistic level where we try to help the patient become healthy overall. But through my time working with Dr. Talebian and her team at CCRM, we've developed this integrative approach where we discuss cases. And so I'll come in and say, thanks for referring so-and-so. Since we share offices, we can go chat face-to-face, which is great. And, I'll give my side from the Eastern perspective of, I'm seeing this in this case, there's like a weakness in the gut. I don't think she's absorbing nutrients well. I'm going to work on that and we'll see what happens. Or maybe a patient has done multiple IVFs and is getting poor quality embryos out. And so Shiva will send me those patients too, and I'll work with their diet to decrease inflammation, which is a big part of endometriosis, which I'm sure we'll talk about. And we'll try to decrease the inflammation using antioxidants and herbs and acupuncture, changes in diet, and then we'll repeat an IVF. And we often do get improved results with subsequent embryos, but occasionally we won't. And then, you know, we'll kind of switch gears, and that's when we might send someone to surgery. So in Nina's case, she made beautiful embryos, and she had a lot, right? And so there was also, you know, sometimes I think we'll get tipped off with endometriosis when it's a young woman and she has decreased ovarian reserve. She's not making that many eggs and they're poor quality, and she's like 32. That's another tip off for us, where we're like, what's going on here? Why are these eggs so poor? And, you know, we'll do our team approach and then kind of powwow on next steps. And sometimes that is surgery to explore for endometriosis.
Thank you very much, Dr. Sobel. Dr. Talebian, I will ask you one more question. One of the questions that always patients will ask, and if I have the surgery could decrease my ovarian reserve, and they're afraid to have surgery, and unfortunately some infertility specialists have created this fear in the mind of the patients. What is your experiences? And I would, of course, discuss with my surgical approach, but
Yeah.
what are your experiences? Thank you.
Yeah, so I do think, again, there is, you know, unfortunately, there is some literature out there that seems to be pretty outdated, where surgery did potentially compromise the ovarian reserve, right? When you think of surgeons who are, you know, doing cystectomies and really removing a lot of that ovarian tissue, then of course that can lower the ovarian reserve. But, you know, again, I like to look at things from a historical perspective, and, you know, and I think, you know, right, surgery has become so much more successful nowadays, right? We, as the fertility doctor, I used to do a lot of surgery when I've been during fellowship and immediately post fellowship, but a lot of the techniques we used are outdated. The equipment is outdated. So essentially, I'm thinking, I'm a fertility doctor. I'm doing egg retrievals and embryo transfers every day, and I'm operating once or twice a month. There are surgeons that now operate, you know, multiple days a week. The equipment is changing. The technology is changing. I don't think the patient's best interest is for me to do this surgery anymore. And I really passed it off quite a while ago, only because it is very important that whoever is doing that endometriosis surgery, A, can recognize the endometriosis, and B, is highly skilled to be able to treat the endometriosis without affecting the ovarian reserve, without really removing a lot of that healthy ovarian tissue, and at the same time, not injuring other structures. So what I tell patients who do their research online, I found this study that showed, you know, lower AMH after the surgery. I say, well, you know what, you have to take that understanding that that is, who knows who was doing the surgery? Were they really a highly skilled surgeon? What is this data from? Unfortunately, our literature, I think, is really outdated and not very accurate when it comes to this, which is, again, why you know, there's a handful of people, I think, in the tri-state area who I think are very, very good at this. And so it's really important who you go to for the surgery, because yes, I agree. If you, you know, maybe don't necessarily see a surgeon very skilled at endometriosis surgery, then your ovarian reserve may be compromised after the surgery.
Thank you very much, Dr. Talebian. So I just want to mention the surgical approach for endometriosis. As Dr. Talebian mentioned, the first aspect is to recognize the endometriosis. When you do surgery, which is right now, it is laparoscopic surgery, or some people, they call it robotic surgery. It doesn't matter, it is laparoscopy. And there are few important things that you should keep in mind. Number one is that you recognize the endometriosis, because endometriosis lesion could be different colors, different patterns, different areas of the pelvis, on the ovaries, on the back of the uterus, even sometimes on towards the upper abdomen, on the diaphragm, on the appendix. So this has to be recognized first. And the second thing is that how to treat it. As Dr. Sobel mentioned, endometriosis causes inflammation. And the important thing is to remove it thoroughly. When you remove them, because this endometriosis, we call them implant or lesions, are sticking to different part of the body, on the ovaries, on the bladder, on the bowel, ureters. So you have to keep in mind why you are removing them, you do not damage that organs. And when it comes to the ovaries, the goal is to treat the endometriosis, but in the same time, do not damage the ovary. So we know excising the endometriosis is very, very effective, but when it comes to the ovary, you have to be careful that not you chop off a piece of the ovary. You treat the endometriosis thoroughly without damaging the ovary. And that is when I talk to my patients and they bring the subject up, I will take my time explaining to them that that is true that excision is good, but on the ovary may not be the best options. And then you have to treat it with the other modalities thoroughly without removing a piece of the ovary. The ovarian cyst, this is different stories. You have to remove the ovarian cyst called endometrioma or chocolate cyst without not damaging the ovary, because you don't want to leave cyst behind, because sometimes this cyst could have potential to become cancer. So you have to keep all of these things in mind. It is not when we do surgery for the cancer and we want to remove the cancer, that is one approach. Endometriosis, also you have to keep in mind the effect on on infertility, and also take care of the disease that patient becomes pregnant, or if she has pain, adequately remove it to become pain-free. So I think, Cameron, if anybody has any question for Dr. Talebi and Dr. Sobo and I'd be more than happy to answer. Otherwise, I think I pass the podium to you.
Thank you very much, Rashbar, and thank you to your wonderful, wonderful guest. It was outstanding and wonderful information, and I appreciate it very, very much. All of us appreciate it. Thank you. I would like to switch to our friend, Dr. Sunny June, and Alicia Langer and her husband, Corey, and her son, Diane. And I would start with Alicia. And Alicia is a mutual patient of Dr. Sunny June with her husband, Corey, and the son, Diane. And we would start to say their story. You look how wonderful your son looks like. Oh, he says hi to you. Hi, Corey. Hi, Alicia. And then we will proceed from there. We have been here fortunate, as my brother Paul has been, to work with Dr. Talebi, and here I'm working with another forward-thinking reproductive endocrinologist, Dr. Sunny June, who, like her partner, Dr. Tazuka, and her friend, Dr. Kelly Beck and Dr. Evazadeh and Dr. Talebian, and she is able to diagnose and pick up patients with endometriosis, and we have been able and grateful to be able to help many couples like Alicia and Corey and Ryan. So Alicia and Corey, why don't you start a little bit of your story? We are anxious to look to hear it.
Thank you for having us today. Yeah, my name is Alyssa, and this is my husband, Corey, and this is Liam. He's our little miracle babe, and we're just so grateful for these amazing doctors who have made such a difference in our life and helping us start a family. So we, when we first got married, after a few months of trying naturally, probably about 8 months, we decided to, sorry, he's quite a busy toddler. After about 8 months of trying naturally, we decided to meet with Dr. Jun. And, my cycles were always long, and but there was nothing out of the ordinary. I didn't have extreme pain with periods. I really ultimately felt like, I had a healthy body in general, and it was really confusing to me why we weren't getting pregnant. We did a couple of IUIs, and they were not successful. And so Dr. Jun suggested that we consider moving forward with IVF. And one of the tests, so we ended up doing the Receptiva test, which was such an important test. And I'm so grateful that she suggested that. It did come back positive for several markers of endometriosis. And we decided to move forward with an IVF cycle, and we had great success, and we're fortunate to freeze several embryos. But she immediately said, I've got to refer you to see Dr. Najat. He's the best of the best, and it'll be really important that you get his insight on what's going on and with your body and endometriosis. And so we're so grateful that we met you, Dr. Najat, and you were very thorough from the very beginning and really listened to us. And we were desperate to do anything to help us start a family. And I definitely feel like you and Dr. Jun really came together as a team to help make the best possible outcome for us. And I remember during that first consultation that I had with you that you said, you could try to treat it with hormones of some sort, but you never really know until you go in with surgery how invasive the endometriosis could be. And I decided, why even take a chance? Let's just do the surgery. And I'm so glad that we did. You discovered that endometriosis was everywhere. I had it stage 4, all over my bladder, uterus, fallopian tubes, bowels. There's just so many different, I'm sure you can speak more to that, but it was fascinating. I remember when I came out of surgery, you said, I'm so glad that we did this. It was quite aggressive. It was stage 4 endometriosis. And again, I felt like I presented as a person that would not have endometriosis. I didn't have any of those typical symptoms. So yeah. And do you want to add anything, Corey?
Yeah. And then after the surgery, Dr. Najat came and put his hand on my shoulder and he goes, you have to be careful now. She's going to get pregnant. And guess what? We got pregnant with Dr. Jun's help. And now we have a very active, very tall little boy that's taken over our life. So thank you, Dr. Jun, Dr. Najat. It's been a blessing, and appreciate everything you did.
Yeah, thank you so much. Yeah, and we were able to move forward with IVF successfully after the surgery, and Liam's here today because of that. So thank you both, and thank you.
Well, thank you very much, both of you. And Liam looks like both of you are very active. And yes, the issue of Alisa's story and Nina's story touches the issue that they didn't come for pain. The issue that they had not looked for that option had it not been the issue that they wouldn't get pregnant. And one important issue for endometriosis, as I mentioned, is a surgical condition, is when you treat it very thoroughly, you also, hopefully, you decrease the risk of cancer associated with a patient with endometriosis, because patients with endometriosis, they have 2 to 3 times higher chance of cancer, and that treatment decreases that. And yes, who was the person who did a lot of this pioneering work in relationship to cancer and endometriosis, and that is Dr. Farb Nejad, that his work was groundbreaking in this area, and he's devoted a lot of his work in this area. He may want later to say something, but I next proceed with Dr. Sunny June, and I'd like Sunny to express her opinion about patients with endometriosis and her thought process. I know often she said, no, look, this patient, they get pregnant and here and there. So we would appreciate it, Sunny, if you give your opinion. And I told you before, it has been a pleasure to work with Dr. Sunny John, a very brilliant REI. Dr. John.
Thank you, Dr. Najat. And thank you, Alyssa and Corey, for sharing your story. And Liam is absolutely adorable. So let's see, whenever I see a couple or a patient, a lot of times it's just mainly the fertility issue, but plus or minus this classic symptoms of endometriosis, whether it be painful periods, pain with sex, pain with bowel movements, but a lot of them don't really complain of anything. And so when straight off the bat, patients complain of, oh, I have severe pain with periods, then big red flag, right? Endometriosis. And even in those patients with severe pain, they go to their annual exams with their gynecologist, and I ask them, hey, has anyone brought up the possibility of endometriosis? And they'll say, no, they just tell me to be on birth control pills, or they tell me to take, NSAIDs, Motrin, or Tylenol during my cycle, and I'm able to manage it. So it has never really come up. And so when patients do complain, or they note in their little questionnaire at our initial consultation that they have severe pain, then that is something I really focus on at the initial consultation. And like both Dr. Najats and have been saying, is that endometriosis is a surgically diagnosed disease. It's not a clinically diagnosed disease. So regardless of whether you have symptoms or lack of symptoms, we don't know until these patients undergo surgery. And also, we don't know the severity of the disease, that the symptoms don't necessarily correlate with the severity of the disease. We have seen patients with severe symptoms, and then they undergo surgery and have stage 1 to 2 endo. And then there are patients who have absolutely no symptoms and just failed IVF cycles, and they end up having severe endometriosis. So when patients do complain of severe pain, then we focus on, maybe we should look into this first, or, after banking embryos, but let's look into this and let's focus on this. But in patients who have no symptoms or just mild symptoms, someone like Alyssa, then there is a screening option, and we use this test called Receptiva. And Receptiva is an endometrial biopsy test that checks for 3 markers. It checks for 2 of the markers for looking for endometriosis, such as BCL6 and beta-3 integrin, and then the other marker is checking for what's called endometritis. It's a different disorder that's looking for infection in the uterus. But for Alyssa, the endometriosis one did come back positive. So in this scenario, what are the options? Well, do we further look into this and get it definitively diagnosed with surgery? Or do we do IVF, bank embryos, and there is that medical option, which is a hormonal suppression, but that doesn't really diagnose or definitively treat it. It just temporarily suppresses it. And I usually tell my patients, you know what, just go see the endometriosis surgeon, the specialist, because they'll do a more thorough exam. They'll do another ultrasound, and they will let you know if they think that you definitely do have it or not. And luckily, Alyssa and Corey listened to our recommendations and went to Dr. Najat, and she did end up having severe endo. And so in patients where it's mainly fertility issue and kind of lack of symptoms, and they're not convinced that they may have endo, then we start off with maybe that screening test. And then for patients who clearly have symptoms, then I actually just send them straight to the endometriosis specialist. Another key thing that Dr. Talibian also mentioned is it's really important for the endometriosis to get very well treated. And I know a lot of gynecologists are very surgically skilled, but endometriosis specialists see and they perform these surgeries day in and day out. And that detecting or identifying endometriosis that can present with at various stages and various colors and different lesions, if the surgeon is not as experienced, they may miss those. And as I mentioned before, we don't know what stage the patient will have until the surgeon goes in. So I've also have had unfortunate cases where we would send the patient back to their gynecologist, and they would undergo the surgery, but it would end up being stage 4. And when it's stage 4 and they don't feel comfortable, then they need now a repeat surgery. So we also don't want that to happen, where patients have to undergo 2 surgeries. And that's why it's so important to send patients to surgeons who can take care of stage 4 endometriosis. That can be stuck to bowel. It could be bowel-related surgery. And Dr. Najat does such a thorough surgery that he does proctoscopy, cystoscopy, like every aspect of where the endo could be. He does such a thorough job that I know that if a patient does go to an endometriosis surgeon like Dr. Najat, they will be treated completely. And one thing Dr. Najat likes to tell my patients afterwards, like, now you can try naturally before doing the transfer. Just try naturally for a few months. And some of my patients have gotten pregnant naturally. And it's been such an honor to work with surgeons who are extremely skilled. And I always tell Dr. Najat he can't retire, because what am I going to do with my endometriosis patients? But yeah, Dr. Najat, thank you for always taking such good care of our patients. And I do think that endometriosis is not as much talked about as it needs to be, even in our fertility field. So I'm so glad that you're doing this webinar to bring more awareness. And now I'm also even talking to my egg freezing patients about this too, because egg freezing, they just think that, okay, well, we'll freeze some eggs. And then when we talk to patients about their symptoms, I'm like, you may have endo, and you probably should get this properly managed up until, when you're ready to have a kid, because you don't want to go like 5-10 years without this disease getting managed and then getting worse. And when you're finally ready to start a family, and then having severe disease. So I'm now trying to be very proactive with my egg freezing patients too, when they come to me for consultation. And if they have this question of, symptoms, or I think that they may have endo, then to really talk to their OBGYN or go see an endometriosis specialist.
Dr. June, thank you very much for your thorough explanation. We really appreciate. There is a question on the chat that I like you to address it. Can you see it, or should I read it? Do you see it on the chat?
Oh, I see. 1 second.
From Zizi Mode about some recent research paper found there is no benefits in IVF outcomes. I have my own opinion, and I'm sure that the Cameron Judge has too, but I wanted to see what you think.
I can't, for some reason, I can't see them. I think it was it a direct message for the.
No, it is on QA answer on the right.
Oh, Q&A. Okay, sorry.
That's right.
I'm not very technically savvy. Okay, 1 second. So some recent research papers found that there is no benefit in IVF outcomes of patients with endometriosis who had laparoscopic surgery to remove endo versus those who did not have surgery, especially that any surgery might have side effects like making new scars and adhesions. Where's the best treatment for a patient with endometriosis who wants to conceive? In what circumstances the surgery would be recommended? How about the deterioration of egg reserve as a result of endometrioma removal? Even some papers did not report egg quality improvements following the surgery in ovaries and removal of endometrioma. Wow, that's a big question. Okay, so I'll address some aspects of it, and maybe Dr. Najat and Najat, you can chime in. So before, I mean, surgery is not something to be taken lightly. I completely agree with that. And I try to look at the entire picture. So if a patient like Alyssa, who has very good number of embryos, and the patient is concerned about surgery and the potential risks. And first, let me step back. In terms of being concerned about the risks of scarring and damage to surrounding organs, and that's why we stress again how important it is to have this surgery if the patient decides to have it done by a specialist, because endometriosis is a very tricky disease. It's, you know, there can be lots of scarring in there that is scarring some very important organs such as the bowel. And so you do want to have an excellent surgeon to be doing this. And so I'm not sure about these studies, who were the surgeons, et cetera, but there are a lot of surgeons out there that say that they are endometriosis specialized, but are they, truly doing multiple difficult stage 4 endo surgeries day in and day out? I don't know. And so it would be dependent on, I would not send patients to just any surgeon. I would have to feel confident. And I always tell my patient, since I was a resident, I've been in Dr. Najat's cases and I know how he operates. So that's why I trust him to take care of my patients. I said, I would send my family members. I would even go if I had endo to Dr. Najat. So it really depends on the surgical skills to have, in terms of potential complications that patients can have. And so, like I said, I look at the big picture. If the patient only has one embryo and they're not going to do any more IVF cycles, then I really try to explain to the patient that if we're going to do everything possible, then, and we think that you do have endometriosis, then surgery probably may be the best option, because it will not only treat, but it diagnoses. And so the most frustrating thing is when we transfer a genetically normal embryo and they don't get pregnant. Then we're scratching our heads. What happened? This beautiful embryo did an implant. What happened? And if the patient has, let's say, surgery and they have stage 4, and we transfer an embryo and doesn't conceive, let's say, then we have to also think about other options or other pathways to kind of figure out what else could be going on. But if you don't have that diagnosis, and if the patient had stage 1, then we know that probably endo may not have been a significant contributing factor to her fertility issue. And so it's just good for us to know how to plan for the future, depending on what the outcome may be with our treatments. And so just to have that diagnosis is key. And then, as I mentioned before, getting that treated. And endometriosis can come back. And so knowing what the severity is, we will then know how to manage, even after the patient gets pregnant and delivers, that if they have severe disease, I tell patients you need to go straight back to Dr. Najat and ask what type of suppression you need to be on until you're ready to have your second child or your third child. And so I kind of answered some questions, some of those questions all at once. But in terms of the deterioration, I think Dr. Talibian also mentioned that too. Yes, with the endometriomas, if you're not careful in removing those cysts, can you remove some of the healthy ovarian tissue and diminish? But then I also tell patients about the pros and cons. We don't automatically, Dr. Najat has been great. He would tell me, oh, this patient has a 2-3 centimeter endometrioma. Why don't you bank embryos first, and then I'll do the surgery afterwards. He doesn't tell patients we need to get this removed, and because he also understands that there could be that decrease in reserve. But then if the patient does IVF and we get poor quality embryos, and then I discuss it with Dr. Najat, and we think, you know what, if this patient has poor quality embryos, maybe could the endometrioma be affecting the egg quality? And I know endometriosis surgeons believe in that. And so then we say, okay, well, why don't we have them do the surgery first? They get all the endometriosis treated, then we do subsequent cycles, and we have seen improvement. Anecdotally, we have seen improvement. And it's so surprising to see sometimes higher euploid rates, improvement in the grades of the embryos. So we have seen that anecdotally, but we don't take surgery lightly. I don't think even Dr. Najat's take surgery lightly, but it can be extremely beneficial for our endo patients.
I like to, oh, sorry, I'm sorry.
No, I just want to thank you, Dr. June. There's only one more last question that you may want to address it. And then the question is, can I ask what is the right amount of recovery time after surgery to optimize my next egg retrieval? I usually, and Dr. Talibian, when they send the patients to me and I do the surgery, we put them on hormonal suppressive therapy like birth control pills, and then I will send them back to when they want to start the next IVF. So what is your experiences? When do you start the next egg retrieval after the surgery?
So do you want me to address, or do you want me to, let me say something here. I want first to thank the brilliant answers of Dr. Sunny June and the way that she really hit the nail on the head. The best things have to be done properly. And a pilot who is very experienced, who can take a big jumbo jet very safely around the globe. But if he give that big jumbo jet to an inexperienced pilot, you are in danger. Surgery is like that plane that has to be done by a very experienced surgeon. If the surgeon is not experienced, they would have results of the person who had that question. I bet you many of those surgeons who do those studies, their experience is very, very limited with endometriosis surgery, and they are not adequately trained to recognize and treat the patient, because our experience is 100% different than that published paper. What the mind doesn't know, eyes don't see. You cannot deny the numbers and the facts. Dr. Sunny June, Dr. Talibian, and Dr. Evazadeh, Dr. Beck, that we routinely work with our brilliant infertility specialists, Dr. Sobo, that we work with them. They are dedicated to their patients, and we see these patients routinely, and numbers don't lie. I have my fellows, Dr. Shruti Agrawal, here online, Dr. Deborah Lee online, and I know Dr. Farnajaz fellow is online. They are doing the research. These patients, they get pregnant much better after the surgery with repeat IVF, or as Dr. Sunny June said, spontaneously, many of these patients, they get pregnant. But the surgery should be done properly, correctly. If the surgery is not done properly, of course it could cause harm. Anything should be done properly. That is why we are training surgeons. The lack of adequate surgeons, unfortunately, is a harm to the patient, because endometriosis is an aggressive disease, is a progressive disease, is associated with higher rate of cancer, and you cannot simply put your head in the sand and say it doesn't exist. Simply, it is, if you have a headache, it is okay to take Tylenol. But do you know if the headache is because you are talking too much, or it is allergies, or it is a cancer? In cases of the cancer, it's better to diagnose it early, because you might be able to do something. And that is the problem with the studies. We do not have enough surgeons to treat endometriosis. Endometriosis does not respond well to doing nothing, and it could progress. It could compromise the ureter and kidney dies. It could compromise the bowel. It could grow on your nerves. And even if it has no symptoms at all, ultimately, these patients, they have a higher risk of cancer. If they may end up with higher risk of ovarian cancer. So we should not put our hand or head to sand and ignore it. In our hands, in our data, when you treat them well, the infertility couple, they get pregnant and they need help. Somebody should help them, and studies should be done by proper place. Come and see what we are doing with our data. Our fellows are doing all the research, and the results are there. So we need to address the issue of endometriosis properly. We have had wonderful, wonderful guests. I know we have gone a little bit over, but I'd like to thank all the participants, Dr. Farnajat, Dr. Talibian, Dr. Sobo, Nina Pero, and Dr. Sunny June, and Alisa, Corey, and Leah, and also all of our fellows, Dr. Agrawal, Dr. Lee, and Dr. Savio, who has been Dr. Paul's fellow, who have been online, and also our organizers at the Worldwide EndoMarch, Dr. Zoe Pennington, and the rest. We thank you very, very much. This is a very important issue. I know I am talking out with passion, but again, the passion is to raise awareness about endometriosis, find out what is the best treatment. Ideally, we hope that we prevent it at all. And we thank you very much again. Next month is going to be the Worldwide EndoMarch. All the celebration is going to be the whole month, and all the progress that we have done, many of you around the world, have sent your videos, your participation is going to be virtual. And the month after, we will continue this address with another REI from LA, Dr. Kelly Beck. I thank you very much, and forward we go. Bye-bye.
Thank you very much. Have a nice weekend. Thank you.
Hello, greetings from Turkey. I'm Associate Professor Dr. Bahar Yüksel, an endometriosis specialist, surgeon, and co-founder of EndoTurkey. My story about endometriosis has started in Stanford University and continued with Endo Foundation in States. And when it comes to my country, my story started when I met a wonderful patient who has a sciatic and diaphragmatic endometriosis. We together started up a new foundation called EndoTurkey. And in EndoTurkey, we are aiming to raise awareness about endometriosis, start foundations, and raise awareness about scientists to continue studies about endometriosis. Since we have been here, we have been supporting patients, and also, as I said, we have been supporting scientific research. The first epidemiologic research about endometriosis has also been done in Turkey by our team, which showed that endometriosis in Turkey is really something more than 1 in 10. And this search led us and taught us that we need to aim all the girls starting from teenagers and going up to even after menopause, because all women might have endometriosis and they might suffer with endometriosis for years and not even diagnosed once. So even in Turkey, like the other parts of the world, we are really struggling about endometriosis, and the awareness is the thing that has to be taken first. With the support of all our sister organizations from all over the world, we have been continuing our organizations, we have been continuing our projects, and we are in a place that we really love right now. We love acting together, we love gathering together different disciplines, including social sciences, scientific researches, and even medicine of different types. Because we believe endometriosis is a disease that cannot be solved in a single hand, because when it is endometriosis, never one size fits all.
Hi everyone. So, how to thrive with endometriosis through lifestyle hacks. Anybody into that? Sound good? All right. So, before we begin, I'd like to share with you a story about this gentleman in this image here. And that's my grandfather, Zubair Ahmed. So, we went back to 1972. My grandfather here, Zubair, decided to take a chance amongst all the turmoil that was happening back in Bangladesh with the independence, post independence for Bangladesh was happening. It took a toll on his family. I remember him telling me they were running through bullets, past bullets, and had to hide in people's houses. And it was a very traumatic and emotional time for not only him, but his wife and his 3 very young children at the time. So he took it on himself and he said, you know, in order to protect my family and look for a better world and education and work for the future, I'm looking to emigrate to the UK. So he could have stayed in Bangladesh amidst all the uproar and the chaos at the time with his mom, who was quite elderly back then. However, he decided to go through the many obstacles in order to come to the UK, which involved going through racism, acceptance, learning a new language, new culture, and a new way of work. So the reason that I'm telling you this is oftentimes the familiar way to go, the way to go is familiar for us to go continue the same route. And living the same way, thinking that there will be a different outcome, will not always give us that outcome. So how does this apply to endometriosis, I hear you wonder? So going the conventional route, hormone pill after pain medication, after continuous surgery, can take a toll on, on an individual. So as much as surgery and on hormonal therapy can be a good crutch, surgery is also a good way to actually clear up those lesions before actually going a renew and making habit changes to make sure we continue make sure that endometriosis doesn't come back or as quickly as it possibly could if we don't make any changes to ourselves. So what I want you to do is have a look at just to have an open mind and see what else is there that is out there that can actually help you to better manage your endometriosis, and take the courage to take the first step. So, is it really possible to thrive with endometriosis? So, I myself, so my name is Roxana Ahmad. I myself am a women's health coach, and I've specialized in endometriosis. And what I use is the functional nutrition approach along with functional medicine approach as well. I've specialized in endometriosis, understanding the complexities of the disease, and how understanding the complexities then allows me to be able to understand things that may trigger it. So I've had personally 20 years of personal experience with endometriosis and adenomyosis. So what will we cover today in today's session? So first we'll look at understanding the complexities of endometriosis. We'll look at implementing practical lifestyle hacks and how to make habits stick to thrive with endometriosis, which is key. Because a lot of the times you can do all the things, eat the right foods, do the right exercises. However, if you just do them for a month, that's not a long-term solution. So we're looking at how do we actually incorporate that habit change for a long-term solution to be able to thrive with endometriosis. So first off, we go back to the ideologies of how historical ideologies of women actually shaped our health history today. So here is an image of Aristotle, and he once said, "A woman is a deformed or mutilated man." And unfortunately, there is still a male bias that exists in the medical culture today. However, things are changing. Unfortunately, it was only until the 1980s where we saw the formation of advocacy groups such as Society for Women's Health Research, and actually they were able to highlight disparities in the medical research. So I think this is promising to see that still as much progress still needs to be done. We are making small baby steps towards that. Okay, understanding the complexities of endometriosis. Endometriosis 101. So let's get to endo. What is endometriosis? Endometriosis, or endo for short, is a complex inflammatory disease. It's where the tissue that's similar to the lining of the uterus, so inside the red part here, inside the uterus, but it's not the same. And it's important to know that it's not the same because the way the treatment options would be different to treating the uterine lining rather than the endometriosis, which is actually growing outside of the womb itself. So where has endometriosis been found? It's been found all over the body. So tissues can have been found in and around the pelvis area, on the fallopian tubes, on the surface of the uterus, on the lining of the pelvic cavity, even on the bladder, on the bowel, on the rectum. And also there have been rare cases as far as the nasal cavity and the brain, as well as there's more and more information coming about thoracic endometriosis, where you have endometriosis growing on your diaphragm as well as your lungs as well. So the fact that it grows in other parts of the body is why a hysterectomy is not a cure for endometriosis. So each month, these cells react in the same way to those in the womb. They build up and then they break down and bleed. So unlike the cells in the womb that leave the body as a period, this blood has no way to escape, and it creates a sticky scar tissue, which is similar looking to raw chicken skin, if you've ever seen it on Dr. Cameron's endometriosis surgeries. You can see it actually looks a bit like chicken skin, and it's quite fibrous. This connective tissue creates these types of adhesions, which cause organs to stick together, fortunately causing a lot of pain. So we know in the UK perspective, there are around 1.5 million women who are assigned female or those assigned female at birth are currently living with this condition. So regardless of race, regardless of ethnicity, endometriosis does not discriminate. It can actually affect you all the way from puberty to menopause, so from your reproductive years. However, the pains can be impacting you maybe sometimes for life. So what theories are there of how do we get endometriosis? So there are two main theories. You've got the retrograde menstruation theory, which is essentially the blood flow flowing backwards into the fallopian tubes, pelvic cavity, instead of actually leaving the body through the vagina as you would normally have through menstruation. However, 80 to 90% of women actually have retrograde menstruation. So, and it's also been found in rare cases in men, endometriosis. So that's not a full, complete reason as to how endometriosis can come about. There are holes in that theory. And then the second theory that I'll touch on today is called the coulemic metaplasia theory. So the metaplasia theory actually refers to a situation where the cells in the body change into different types of cells, so the stem cells. And in this context, it's like saying the cells from structures in the body that are like those seen in early development, i.e. the Wolffian and the Mullerian ducts, actually remain and turn into these abnormal growths called endometriotic lesions when they're exposed to the hormone estrogen. So let's learn a little bit about lesions. So there are three types of lesions, peritoneal lesions, and they can be categorized into three distinct types. You've got your red, your black, and your white, symbolizing different stages of the disease. So your red lesions in this image here, in image C, they indicate the initial phase of the peritoneal endometriosis. So they're characterized by this high vascularity, lots of blood vessels, and lots of activity happening in that area. And then you've got the black lesions, which are in images A and B. So B showed this puckered type of black lesion. And they actually signify a second stage representing advanced endometriosis. And then lastly, you've got in image D, the white lesions, and they denote a healed endometriosis, indicating a latent inactivated state. And it's important to understand that the location of the lesions can actually determine the specific areas of where the pain is experienced as well. So let's talk a little bit about diagnosis. So the current gold standard method of diagnosis is via laparoscopic surgery in the UK. So this is going off UK data. However, a skilled radiographer who is trained specifically in identifying endometriosis can sometimes pick up on endo on transvaginal scans or MRI. And I've heard even some other cases of ultrasound. If you have a very specialized radiographer who knows what they're looking for, they can sometimes be able to see endometriosis, especially if it's the deep infiltrating endometriosis, which is more prominent on the scans itself. And in the UK, it takes, sadly, on average 8 years to get a diagnosis of endometriosis. The reason it is taking this long is because endometriosis, the symptoms of endometriosis, they overlap with a lot of other conditions as well. And that's why it's so hard to diagnose, fortunately. And also we need to have more specialists to be able to know what they're looking for as well. So I share this image here, which shows the relative locations of the digestion and absorption of nutrients in a healthy gastrointestinal tract. And what you can see is along the gastrointestinal tract, nutrients are being absorbed at different parts. And the reason I'm sharing this is because if, for example, you do have deep infiltrating endometriosis and a bowel resection may need to be done, it's important to know. So what happens is in that procedure is they take a chunk of your bowel out and then they stitch the two parts back together. And why it's important to know about this is because if there's a chunk of your intestine that has been removed, for example, if it is absorbing a lot of the B12, then you're no longer able to absorb the B12 because there's that chunk that essentially was doing that job is no longer doing that anymore because it's been removed. So it's making sure that you then have adequate supplementation of B12 to make sure you're not becoming deficient in that. So let's look a little bit about risk factors. So typically endometriosis is only active after starting your period or menopause. And some common risk factors are starting your periods early, having menstrual cycles greater than 30 days, and also if you have a family history of endometriosis, there is an increased rate of you and likelihood of you having endometriosis. So what do we understand about the disease? Right, we know that there are microbiome imbalances. So endometriosis appears to be associated with an increased presence of Proteobacteria, Enterobacteriaceae, Streptococcus species, E. coli across various microbiome sites. And we also know that stress can drive further development of endometriosis as well. That's why other modalities, lifestyle changes can actually help to alleviate. If we can alleviate the stressors, then we can actually in itself then help with reducing the development of endometriosis through lifestyle changes. So other things that we know about endometriosis is there are epigenetic factors to consider too. Epigenetic factors, which is behavior and environmental factors, they can actually cause changes to the way your genes work. So they can either switch them on and off, which is exciting news. So it's also another lever that we can pull on through lifestyle changes and knowing that the behaviors that we're acting on, the environment we're living in, the pollutants, contaminants that are going into our system, if we have more control of those, we can actually then help to better manage endometriosis. As I mentioned at the start, endometriosis is an inflammatory disease, so there are inflammatory factors involved as well as hormonal imbalances. There is this estrogen excess link. Why I say excess and not dominance, because in the medical world, it's important to know that in relation to progesterone, they need to be looked at together. Then we look at looking at the lack of optimal function of your detoxification system. So how is your liver performing? Is your liver able to detox the toxins that build up during the day effectively? And also we know that there's a nervous system function dysregulation link too. Just a note on this as well, there was actually a study done involving around 1,800 cases and just over 2,000 controls. And they saw that the key enzyme for estrogen metabolism, the COMT gene, and CYP1B1 polymorphism were found to actually contribute to the risk of endometriosis and adenomyosis as well. However, when the data was analyzed by ethnicity, the risk was associated in Asian populations, but not in Caucasian populations. So that's something interesting to think about as well. So pain perception. So this is a really interesting study where they saw that chronic pelvic pain being one of the most painful symptoms of endometriosis. But they weren't sure about how the nerves from the pelvic organs, i.e. the female reproductive tract, could actually sense and send pain signals to the brain and how the brain was actually processing those. So they tested sensitivity of nerves around the mouse here, the sham mouse, and the endometriosis mouse by actually poking them, I know, not very nice, to see how they reacted. And they also looked at how pain signals traveled from the vagina to the spinal cord, and they checked for signs of inflammation and changes in the spinal cord. So what they found was the results showed that the nerves around the upper part of the mouse vagina became more sensitive in endometriosis. So the pain signals from the vagina to the spinal cord also increased in mice with endometriosis. So these findings actually suggest that endometriosis changes how nerves work, both near the reproductive organs and in the spinal cord. So I think understanding these changes could help to find better ways to relieve the pain caused by endometriosis. So just to quickly go over the differences between endometriosis and the uterine lining, the endometrium. So we know endometriosis itself is growing outside of the uterus. It can actually produce its own local hormonal microenvironment because it creates its own estrogen by promoting, which actually promotes growth and the persistence of these lesions. We know that there is chronic low-grade inflammation in endometriosis, and the endometriosis lesions themselves exhibit lower levels of progesterone receptors. And then in comparison to the uterine lining, what you can see is that the tissue is inside the uterus, and it thickens and sheds cyclically in response to hormonal changes during the menstrual cycle. And then you have the endometrium, which is responsive to hormonal changes. And then with the endometrium, it has high levels of what's called estrogen receptor alpha and lower levels of estrogen receptor beta, whereas endometriosis has the converse of that. And then also uterine lining, it has the inflammatory response in the endometrium, but that is controlled, it's short-lived, and it resolves when you have your period. So current treatment options available, you have the contraceptive pill, hysterectomy is offered, repeat surgeries, continuous and stronger usage of painkillers, other birth control medications as well. So this is a really interesting slide. I ran a survey with over 200 women with endometriosis, asking about how they would describe endometriosis and the impacts that it has on their life and the quality of life. And these are some of the descriptions that they came back with. So some of the big ones, you've got fatigue, just above my head here. You've got this pulling pain. You've got this, it's that way here. There's some people are saying it's giving them reduced quality of life. However, there's other positives to come out of this. People are saying it's a beast to be tamed. You know, it's something that they feel they want to get control of, which is positive. Okay, so implementing practical lifestyle hacks. So before we get into practical lifestyle hacks, I'd like to share a little bit about what health coaching is and how it can help you. So as an endometriosis women's health coach, I specialize in providing support, guidance, and endometriosis specific resources for you. So some reasons why you might consider working with an endometriosis women's specialist is to make sure you get up-to-date information, to help you to educate yourself about the symptoms, the treatments available, your management strategies, and also to clarify any misconceptions that you might have about the disease. As a coach, I also provide you with support, empowerment in dealing with endometriosis, as it can be emotionally challenging, and to help you to encourage you to navigate those complex emotions that come along with this chronic illness itself. So as a health coach, I do look at helping you to understand more about the lifestyle management of endometriosis, how it can impact various aspects of your life, including diet, exercises you can do, stress management, and ways that it can impact your relationship. So navigating those helps you develop a personalized lifestyle management plan to address your unique needs and challenges. So what I do is I take an integrative approach, meaning I collaborate with your healthcare team, your doctor, your physiotherapist, whoever else may be on your team. And I look at you from a whole body perspective, addressing not only your physical symptoms, but also your emotional and your spiritual aspects of the condition too. So a little bit about my journey as well. So what brought me to health coaching is I have personally had experience with adenomyosis and endometriosis ever since I started my menses. I was having very heavy periods, bleeding so much for months on end that I'd actually become anemic. And then after becoming anemic, I was put on iron tablets, which then made me constipated, and the constipation led to fissures, which then meant that I had to have Botox injections in my rectum to help with the healing process, constant medications, constant hormonal therapies, contraceptive pills, painkillers, stronger and stronger painkillers, for 15 years, colonoscopies, inflamed eyes, jaw pain from the stress in the body, grinding jaw where I've actually got bone loss in my right side of my jaw, whole body aches, cold feet, cold hands, migraines, passing out on the floor, feeling like what I once described that my period passing out on my body felt like a jellyfish. It was disgusting, but that's the only way I could actually explain it, because it was so heavy and big and clotty. It felt like I was actually giving birth to a big blob, and it was just really not. It was just a really very awful time. But thank God, through looking at ways to manage it through lifestyle management, lifestyle changes. When I talk about lifestyle changes, in a nutshell, that is looking at your diet, is looking at your nervous system, is looking at your mental health, is looking at any past traumas as well. So we'll get into that a little bit more. Okie doke. So trigger factors. So if you imagine yourself, you in the middle here, and there are you sitting in this soup bowl, soup of you. And in the soup of you, you've got all these different trigger factors that are coming into that soup bowl, which are impacting you. So one thing here, we've got your A, B, C, D. So that's possibly your nutrient deficiencies. Are you eating enough? Are you juggling too many things at the same time? Are you not drinking filtered water? Are you smoking? Do you have microbiome imbalances? You wearing lots of makeup which have endocrine disruptors. So endocrine disruptors are actually chemicals that interfere with the body's hormonal system. They're actually responsible for regulating your hormones. They can actually mimic, block, or interfere with the production, release, transport, metabolism, and the elimination of natural hormones in the body itself. So this is why it's important to understand, what is our load? What's the load on our body? What's this? What are we putting? What are these trigger factors into the soup of us here in this bowl? Here on the bottom right, we see trauma. So what past traumas are contributing to having us in this contributing to our pain? So I don't know if you've read the book Gabor by Gabor Mate, The Body Keeps a Score, and he talks a lot about how the traumatic events in our childhood can actually shape us and cause disease in our body, which is an interesting take as well. So moving on quickly, so what I use is the RND 3-pillar approach, and how this works is from the bottom up. So first look at reducing inflammation, calming your nervous system, and then look at by neurosensory daily exercises, and then we look at the nourishment. How is your gut functioning? Do you need support with your digestion? Are you chewing your food 40 times? 25 to 40 times is what is the recommended amount to aid digestion. How are you? What's your detoxification like? So do you have a sluggish liver? Are you actually able to remove toxins out your body efficiently? If not, then that's a load on your body, which is actually contributing to inflammation as well. So some of the easy things that we can start to do: balanced blood sugar diet. So why I've put this as number one is because eating healthily, a lot of the times people think eating healthily is just eating vegetables and salads. Unfortunately not. We need to make sure we're having sufficient carbs, sufficient protein, sufficient fat. If we need fat for cholesterol then is the raw material for then producing our hormones. And then we need protein and building blocks of life, your amino acids. You need carbohydrates for breakdown into glucose for energy. So it's important that we have a balanced plate for every single meal. Even breakfast, people think it's strange to have protein for breakfast. When you have endometriosis and your body is constantly in this state of inflammation and bleeding out, it needs to be repaired to repair and restore. And what do we need? We need those building blocks, protein, as well as sufficient carbs, as well as fat. So beyond food, what other things can we do? Beyond food, we can actually look at, first off, can we celebrate everything? Celebrate everything. It shifts our mindset, never go to sleep angry, making sure you drink plenty of water. Time and time again, I hear a lot of my clients say to me, it's winter or it's winter time. I don't feel like I need that much water. Your body needs water. Your cervical spinal fluid actually replaces itself a number of times during the day, and that requires a certain amount of water in itself. And what that does is bathes our nervous system. So if you're not getting sufficient amount of water in your day, it's actually you're doing yourself harm by not doing that. And then other things that we can look at: sunlight exposure. Going backwards. Sunlight exposure. So daylight enhances our nighttime sleep. A lot of women with endometriosis tell me one of the number one things that they have, apart from the pain, is fatigue. The fatigue the pain is actually tiring to have. When you're in so much pain, it just takes your energy, it zaps your energy. So daylight enhances the nighttime sleep. So if you're exposed to bright light during the day, you will experience improved ease in falling asleep at night. So in a study, subjects under bright lighting not only experienced quicker sleep onset, but also reported having higher sleep quality. And so that means, therefore, morning sunlight actually contributes to establishing the conditions for a more restful night's sleep. And also, not to mention, it is a serotonin boost. The more bright morning light stimulates the production of serotonin, which is actually a neurotransmitter, which contributes to the feelings of well-being, happiness, and overall mood too. And a fun fact here, 30 minutes after sunrise and sunset, there is neither UVA or UVB sunlight, UVB. So sunlight is 42% infrared light, which can actually stimulate your collagen production, increase bone healing, and heal wounds, especially beneficial for endometriosis. I myself used to get a lot of inflammation, sclerosis, that's what they called it, redness of the eye. There wasn't any cause or reason for that. I'd go out 10 minutes in the sunlight in the early morning and it would clear up straight away. If I hadn't done that, I'd go days on end where my eyes are just both bloodshot red. So just something to think about there. Sleep strategies. Easy hack. So more intense chronic pain is actually associated with lower sleep quality and alteration in mood. So first off, I would ask yourselves to assess your sleep. Ask yourself, are you getting enough sleep? Understand that sleep is actually crucial for relaxation as well as memory processing. So there are four main stages of sleep. You've got your beta waves, which actually signify your wakefulness. You've got phase 2, which is your rapid rhythmic wave activity, where you're actually processing your memories. And then you've got phase 3, which is a deep sleep, where you're in this delta brain wave, and that's where repair and restoration happens. And then you've got the REM sleep, where you have the most brain activity, where you're dreaming and you're processing emotions. So how to make habits stick and to thrive with endometriosis? So something that I always say to my clients is there's only one thing, there's one thing to do, always to do all the protocols. However, fundamental mindset shift is actually what sets them apart in being able to thrive with endo rather than get by with endo. So what I say is create a new identity of who you want to be, because motivation yields the short-term results. However, what breeds long-term success is discipline. So this is where the coaching really plays a huge part in identifying those conflicting beliefs, using behavioral change psychology and strategies to address and weed out the obstacles that are in the way of your healing. So this is just a model of what I share with my clients. So first off, identify what your identity is, the methods around that being what it is that you have to do to get to that, and then the outcome is basically refers to what you get. So the methods pertain to what you do. So for an example, imagine how we typically set goals. We might start with saying, I want to lose weight, or I want to get stronger. If you're lucky, someone might say, okay, that's great, but can you be more specific? So then I want to lose 20 pounds, or I want to squat 300 pounds. So these goals are centered around outcomes, not identity. Unless you say, I'm someone that goes to the gym, you're identifying yourself with someone who goes to the gym. You're a gymmer. So how do we make these stick? So one habit at a time, focus solely on one habit at a time to ensure success. Starting multiple habits at the same time simultaneously often leads to failure due to the lack of focus. So start with short-term changes. People don't generally like long-term commitments. So instead you can start with a month and then ask yourself how they're going and renew those commitments at the end of each month. Form core principal habits. These are the habits that have positive snowball effects. So throughout all areas of your life. For instance, daily exercise gives you more energy, which leads to less sugar cravings and caffeine, which then leads to a seriously improved quality of life. So start by defining your core principal habits and then come back to those habits whenever the need arises. Example, when you fall off the bandwagon. So, and also celebrate your success. and praise yourself for each accomplishment. Ring up one of your girls and just have a win session each, and or just brag about all the things that have happened for this week and what they've been doing. And I do this myself with one of my close friends, and it's such a nice way to actually get to know them better and how they can get to know you better as well as making you feel really good after the call too. Okie doke. So if you are interested in reaching out, for something bigger and taking endometriosis management to the next step, please get in contact. For the first 3 people, I am offering 30% off exclusively. I want to rattle your cage and get in your face, even though I'm not literally in your face, so that you can see that there is a better way. I don't want you to stay on the same old path expecting a different outcome. I want you to reach for something bigger, more intentional, more aligned with who you are at your deepest level. All right. Thank you. Speak soon.
Good morning in the West Coast. Good afternoon in the East Coast, and the rest of the world. Good morning, good day, good noon, good afternoon, good evening, and good night. It is an honor and privilege to be with you again. I'm Dr. Kamran Najat, the founder of the Worldwide EndoMarch on Endometriosis Day. And we are very honored and pleased to have another extraordinary panel today to discuss the role of endometriosis in patients with infertility, undergoing different procedures of assisted reproductive technology to get pregnant. And they have received many, many questions. The panelists, beside my co-founders, Dr. Spar, Sina, and Azad Nejad, are the esteemed colleagues from New York, Dr. Shiva Talebian, a reproductive endocrinologist, and from San Francisco, a very esteemed colleague of ours, Dr. Amy Abadzadeh, and from the Los Angeles, another all very esteemed REI, Dr. Kelly Bake. All of them, they know each other, and it is a fantastic team we have put together. The mission of the Worldwide EndoMarch since 7 years ago, when we started, has been to increase awareness about endometriosis and empower women and young girls with endometriosis to take control of their life to a large degree. And since in its inception, it is in more than 63 countries, and many other organizations have followed suit, and we are very happy to see this progress is going on. And the virtual meetings have been very successful. And this meeting, we have received many questions. Each participant would answer one question, and at the end of all the questions that we have received, we have tried to answer the questions that addresses almost everybody, because the questions, there were too many. So many of you might not see exactly yourself, but similar to you, we have tried to choose the questions that are not repetitive. And the next session, again, we have taken a poll from you as you have requested. The next session next month will be about endometriosis, pain, and the bowel endometriosis. So at this stage, stopping the introduction, I would start with the first question. And the first question is from Dr. Sina Nejad, and the question is, I am 27 years old and I have deep fibrotic endometriosis. I have had surgery recently, and I would like to know how long do I have to get pregnant? Dr. Sina Nejad?
Hello, and thank you for the opportunity to be with you today. Fertility enhancing surgery with endometriosis, it requires additional skill, and it's not just limited to excision. Considering the fact that this individual is 27 years old, and if the condition I am sorry, I had to unmute. It's a pleasure to be with you today, and this is a very good question, specifically that the individual is 27 years old. Considering that if the sperm factor, the condition of the tubes are good, then it all has to do with the skill and experience of the surgeon who performs treatment of endometriosis. I'd like to reemphasize excision of endometriosis for infertility patient is not necessarily always the best choice. The surgeon who performs endometriosis surgery requires more knowledge and skill than just excision. Considering that if the surgeon has performed adequate treatment and there is no harm to the ovaries and the tubes, this person could try minimum 3 months. In most cases, I allow my patients to go 1 year without interfering. And the chances are very good. In 1 year is more than 70 to 80%. Thank you. You are muted too.
I think, Zoe, please try not to mute me. Just let me be unmuted, please. I appreciate it. So the next question is for Dr. Shiva Talebian. She's in an RUI in New York. Dr. Talebian, the question is, patient says, I am 37 years of age. I have had multiple failed IVF, and I have had PGD, and I have no symptoms at all. What is my next chance? How do I know if I have endometriosis or not, and what should I do?
Great. So this is a great question, and I think a very common patient scenario that I see in my practice in New York City. So, historically, when IVF was not as successful, meaning we weren't as good in the IVF lab at making chromosomally intact, high quality embryos, when we did the implants and the patient had a negative pregnancy test, we just typically blamed it on the embryo. But nowadays, we're really very, very good at making high quality chromosomally intact embryos. And when patients start to fail repetitively, at this point, we have to start thinking outside of the box, and that it might not just be embryo related, and it could be something related to, is there an implant failure issue? Is there an immune issue? Is there blood flow issues? But one of the things we have to start to consider in this scenario is, could there be, significant endometriosis? Maybe the woman doesn't have severe pain. Maybe we don't necessarily see evidence of the endometriosis on the ultrasound, but could there still be a fair amount of endometriosis and inflammation? And could those negative inflammatory factors in the pelvis somehow potentially be preventing implantation to occur? Again, 15, 20 years ago, when we first started doing IVF, we thought, okay, endometriosis, just take the eggs out of that environment, make the embryo in the lab, put it in the uterus, and the patient gets pregnant. But again, as we've gotten so much better at making embryos and there are patients not getting pregnant, we do have to consider endometriosis in this exact scenario. So what do we do? And this is what's hard is, obviously you want a high level ultrasound, good physical exam, any evidence of endo on the exam. There is, a uterine biopsy that we many of us in the fertility world use called the receptiva biopsy. That's an endometrial biopsy that looks for a protein called BCL6 that, if this is highly positive, may suggest inflammation and endometriosis, and kind of go down that pathway. But for sure, in this exact patient scenario, it's something she should bring it to the attention of her RE and say, you know, maybe I do have inflammation, and what can we do to learn about it, and then what could we do to potentially treat it before another implant.
Thank you very much, Dr. Talebian. The next question is for Dr. Bake, who is in Los Angeles. And the question is, I am 33 years of age. I have had many failed IVFs. All of my tests are normal. Her husband's tests are all normal. And she said that it has been recommended to her to have adoption. She wants to know if there is anything else she can do.
So first of all, I think if you're having that, the questions that I would want to know is, when you had your failed IVF cycles, were these genetically tested embryos, and what cycle day blastocysts were they? Were they structurally normal as well? Because you have to look at whether an embryo is not just structurally normal, but also genetically normal. That's number one. Number two, especially before you move on to something like adoption when you're young, you may consider getting a second opinion with another fertility specialist, just to get a second pair of eyes. Even if everything was perfect, it wouldn't hurt you to consider getting a second opinion to look again and recheck, was everything truly normal? So you would want to look at the semen analysis. Was the morphology normal? Because the morphology is more consistent with the DNA potentially of the sperm. If the morphology is low, did you check a DNA fragmentation? For the woman, even if you're doing IVF and you know you're going to have an embryo transfer into the uterus, was the hysterosalpingogram performed? What you would want to know is the uterus perfectly normal? Is there anything that would prevent implantation? Even if the tubes are patent, you'd want to know, everything in our body should be asymmetrical. And so if your uterus is deviated to one side, or your tubes are technically open but dilated to a certain degree, one of the things I always think about is endometriosis. Because really what would cause the uterus to be deviated to a side is potentially if you have an inflammatory process in the pelvis. What it can do is it can cause scarring of one of the uterosacral ligaments that can cause that kind of deviation. So in addition to that, I'd want to make sure you have a normal ultrasound, your hormone profile. As we all know well, the thyroid, when you're not trying to get pregnant, should be above 4 to 5. But when you are trying to get pregnant or are pregnant, we would want that TSH to be less than 2.5. And finally, in addition to considering checking the uterine lining on a microscopic level, I know with Dr. Talebian, the receptiva is great, but I would also consider something called the endometrial function test, which I utilize quite often whenever there's recurrent pregnancy losses or recurrent failed cycles. It's a test that was created out of Yale with Dr. Kleiman, and you're looking at to see whether or not the lining develops properly, if you have the necessary proteins to support a live birth, and if there are inflammatory cells or an underlying infection. Whenever I've seen inflammatory cells, specifically macrophages or leukocytes in the lining, or evidence in someone who had completely normal tube lining hysterosalpingogram, but there's fluid in the on the biopsy sample that's suggestive of hydrosalpingo still, I have sent them to Dr. Najat specifically to have them assessed for endometriosis, even in these completely asymptomatic women. And then finally, I would really have them consider getting a laparoscopy and hysteroscopy to make sure there isn't something missed on the uterus. Yes, your uterine cavity may be totally normal in shape, but however, what if the perfusion's not normal? Maybe you have a pale area or a flat scarring called Asherman syndrome. And on laparoscopy, Dr. Najat has oftentimes looked for not only endometriosis in these asymptomatic women, but you can also see whether or not the fallopian tubes are perfectly healthy and normal and not just patent. So that's what I would consider before moving on to something like adoption.
Thank you very much, Dr. Bake. The next question is for Dr. Amy Avazadeh, that she practices in the San Francisco Bay Area, and the patient says she is 38 years of age. Her husband is 45 years of age. They have tried multiple IVFs and it has failed. They have had a receptiva test which showed positive for inflammation. And following that, she received a 3-month period of Lupron. And after that, she tried IVF again, and it failed. What are her options? What should she do, Dr. Eva? You are, please unmute, Kelly. Please unmute.
Hi, everyone. Can you hear me? Thank you again for having me. I'm Dr. Amy, and thank you to all the Dr. Najats and all the panelists for all the work that you do. So for this patient who's 38, who's been given a diagnosis of no explanation, I always say, let's see what the possible explanations could be. I have a very straightforward approach I use for each of my cases. I call it the egg whisperer diet. D is for diagnosis, and really talking through what all the possible diagnoses could be. And for someone who's over the age 35, you always have to wonder if egg quality is an issue. So at 38, we know each egg has about maybe a 25% chance of being genetically normal. So considering PGTA would be something important to do if this patient hasn't done it already. And egg quality has to do with age, and age stands for age, genetics, and environment. So whatever you can do that's in your control to be as healthy as possible also help with your embryo quality. So ask your doctor about your embryo quality. The I of the diet is IVF, and considering PGTA would be potentially helpful in this case. And the E is endometrial testing. So you've done the receptiva test, but maybe consider, just like Kelly mentioned, the EFT test. I also like the ERA test. I know that these are a whole bunch of acronyms, but your doctor, if they have experience with the receptiva test, they probably have experience with the ERA test as well. And maybe consider doing more IVF, freeze more embryos, and then as far as the transfer goes, pick a time in your life which is the least stressful as possible. And sometimes when you've been through as much as you've been through, it might be helpful to think a little bit outside the box. I'm not a huge fan of immune testing, but I think women who have endometriosis might have some immune system dysfunction that might be addressed with other types of treatment modalities that I won't mention here. It's important to talk to your doctor about those. Thanks, guys.
Thank you very much, Dr. Amy. The next question is from our niece, Dr. Azinejad, who is a reproductive surgeon. The question is, patient says she is 40 years of age and all of her adult life she has suffered from endometriosis. Now she has a 13-year-old daughter who has started having her period, and that is very painful. And she wants to know if endometriosis is hereditary. What is her next option? What should she do? Please unmute your microphone. Zoe, please keep everybody's microphone unmuted.
Okay, sorry. Thank you for that question. The genetics of endometriosis and inheritance of endometriosis is a complex issue, but most investigators and the authorities feel like it has components of polygenetics and environmental factors that affect endometriosis, which means that it's not one gene that is inherited, and the fact that you have endometriosis and in your case severe endometriosis, your daughter is more likely to have endometriosis. You can think of it as something like heart disease. If you have family history of heart disease, you're more likely to have heart disease, but that doesn't necessarily mean that you will have heart disease if you watch your diet or exercise. So this is similar to endometriosis. Your daughter is likely to have it, more likely to have endometriosis, but I think you should consult your, be aware of the signs and symptoms and kind of make sure she knows about it and seek help early on to hopefully have a more positive effect on her growing up without pain. And if it's the infertility is the issue, you can, once she's aware, she could seek help early on.
Thank you very much, Dr. Azinejad. The next question is for Dr. Farnejad in New York. He's a GYN oncologist. The question is, this patient has bilateral ovarian endometrioma. She has cysts on both ovaries in each side, and one of her IVF physicians didn't want to aspirate the endometriomas. Another IVF physician said, well, I like to aspirate these endometriomas. And so the other one said, no, I am concerned about ovarian cancer. The question is, what are the risks of ovarian cancer in these patients with endometriomas, and what should she do? What do you recommend?
Hello, everybody. It is a pleasure to be with you guys. And there are a couple of questions. What is the incidence of the cancer in patients with endometriosis? Overall, in the lifetime of the patients with endometriosis is a 2 to 3% that could develop cancer. So the risk is not very high, fortunately. However, ovarian endometrioma, the incidence of the cancer on that endometrioma ranges from 0 up to 15%. Depends how does the endometrioma looks like. If there is no solid component on the endometrioma and the radiologist could describe homogeneous type of cyst, the chance is almost 0. But if there is any solid component by the ultrasound or especially by MRI, then you have to be careful. That could be cancer. Or if the endometrioma gets large in a very short time, that could be a sign of the cancer. Overall, it is not a very good idea to aspirate any cyst that is suspicious for malignancy. So I agree with that physician that says do not aspirate. The other problem with the aspiration of the endometrioma or chocolate cyst is that this is old blood, and it is not very easy to aspirate the old blood. And there is a risk of the contamination of the endometrioma with bacteria from the vagina and get infected. So overall, we do not recommend to aspirate the endometrioma via transvaginal approach because there is a risk of the infection. Thank you.
Thank you very much, Dr. Farnajad. The next question is for Dr. Kelly Bay. And the question is, the patient says that she has a large endometrioma, 7 centimeter, and she would like to know if she should have her endometriosis and endometrioma treated before egg recovery or after egg recovery. What are your recommendations? What should she do?
When you have 7 centimeter bilateral endometriomas, I would recommend that you remove the endometriomas by excision therapy by an endometriosis specialist first. And the primary reason for that is because we know that when the endometriomas of that size in the ovaries are present, you may not stimulate as well even if you're doing an IVF cycle. Second, during the IVF egg retrieval, based on that large size, even if the follicles in the perimeter, it would be really challenging to avoid the endometriosis of endometrioma. And certainly we know that when parts of the endometrioma is aspirated in the follicular fluid, I consider it to be toxic to eggs. Immediately when I'm doing an aspiration of an egg and we see any chocolate fluid, our surgical tech immediately separates that follicular fluid from all the other tubes. The embryologist also separates it because we do worry that there could be a negative component in terms of how that egg will fertilize and develop. So I do think that, especially when you have 7 centimeters, to remove it first. Prior to surgery, I do recommend getting an AMH test done because you want to know what your ovarian reserve is prior to going into surgery. And you can check that post-surgery as well, and check a semen analysis, because during that time of healing, if there's a male factor, you can certainly help address and try to improve that sperm, because half the DNA is sperm and half the DNA is egg. So when the surgery is done, at the time of surgery, the surgeon can also reevaluate the fallopian tubes, not only to check is it patent, but is it perfectly healthy? Because as we know, fertilization occurs in the fallopian tube. If if you're going to try naturally. And also you want to know, where is the ovary located? Is it scarred down? Will it be possible to conceive without IVF? Would the sperm and egg actually be able to meet in the fallopian tube? So I think those are all important questions. And that would help determine what your treatment options are post-operatively. So based on, I always try to ask patients, my goal here is to find out, what are your fertility goals? If you want more than one child and you have a low ovarian reserve, should we consider freezing embryos first for the future? And then the treatment options would determine, after we harvest embryos, if they want more than one child, is to consider, okay, is your fallopian tube completely healthy and patent? Is the sperm perfectly normal? And then if it is, I usually would monitor cycles to try to help my patients conceive for about 3 months post-operatively with either timed intercourse or an IUI. But if either the fallopian tubes are damaged, they have a very low ovarian reserve, or there's male factor, then I do recommend IVF with PGS testing. And so to me, those are the main considerations: are what are your fertility goals and what's affected. But certainly I would always recommend removing those large endometriomas first, because I do think the environmental milieu of the inflammation can be harmful, not only towards an IVF cycle when you're trying to stimulate, but also when you're undergoing a frozen embryo transfer, because we know inflammation can lower implantation.
Thank you, Dr. Bake. The next question is for Dr. Amy, and the question is, patient says that she's 28 years of age. She has had 4 failed IVF, and she is fine. All of her tests are normal. Her husband's tests are normal, but they are suspicious of her having endometriosis. But patient says her IVF physician believes endometriosis doesn't interfere with her getting pregnant, and she wants to know why. And what do you think?
I mean, as a 28-year-old, obviously I'm not 28, but it's so frustrating to not be heard, because young people often are told, don't worry, you're young, it'll happen. So the fact that this 28-year-old has already gone through 4 IVF attempts that haven't been successful, I imagine she is at her wit's end. So what I would say is, listen to your gut, or listen to your uterus. So if you feel like you are having a problem with endometriosis, do some diagnostic tests to see if that's going on. We've mentioned a test called the Receptiva test, so that's one thing that you can do. But I would also just kind of take a step back, and just like Dr. Bake was mentioning, get your AMH tested again, do a semen analysis with a DNA fragmentation test, look at the embryo quality, consider PGT, go through those steps that I mentioned, those 4 steps, the diagnosis, and see what the possible diagnosis are for you. Why are you doing IVF in the first place? And then try to fix everything that you can possibly fix that's in your control. But I think sometimes when you've gone through IVF that doesn't work, it could be the embryo quality. Try and get as much transparency and information from your doctor as possible. Look at the embryos. Sometimes things are sugar-coated and your doctor says things like, oh, your embryos are just fine. It should work eventually, but the reality is that your embryos are really low quality and you weren't given that information. So ask about that quality of your embryos, what the percentage rate of implantation should be for each embryo. Think about doing PGTA. And in cases like this, in young people, sometimes patients are told you don't need PGTA because you're so young, but this might be a situation where it would be extremely beneficial. And if I have a patient who's this young and who chooses not to do it, I will now always do a chromosome analysis on both partners to make sure that neither one of them have a structural rearrangement in their DNA. And it could be that the embryos are abnormal and the efficiency of IVF would be a lot lower, and that might be something that someone who's that young would want to know before they keep going through more cycles. But listen to your uterus.
Thank you very much, Dr. Amy. The next question is for Dr. Tolabian, and the question is that is it possible to get pregnant if endometriosis has spread to your ovaries?
Okay, great question. So yes, absolutely. So endometriosis, when present, most often is on the ovary. It may not be a clear-cut endometrioma seen on an ultrasound, but if that woman has surgery, there's probably some small lesions. So it's, you know, if there is endometriosis present, there's a high likelihood that it also is somehow on the ovaries or impacting the ovaries. And so, you know, we spoke a little bit, Dr. Beck, you know, very nicely explained a case of, you know, a patient with large endometriomas on their ovaries and what the approach would be. But again, if there is endometriosis on the ovaries, I think it just depends on the extent and whether or not surgery might be recommended prior to doing other forms of treatment. But of course, you know, the whole thing that we've all talked about, you know, this patient should be evaluated, have an AMH hormone. You know, for those of you not familiar with that, it's a marker for your egg quantity. So that would be, you know, very helpful to have. And again, if the endometriosis looks very significant and is occupying a bulk of the ovaries, you may want to, you know, definitely meet with an endometriosis specialist, a surgeon, and discuss removing that prior to potentially trying, you know, actively to conceive or to proceed with IVF. But absolutely, you know, the assumption is that if you have endometriosis, it probably is somehow somewhere on your ovaries and impacting those ovaries. And absolutely, you can still get pregnant, sometimes naturally, you know, unassisted, sometimes assisted.
Thank you very much, Dr. Talebian. The next question is for Dr. Amy, and the question is, I am 43 years of age, and I have had many IVFs, and I have had only chemical pregnancy. My embryos are all good. This is what she said. Could I have endometriosis, and is it possible, and can surgery help me?
Great question, and I would say that the majority of my practice is women who are over the age of 40, and a large majority are even over the age of 42. So this is something that I personally see a lot, and it's a very frustrating problem because you feel really healthy and you feel really good and you're making these beautiful blastocysts, but at the end of the day, they're just not working. So I think talking about embryo viability is really important. What the likelihood that each embryo will be normal at the age of 43 is helpful going into it. I review something called the IVF attrition pyramid with each of my patients, and I give them a very clear idea as to what the expectations from treatment should be at their age. So if an embryo has normal chromosomes in this 43-year-old and they're still resulting in chemical pregnancies, certainly we want to do implantation testing. The tests we talked about already, like the Receptiva test and the ERA test, can certainly be helpful. And also look above the uterine lining, see if potentially these are recurrent ectopics that are happening. Is there fluid in the tubes? I mean, these are the standard tests that OBGYNs will do. Fertility doctors as well, if a patient has recurrent biochemicals, even outside of IVF. And sometimes doing recurrent pregnancy loss testing could be helpful in this situation, especially if the embryos are normal. For example, looking at an anatomic defect in the uterus, which most of us will do ahead of a transfer, looking for an autoimmune issue, a thrombophilia. Those are just some of the standard things that we would do as part of our workup in a patient who's 43 who has good embryos and is having recurrent biochemicals. So make sure the tubes are open, see if the chromosomes of the embryo are normal, and then look really carefully at the lining. And if you have just one chance to have a healthy pregnancy and you're going through something like this at the age of 43 and these are your own eggs, at this point, sometimes you might want to consider a gestational carrier. Those are the things that docs like us would bring up with our patients.
Thank you very much, Dr. Amy. The next question is for Dr. Talebian. The patient is 25 years of age. At the age of 21, she undergoes surgery for severe endometriosis, extensive, and she has tried to get pregnant since successful. And she, due to financial limitations and lack of insurance, and also because of her own health, she doesn't want to undergo any kind of hormonal treatment or IVF or ovarian stimulation. She wants to know if there is any other options for her. Should she try other ways to, is there anything else could be done to help her get pregnant?
So let me just make sure that I'm unmuted. Okay, so good. Oops, sorry, I cut up my video, sorry. So this is a tough case. So, you know, a 21-year-old who underwent extensive surgery for endometriosis, who's now 25, who is having difficulty conceiving and is very concerned about hormonal therapy. Again, most certainly, while she may be reluctant to undergo treatment, she should absolutely meet, with a reproductive endocrinologist, undergo all the various testing, including tubal assessment, ovarian reserve testing, semen analysis, do as much testing as possible. And then depending on the results, talk about options. But, as Western trained physicians, most of our treatment to help patients get pregnant does involve some sort of ovarian stimulation therapy, inseminations in an office, or IVF. There are alternative options if she's very reluctant to go the Western route. There are, Eastern adjuncts and anti-inflammatory diets and anti-inflammatory acupuncture and herbal treatment. But at the end of the day, given her history of extensive endometriosis, she very likely, will need something like in vitro, if her tubes are no longer functioning. And, given her age, even if she has a very low AMH or low ovarian reserve, her egg quality still should be very strong. And I would say it's kind of now's the time to do the treatment. And I think that there are also a lot of myths and misconceptions about IVF treatment and what it could do on the body and what subsequent impact it may have on the ovaries. So I think this is the exact patient, while she has, kind of a lot of preconceived ideas about what she may or may not want, I think she needs really, really good counseling with a physician that she feels comfortable speaking to and safe, and then making an informed decision about what kind of treatment is best.
Thank you very much, Dr. Shiva Talabian. The next question is for Dr. Kelly Bake in LA. And the question is, patient says she is very symptomatic. She has a lot of pain and problems with endometriosis already. And how should she go about how to add an extra burden of receiving so many fertility medication? How do you deal with that?
Right. So with these patients, I usually like to get an assessment of how conservative I can be with their treatment. So it's important to know how old they are, because if they're younger, we can be a little bit more conservative with proceeding with treatment or not. I'd like to check the AMH also. It's not predictive of live birth, but it does tell us what our ovarian reserve is. And as Dr. Talabian and everyone else has mentioned already, is to make sure that the semen analysis, HSG, are complete normal, as well as the ultrasound, so that we know, could conception happen naturally without IVF, or will we need IVF? Following that, I have a holistic approach where I work with a real network of people to try to address this. I work with mind-body specialists as well as acupuncturists who specialize in fertility. And I think in the right hands, they can oftentimes try to help. There's pelvic floor therapists who specialize in endometriosis. And believe it or not, women who have endometriosis, and even if it's undiagnosed or misdiagnosed, because 1 in 10 women do have endometriosis, what I found is that by the pelvic floor therapy in the right hands can help increase blood flow to the ovaries, so you actually have more ovarian activity. It can help alleviate some of the discomfort. And finally, if they're still symptomatic, then I would definitely have them consider having surgery. If they have a good ovarian reserve, then post-surgery, I would want to make sure that we try to alleviate their pain and their symptoms first. And following that, I would monitor them in a natural cycle to ensure that they're ovulating properly. Simply because you're ovulating, it doesn't mean you're ovulating in a good size or that you're not ovulating a post-mature egg. You want to make sure that, conception has been optimized, because the longer you wait, when there's a higher estrogen, the endometriosis is a lifelong entity where it will come back. So the goal would be to try to help them conceive sooner than later, to use minimal stimulation if possible. And so that would be my initial approach. But I found that when you have a holistic team, holistic with the WH, when you have a holistic team approach and you have a real support network for patients with this who are symptomatic, they tend to do pretty well with surgery. And oftentimes, once they're pregnant, it's amazing how a lot of their symptoms are relieved, because they're, I don't know if this is the stretching of the uterus, Dr. Najat, you probably know this better, or because they're not ovulating anymore, but people tend to feel much relief once they're pregnant.
Thank you very much, Dr. Amy, Dr. Kelly Bake. The next question is for Dr. Amy, and the question is, patient says she is 34 years of age. She has had many failed IVFs. Her husband, all of her husband tests are good, but she has bad eggs, and also the embryos that are produced are not good. So, and she is asymptomatic. She wants to know if she has, is it possible that she might have endometriosis? And if so, could surgery possibly help her?
That's a great question. Yeah, I mean, as far as low egg viability and embryo viability, it's also the same causes as I stated before: age, genetics, and environment. So the environment could be endometriosis affecting egg quality. And a woman who doesn't necessarily have symptoms and doesn't have obvious signs like endometriosis, endometriomas on the ovaries, it's less likely that endometriosis is causing her poor egg quality, but it's definitely worth looking into. One of the things that I sometimes consider doing in a case like this is potentially, if she needs to go through more IVF, is doing a Receptiva test during her IVF cycle. So either doing it at the time of the egg retrieval or a week later. This information can potentially provide her some diagnostic clues as to what's going on. But some other things, just unrelated to the question, a woman who's 34 could consider doing, who's had multiple failed cycles, is potentially consider other protocols, medications to help with egg quality like HGH. Ask your doctor about that. And then talk to your doctor about what their experience is in cases like yours, as far as what your chances are of getting pregnant. What is the, experience of the lab? Do they have the newest technology? Do they have the right certifications? Because maybe it might be time to find another center that might be more suitable for you and your case.
Thank you very much, Dr. Amy. Next question is for Dr. Talebian. The patient has a question. Unfortunately, she hasn't said her age, but Dr. Talebian, perhaps she could address it if the patient is around 30 years of age or if patient is around 40 years of age. So let's say if patient is around 30 years of age and she has had recently a miscarriage, and since then, about 11 months ago, she has been trying to get pregnant, and she hasn't been successful. And she also has a very painful period. She doesn't want to have IUI or IVF. What are her options? If the patient is 30 or if the patient is 40, because she has not, how old she is, we extreme that these two ages, please.
Right. So exactly. So, again, very, very common scenario. A 30-year-old starts trying, gets pregnant maybe pretty quickly, but then has a miscarriage, and now is trying, for months without success. So, again, doesn't want to do treatment, but you should still speak to a reproductive endocrinologist at this point. You've been trying for over a year, you're under 35, you haven't had a successful pregnancy. So first is, okay, what are the various causes of miscarriage? Why could that miscarriage have happened? Yes, it could sometimes just be bad luck, and young women also have miscarriages as well, for sure. But again, this is a patient who needs a full workup, ovarian reserve testing, a transvaginal ultrasound, an HSG, semen analysis. If she hasn't had preconception genetic screening, her and her partner should undergo that. But again, it depends on what any of the testing shows. Many times, 20% of the time, the testing is all quote unquote normal. So it's now technically unexplained infertility, and she's 30 years old. So what I always explain is, okay, your options are to, maybe take an oral medication to augment your ovulation, something like Clomid or Letrozole, track the ovulation, do an IUI. So in a case of unexplained infertility, what's the purpose of something like Clomid and IUI? I say, well, it's trying to target something that's going on that we're not able to pinpoint. So it's just trying to, make your timing more accurate, bring egg and sperm closer together. If that doesn't work after about 3 trials, we do usually progress to IVF. However, if the patient says, okay, I've listened to everything, I have unexplained infertility, there's no major red flags, I don't want to do this treatment, what should I do? I say, okay, again, you can try the Eastern route, acupuncture, herbal treatment, track your cycles. But I always explain the more and more months that go on that you're not successfully conceiving, the bigger and the more real the issue is. And oftentimes we say IVF is both therapeutic and diagnostic. It's therapeutic in the sense that it's dramatically increasing your odds of a pregnancy, and it's diagnostic in the sense that it gives us information as to what's going on with your embryos. Now jump ahead to that same patient who's 40, and it's a little bit the discussion becomes a little more sort of serious in the sense of, okay, all the same testing for that 40-year-old, it's the same battery of tests. It's just that we know that egg quality at 40 is very different than it is at 30. And therefore she really may not have the luxury of time. That 30-year-old can try for a whole other year unassisted. And if her AMH was good and her day 3 FSH was normal, she may not be dramatically lowering her odds if she doesn't rush right over to treatment. But a 40-year-old, unfortunately, the average 40-year-old doesn't have that luxury of time. And so she just needs to really be adequately counseled regarding what all her testing shows, what the implications are, what her chances are of trying unassisted, what her chances are of trying with, therapy like IUI or IVF. What I always say to these patients is my job is to give you as much information as possible so that you can make the best decision now and not look back at this time with regret. Because we've all had it where they come to our offices 3-4 years later at 43, 44, 45 and say, I wish at 40 I had done, IVF or egg freezing. And so, again, our job as a fertility doctor is to give these patients all the tools they need to make the right decisions in real time, and that we don't want them looking back with regret.
Thank you very much, Dr. Talebian. The next question is for Dr. Bake, and patient says she has been diagnosed with endometriosis and currently trying to conceive. How long should I try before looking to specialists for assistance? What can specialists do for me? Additionally, is there anything I can do, like lifestyle changes, diet, etc., to help to increase my chances?
Sure. So I think this is really important, and Dr. Talebian and Dr. Amy both highlighted it, is to know, first of all, how old is this patient who was diagnosed with endometriosis. So if you already know you have endometriosis, that we know that potentially they may have a lower ovarian reserve than other women their age. Even if they've never had chlamydia or gonorrhea or any pelvic surgery, they may have tubal disease. So I would want to have them consider getting a fertility assessment early on, even before they start trying, to ensure that they're not wasting their time. Since we know that endometriosis is a progressive disease that's lifelong until you go into menopause, you may want to know ahead of time, what is your ovarian reserve? Is the semen analysis normal? Are your fallopian tubes open so that pregnancy can actually occur naturally? So when you're trying, if it turns out that your tubes are blocked or the semen analysis is really compromised, you know that you haven't wasted your time trying to conceive, because I can't tell you how many times I've seen women to find out after they've been trying only to discover that their tubes were blocked or the sperm is really compromised. And so that's something you may consider. And again, even if the sperm's compromised, because the life cycle of sperm is 2 to 3 months, it's something that we can help address and try to improve once we uncover what the issue is. The other thing is about the lifestyle. There are a lot of things that can affect, which we can try to do to optimize success. So if the tubes are pain and the hormone panel is normal and the semen analysis is normal, I really go through all the lifestyle issues. We know sleep is critical. Sleep is important because our pituitary pulsatility occurs at night. So women who don't sleep well, change time zones often, are under a lot of stress, may not ovulate properly. Whenever I have a concern that someone may not be ovulating properly, I will monitor them in a natural cycle to ensure that. I also want to make sure, what is their diet? Are they doing something like a low calorie restrictive diet, keto or Atkins, where I've seen that you may not ovulate properly or you can diminish your ovarian activity? What is their exercise like? Are they just doing normal cardio? Are they swimming? Or are they doing high intensity workouts where you can really shut your ovarian activity down? We know what I could never tell someone don't be stressed out, because I think that can cause more stress. But I'd also want to look at what is their overall well-being and their stress level. Finally, I want to know socially, are they smoking a lot of cigarettes, pot, or vaping? Unlike men who are always making new sperm, we're born with our eggs, and we know that smoking, pot, vaping can actually diminish our ovarian activity and our reserve and quality of our eggs as well. Do they have a history of an eating disorder? And do they have any chronic medical illnesses? If you do have a chronic medical illness, it's really important to consider trying to get that under your control. If you have a medical illness that has an autoimmune component, for example, like a thyroid disease with autoimmune antibodies, we know that that can age your ovaries more quickly. And that may change how long you'll try naturally if everything else is normal. And finally, age is the #1 predictor of live birth. So if you're younger, you may consider trying on your own naturally for like 6 months. And if you're older, you may not try on your own at all, or consider trying on your own for about 3 months.
Thank you very much, Dr. Bake. The next question is for Dr. Azinejad. And the question says, patient says, my mom had endometriosis. She also, patient has had endometriosis herself, stage 4, which affected her ability to get pregnant. Her doctors took good care of her, and through IVF, she got pregnant with frozen embryo transfer. Her baby now is 7 months old. Her question is, what are her chances that her daughter might also have endometriosis? And she has heard that some physicians tell younger women to go ahead and get pregnant early because her best chance is when they are younger to get pregnant. And but she said this is not a good solution. What are her options? When should she consider freezing the eggs of her daughter?
Okay, I think in this case, the most important thing is educating your daughter. It is important to be aware of the early signs of endometriosis since she's only 7 months old. Being aware of the early signs of endometriosis is very important. And I think to be cognizant of the fact that the endometriosis could affect her fertility in the future, those are the most important thing to me, and that I would say she should be aware of. Also, as we said before, there is if she has a family history of endometriosis, if she has endometriosis and her mom has endometriosis, the likelihood of her daughter having endometriosis is high. Hopefully, if early on she's educated and she has those symptoms, she should seek professional help early on. That could help. Hopefully by the time she is in the reproductive age, there are more treatments and more, hopefully there's even possibility of a cure for endometriosis, but freezing her eggs at the appropriate time, that most certainly is an option. I think it's hard to say they should have children at early age because she has hopefully about 18 to 20 years of ahead of her, and things could change. So I think educating her is the most important thing, and making her aware of the signs and signs of endometriosis, to me, would be the appropriate thing to do. And most certainly if she is at the age to preserve her eggs.
Thank you very much, Dr. Azi. So the next question is for Dr. Amy, and it's interesting. This patient has been a patient of mine, and her question is, I am 35 years old medical student who has had surgery with Dr. Kamran-Najat 5 years ago for advanced endometriosis. My husband and I live in different states and recently got pregnant, but then had a miscarriage. There was no evidence of intrauterine pregnancy or ectopic pregnancy. On ultrasound and her beta HCG goes from 900 to 3 within 3 weeks. She's planning to check her AMH and do an HSG as well. She wants to know what next steps are recommended for her.
Excellent. So this is a 35-year-old medical student who has a husband that lives out of state with the diagnosis of severe endometriosis. And at that age, I would strongly suggest freezing eggs, embryos, or both. So embryo freezing will give her at least help her secure future options for baby number 2. It doesn't mean that she needs to use the embryos for baby number 1, but that's something that I would highly recommend. Any woman who is over the age of 32 who already doesn't have 2 or at least 1 child and wants a chance of 2, I highly recommend, if you're partnered, freezing embryos. If you're 37, for example, and you already have 1 baby, consider freezing embryos, you know? So we don't want to take this woman's age for granted, and the diagnosis of endometriosis makes her egg quality a little bit lower and potentially could affect the implantation rate as well. And then as she's preparing for transfer, when she's going to get pregnant, if she does choose to use those embryos, consider, you know, treatments for endometriosis to prevent the progression of endometriosis, especially because we know that it can affect the walls of the uterus. She may have adenomyosis at some point in the future if she doesn't already, and that could be what's causing the implantation issues that she heartbreakingly just went through. So my heart goes out to her, and I hope that she is successful. And I would just tell her to do the work of freezing embryos so that hopefully she has the chance of having a healthy baby now, and then in 2 or 3 years, she can have a healthy baby then.
Thank you very much, Dr. Amy. And we have time for perhaps one more question to get everybody on time, and some announcements that I would make at the end of the this question from Dr. Talebian. And once again, I want to thank you. And this last question, patient says she has been diagnosed with endometriosis at the age of 27. Her AMH has been 0.85 and AFC 13. She had regular periods until she was diagnosed with a 9-centimeter endometrioma, and that was a surprise to her. Her mother history has had early menopause around the age of 40. She is not actively trying to get pregnant, but she has frozen some eggs and she has gotten only 2 mature eggs that are well below her average age. She has had 14 days of menopause and Gonal-F at a very high dosage, has been triggered with Lupra. She wants to know which protocols and triggers do you like to use in endo patients with low AMH for her age group. How many eggs should I try to bank given the potential for low quality as a result of her surgery perhaps? Is it recommended 14 eggs given her age is still she should have 14 eggs freezing? Additionally, she wants to know how many eggs freezing are too many. My endo doctor doesn't want me off the birth control pill, but I am worried it is too suppressive if I want to have another round soon. Dr. Talabia?
Okay, so not a straightforward case. So she's in her late 20s, known endometriosis with a very low AMH. So if I understand correctly, though, her AMH is 0.85 and her follicle count was pretty decent. I think you said 13. So, you know, it's interesting because she did a cycle and she only got 2 eggs. Based on her AFC and AMH, I would have predicted that she would make more. And it sounds like she was on a max dose protocol. And while it's almost counterintuitive, sometimes these patients may do better with slightly lower dosages. Sometimes you can use something like letrozole or Femara in conjunction with something like Gonal-F and Menopur as well for the stimulation. So, you know, there's a handful of different protocols out there. I always say that IVF is both, it's as much an art as it is a science. And so when you try one protocol and you don't have the desired outcome, you may really want to try to switch things up. And sometimes, again, it sounds counterintuitive, but sometimes we go less aggressive with the gonadotropins and add in some oral agents. And sometimes those patients end up doing better. You know, in an ideal world, in your late 20s, given the history, yes, the more eggs she has frozen, the more insurance policy moving forward. In terms of how many is too many, there's no data per se that multiple rounds of the treatment can increase, your cancer risk. Obviously, you want to be vigilant, do breast exams, make sure if there's a strong family of breast cancer, that's a different story. But in the average, woman who doesn't have that risk factor, we don't have a limit per se, but again, also, we don't need to be max dose, full dose each month that she tries this. So, there are ways to sort of tweak the protocol, maybe a more what we call milder / gentle protocol that she may actually even do better with. And, I think in an ideal world, if she is able to have about, 15 eggs aside, that's great. But again, these women need to just be counseled that there's only so much, there's so much we can do now to protect ourselves for the future. And they also need to have a frank conversation with this patient about, down the road when maybe, come to use those eggs, or if you're trying naturally or whatever it might be, but down the road, if none of these eggs are viable, what are your other options? And I think it's important to, discuss, even though she may be so young, they need to understand there's no guarantees that these eggs may work down the road. There is something called donor egg. There's adoption, a lot of other options to become a parent. But again, it's all about the counseling. And each month you can kind of tweak the protocol and just try to see if there are better ways, to optimize the outcome.
Thank you very much, Dr. Talibian. This has been the most fantastic and fascinating virtual lectures and presentations by the very esteemed colleagues, Dr. Beig, Dr. Evazadeh, Dr. Talibian, the co-founders of the Worldwide EndoMarch, Dr. Spar Nejad, Dr. Sina Nejad, Dr. Azadeh Nejad. Also, I would like to thank significantly we have had 3 of our fellows, Dr. Asiai, Dr. Roman, and Dr. Rambatla, that they have been fielding the questions that they have been coming live, answering people online. Also, I would like to thank the co-founder of the Worldwide EndoMarch for all of her efforts, Dr. Barbara Page, also Tiffany, Zoe, and Elisa for all of their efforts. Thank you very much. Please look at the barcode behind me. You can use that barcode for some more questions. Also, the endometriosis can be diagnosed. There is a Nejad endometriosis advisor that was developed for Worldwide EndoMarch, and it is completely free. It is a guide to help those of you who can try to see if you have endometriosis or not. It is highly accurate. And the next meeting would be about bowel endometriosis and pain, what to do, when, what not to do, the role of surgery, and what kind of surgery. I'd like to thank all the panel again, and also especially all of you around the world who have been the loyal followers of the Worldwide EndoMarch, and for your support to help yourself. Thank you very much, and wishing you a fantastic weekend. Bye-bye.
Bye-bye, everybody.
Hello, my name is Dr. Shruti Agarwal. I was a fellow with Dr. Nejad from 2020 to 2022. I finished my residency in Florida and then decided that I wanted to pursue a career in REI, or reproductive endocrinology and infertility. I wanted more education on reproductive surgery, diagnosing endometriosis, seeing infertility patients who had undiagnosed endometriosis, and I was fortunate enough to be able to be granted a position with Dr. Nejad. During my 2 years of fellowship with him, we saw several patients with chronic pelvic pain who had never been diagnosed with endometriosis or patients who had been diagnosed with endometriosis, had undergone several surgeries for it, but were still dealing with the pain associated with it. We also saw a lot of infertility patients who came to us either through an infertility specialist or by themselves for a diagnosis for why they were unable to get pregnant despite going through IVF treatments, and we were able to diagnose and treat endometriosis for these infertility patients who then went on to have successful pregnancies. During my fellowship with Dr. Nishat, I saw many complex cases that as a general OBGYN, we never learn in residency or training. Cases that we don't see in surgery that we would have never recognized as endometriosis if I had not done this fellowship with Dr. Nishat. Time and time again, we would have pathology specimens returned to us, which would prove to us that it was indeed endometriosis, although at the time of surgery, when Dr. Nishat asked us, we would always deny that we would not be able to see any endometriosis based on our OBGYN training in general. Since my fellowship with him, I have been practicing as a general OBGYN, and I feel like I am better equipped to diagnose and medically treat endometriosis, and also to help my fellow surgeons identify endometriosis better during surgery as well. During my fellowship with Dr. Nishat, I was able to publish several papers with him. We looked at the time to conceive following endometriosis surgery in infertility patients. We also looked at the number of patients who were successfully able to undergo and have a successful pregnancy after endometriosis surgery. We also worked on the Nishat Endometriosis Advisor app, which will help patients without access to an endometriosis specialist in their area to see if they are at a higher risk for endometriosis. I'm currently awaiting a fellowship position for REI in Orlando, Florida, and I'm very excited to bring my knowledge from Dr. Nishat's fellowship to the REI fellowship. I am hoping to be able to educate my co-fellows and my mentors about what I have learned with Dr. Nishat regarding infertility, pelvic pain, and endometriosis, to be able to diagnose and treat complex cases of endometriosis and infertility patients, and hopefully help the population in Orlando, Florida. I think with EndoMarch, we are able to spread so much knowledge and information about endometriosis to patients around the world who are dealing with chronic pelvic pain or infertility, who have been unable to get a proper diagnosis, to be able to be a voice for these patients and to be able to hear from our patients giving positive reinforcement and hearing their stories of how much their life has changed after meeting Dr. Nishat and undergoing surgery with him. I'm really hoping to make a difference to the world regarding endometriosis, and I'm very excited about what the future holds. Thank you so much.
once again, I would like to thank all of you, all the viewers, all the patients with endometriosis and their families, their communities, all the advocates around the world, all of you that you are doing everything to help change the dynasty of endometriosis. You have been wonderful. Together, we are going to conquer this disease. And we appreciate all of your devotion. Also, I would like to thank immensely from every one of the participants that they participated in this program. And I would like to specifically thank people who have put this program together, and including Zoe Pennington, especially, and Barbara Page, and Mary Aiken, who has recently joined us, and Rana, Roya, Gerard, Elif, Marianne, Eden. There are so many of you who have been very helpful, and we thank you for everything that you do. And I'm sorry if I'm forgetting anybody, I'm sure I do, but this is a large number of people who are continuously trying to move this mission forward. Also, I would like to thank unwavering commitment and support of my brothers and co-founders of the EndoMarch, Drs. Far Nejat and Dr. Sina Nejat, and also my niece, Dr. Azad Nejat. Thank you very much. We appreciate it, and forward we go.